क्योंकि लाइट पे डायरेक्ट नहीं बांध के रखी आ गई। मेरी वाइफ की तस्वीर बनाई थी मैडम थी ना, उसका खुश है डायरेक्ट लाइट से मत पड़ने दीजिएगा।
हेलो। अच्छा, ओके। ठीक है। Good afternoon, everyone, and thanks for coming this CME. I think this is first CME under the aegis of SOGO and with collaboration with RGCIRC. And actually, it is because it is a very long weekend, so it was very hard time for me to get all the faculties here because most of them they wanted to be on Zoom. But I thanks all of you who are physical here. So actually, this is a very core group of Uro oncologists and those who are associated with the radiation part or medical part, medical oncology part of the Uro urological malignancies. So this is a very focused meeting, and we are having our annual conference also. So we'll be having, I think, our annual conference in Calcutta just after two months of this. So this is first sort of midterm CME of this SOGO. So I welcome all of you. So I would just invite Suchita to just start the proceeding of the program.
A warm welcome to all the delegates. So we have divided the sessions into organ-wise talks, and we'll kickstart with the prostate cancer sessions. And for that, I would like to call on stage the chairpersons, Dr. Jagdish Kulkarni, Dr. Amit Goel, and Dr. Praveen Alawat. So you will find that those mics are activated when you talk. If one of you could kindly... We would also like to invite Dr. Ravi Mohan on stage. I'll request one of the chairpersons to please call and introduce the first speaker.
There? Oh, yeah. Hello. Okay, that sounds good. No. Okay, okay. Good afternoon. Just to give you, for those who don't know what is SOGO, that SOGO concept was conceived in February 2020, and then the corona struck. So we have now entered 5th year of SOGO. We have survived through corona, both virtually as well as physically. And the genesis of this workshop or CMU was, I was talking to Dr. Rawal, who is actually the key person of the whole SOGO, that we must do before annual conference, which occurs every year in August. We must do something physical, because we have been doing virtual meetings for, practically every monthly, weekly, or something like that. This time we need to, and he said the basket will be only on a precision medicine, which includes all that. So we are presenting this basket to all these learned guys, and to start with the prostate, which is the most common problem which we urologists and uro-oncologists face. I have none other than Dr. Sanjay Adla, who will speak on fusion transperineal biopsy. Dr. Sanjay Adla is a uro-oncologist of repute over 2 decades, and he's in Hyderabad. And his lecture will speak to his credentials. Thank you very much.
Thank you very much. It's always good to be in Delhi, and thank you very much for the invitation. And there is always the pleasure of being the opening batsman. So let's see if I can keep you awake for the next 15 minutes. Presentation, please.
White ball. It's a white ball.
Sorry.
White ball.
No, trial ball. They call it trial ball. Trial ball. This is the red ball.
Last one in the
Last one.
Oh, I can do.
Okay.
Okay. So thank you. So this is what was given to me. And when I started the presentation, I thought I would talk about these things, about freehand and stabilized version of transperineal prostate biopsy. Then for the last 2 days, I was doing this in Mumbai about getting trained in development of guidelines. It was absolutely intense. So at the end of 2 days, we were asked to quantify the quality of NCCN guidelines. And what we found was it was actually quite poor. We were expecting that they would score around 70 to 80%. NCCN guidelines were scoring around 30%. So this is where I started off. So rather than saying what, I thought, how did we end up where we are? So I would look at the process of it rather than the technique of it. hopefully by the end, you'll be able to understand. So these are the guidelines. So I want to work out how did we end up with these guidelines at the end of 2023. And I've got a brief about the technique of doing the transperineal biopsy. If anybody among the trainees, if you haven't read this paper, Landmarks in the Evolution of Prostate. There is a landmarks in radical prostatectomy and everything, but landmarks in the prostate biopsy. So there is the reason why it is important is prostate biopsy is almost just a bit more than 100-year-old. Started off in 1922. Then around 63, we had transrectal ultrasound scan used to see where the prostate was. And then 82, the first MRI of the prostate was done. And then 89, sextant trust biopsy. The reason why I've highlighted that was few things. One is before this, everything was transperineal. Quite a few of the biopsy technique was transperineal. They were even trying to do open transperineal, but majority of the approach was transperineal. Secondly, everything was a bit focused. What I mean by focused is there was some sort of an image guidance. And when you look at the last one that I said there, which is sextant trust guided biopsy. So the transrectal ultrasound scan was guiding where to take it, but we knew we were only going to take 6 biopsies. And this was different. Okay, so this one was the landmark paper from 1989, which made us start doing the sextant biopsy. And what it did was quite simple. They took 6 biopsies, and they also took biopsies for hypoechoic lesions in the prostate. And what they found was, and this is where the... This is where, I think the Zoom needs to be muted.
Zoom.
Yes. So this, quite a few of us are aware of this image of the sextant biopsy. And what they said is actually sextant was better than doing a transrectal ultrasound guided biopsy of the hypoechoic lesion. So past 1989, we started doing sextant biopsies. We were looking at the prostate, but we were not looking at the architecture of the prostate. We were just looking at the prostate. Then this word came in, random systematic. It's an oxymoron. Either it is random or it's systematic. It can't be random systematic, but we have accepted it. Then the next one came almost 10 years down the line, saying that doing 12 cores is better compared to 6. So 12 cores is better than 6. There was almost a 10% increase in the overall diagnosis rate. And the second thing that came up was the larger the volume of the prostate, the better, the higher the number of biopsies. Sorry, the last line went off. It was more than 50 cc of the prostate. So the larger the volume of the prostate, the more number of biopsies that you had to take. Then the next one was you kept on increasing the number of biopsies. None of these were actually seeing where the biopsies were being taken. We were just taking more biopsies without even looking at where the biopsies were being taken. So this was 23 biopsies were being taken in patients who have had previous negative biopsy and still saying that we are picking up cancers. So if you see there, sextant biopsy started in 1989 until MRI fusion in 2015. So 26 years we were doing random or systematic or blind biopsies. We were just looking at the prostate and then saying we are taking the biopsies. It's like saying that, oh, there is a renal tumor, but I'll just take biopsies from the whole of the kidney. That's what we were doing. So now we come to the guidelines. I just wanted to reach up to 23 and then say, where do we have the evidence for this one? So the first one was, which we already have evidence. This is from 1998, when performing systematic only biopsies, do 12 course of biopsies. This is the 1998 STEMI paper. Then the other important one, perform MRI scan before the biopsy. Okay, what is the quality of the evidence? This was a landmark paper, the PROMISE trial. It was a trial, but actually it wasn't comparing to. What I mean by that is, so these were 740 patients who had an MP-MRI done. Okay, who had an MP-MRI done, and the comparator was a transperineal prostate biopsy. So transperineal was a comparator, and then half cohort had MP-MRI and half cohort had standard trust-guided biopsy of the prostate. And what they found was So all the patients had it. What they wanted to find out was MPMRI, does it pick up significant cancer? And how often does it pick up the cancer? So when you look at it, sensitivity was 93%. So if there was a significant cancer was picked up from the transperineal almost template biopsy. There were 70 codes that were taken. So it was sensitive and the negative predictive value. What that means is when the MRI is normal, the chance of you missing significant cancer was only 11%. So we were getting, and this was the first time after 26 years wherein we tried something else to see how does the prostate look. The second part of it was the precision study. So that one did not have a MRI guided biopsy. This one had MRI guided biopsy. So this one had two cohorts. One was a standard cohort and the other one was a MPMRI guided biopsy cohort. And what it showed was, if you look at here, MRI group, 30% did not need prostate biopsy. Significant cancer was higher. Insignificant cancer was lower. Okay, so that's the reason the precision trial was important. The first one was the promise. The second one is the precision. So now we know the evidence is good. MRI to be done before the prostate biopsy. The second part of the sentence was, when MRI is positive, do perform targeted biopsy only. Only. That's where the key is. Should we be only be doing targeted only, or should we still be doing systematic biopsies? All of us tend to do targeted as well as systematic. But if you look at the guidelines, it says only. So I just wanted to see what is the evidence. So I had to go through all the references that they gave just to see what they were talking about. Actually, that only is they shouldn't have had only there. So this one is patients who are coming in for prostate biopsy. What they did was they looked at the targeted biopsy as well as systematic biopsy, and they wanted to see what is the additional value you get by doing the standard systematic biopsy. So added value of the systematic biopsy would pick up 5% more of significant cancer. Okay, so if you do a targeted biopsy as well as a systematic biopsy, the biopsy cancer pickup of significant cancer increases by around 5% or 6%. The same one in a larger cohort. This is much better done study, almost 1,300 patients. So if you see their systematic, targeted, and combined, what you see is that as these are the grade groups, okay, the percentage of significant cancer increases as you include the targeted one. And what they did more interesting was compared it to the radical prostatectomy. So these patients underwent the TRUS biopsy, then the radical prostatectomy. And what they looked at was what percentage of them do end up having an upgradation. So this is the overall upgradation to grade group 2, upgradation to grade group 3. So if you just do systematic, 40% of them are upgraded. If you just do targeted, around 31% of them are upgraded. If you just do both targeted and systematic, the level of upgradation is only 15%. So as of now, the best one is don't just do only, do targeted as well as systematic biopsies in de novo or biopsy naive patients. That's the first one. So though it said only, I don't think only is right there. Next one, what happens in repeat biopsy? Patient has undergone a systemic biopsy, comes to me with an MRI scan that shows an abnormality. Should I be doing only targeted biopsy or should I repeat the systematic biopsy? Okay. There again, this one was in the repeat biopsy setting. And what it showed is when you do repeat systematic biopsy along with the targeted biopsy, actually the increase in the yield with respect to significant cancer is small, only 1.3%. So when you do a repeat biopsy, if the previous one was a standard 12-core biopsy, you don't need to repeat the standard biopsy. You can just get away doing a targeted biopsy. Okay, so I've answered the first one, then goes to the MRI. So we have done an MRI scan. There is an abnormality. How do I do the biopsy? Should I be doing a cognitive fusion? Should I be doing a real-time fusion, which is what I'm supposed to be talking? And then the third one is the in-bore one. Which one is better? And what it says is there isn't any difference. All of them seem to be the same. let's see what is the evidence. So this one was real-time fusion versus cognitive fusion versus in-bore MRI biopsies. And when you look at the detection of PCA, the numbers are small, but majority of the studies in this sector are like that. The overall cancer pickup rate seems to be the same. Detection of cancer, clinically significant cancer is the same. As long as you are doing some sort of a fusion, it seems to be the same thing. Okay. Now, once you have found a lesion and you want to do a real-time fusion, is it better to do a transrectal fusion or a transperineal fusion? This study was published just last month in the European Urology, the PERFECT trial. And again, they looked at the same transperineal versus transrectal real-time fusion biopsy to see if it makes any difference. Actually, transrectal seems to be slightly better, but what they said is if they are posterior lesions, transrectal is better. If they are anterior lesions, transperineal is better, but overall, they are the same. Okay, so I have answered all that. Then this one is there. This, I don't know how this one even came in. Systematic transperineal biopsies are preferred over systematic transrectal biopsy for detection of clinically significant cancer. The level of evidence is strong. I have looked through all the references. There isn't. They have quoted a meta-analysis of Chinese meta-analysis of transrectal and transperineal, but they were MRI targeted, not systematic. So this word of systematic should not have been there. EAU should not be getting it wrong, but they got the sentence wrong and the level of evidence wrong. And overall, in that meta-analysis, there were only 350 on either side. So transperineal biopsy, as of now, we do not do it for increased pickup. We do it because of some other reason. So why do a transperineal approach? The reason why we do a transperineal approach is it is associated with lesser chances of infection. And even if you do not give them antibiotics, still they seem to be fine. So that is the reason. So transperineal doesn't increase the pickup rate. It decreases the infection rate. So perform transperineal because of lower risk of complications. Can we do it under local anesthetic, which is what we always are worried about, because transrectal, we can do it under local. Can we do transperineal under local? They have done more than 1,000 cases. Can be done. And when you look at the overall infection rate, it's almost none, close to zero. So that's the reason why you want to be doing a transperineal biopsy, not because of an increased pickup. How to do it? These are the steps. The radiologist does the contouring of the prostate, identification of the lesion, and there is this angle correction, because normally when we were doing the transrectal biopsy, the prostate is where the ultrasound scan is showing, whereas here, the biopsy needle is going at an angle compared to where the transrectal probe is. So that angle has to be corrected. And then you import it into the ultrasound scan machine. So this is me trying to explain. So these are the images that have been imported into the ultrasound scan machine from the MRI scan. As you can see, there are lesions that are marked. And if we can go upwards, as you can see, as I go upwards in the axial plane, I'll be able to see where actually I'll be doing the biopsies from. So that's a second lesion. And then as you come towards downwards, you will see that there is less of it. So this is what I will see. And then we will see both on the sagittal plane as well as the axial plane where the lesions are. Okay. Now when I'm going to put the probe inside, we'll try to match up the prostate to this size, thereby fusing both the images. So these are. So this is for the biopsy part of it. So this has got a linear probe that is along the ultrasound scan so the transducer is much longer. So that's why you can see the whole needle going through the length of the prostate and the lesion. These are the individual lesions that have been color marked, and you can see the needle going through it. So these are the EAU guidelines, but currently the performing targeted, I would not say. I would still do a standard along with the MRI positive. And then the second is there isn't any evidence. I could not find a systematic review to say that it is that conclusive. You do it because it's a lower risk of infection. So finding ourselves in a place like this is different, and trying to work out how you ended up there is slightly different. So thank you. In case if you were looking for a technique of it, I didn't think there was any point in telling a technique wherein the machine is not available with you. So that's why I thought I will give you a theory bit and give you some reason why transperineal is better. Thank you.
Yeah, thank you very much. And you did as usual. One question which I had, is there any way of, is the super saturation biopsy out of the window now, or is still on?
Yes.
It's out of the window.
All the blinded biopsies are out.
Out of the window, because that's one area which we were talking about, first biopsy negative, second biopsy negative, then we say super saturation biopsy.
So as I said, all blinded biopsies are out of the window. Gone.
And
so everything is under vision.
And secondly, also, where does the sonologist end and urologist come in? Or where does the urologist start and your sonologist end?
So I think the sonologist will be replaced by a machine learning machine, and then the urologist will be still sitting there doing the biopsies.
Thank you. Thank you.
Thank you, Dr. Sanjay. May I call upon the next speaker, Dr. N. Raghavan. He'll be talking about advancement in robotic radical prostatectomy, ridge sparing hood technique, transvesical prostatectomy. He's on Zoom, seems. Dr. N. Raghavan.
Well, standard exam, that's why I think of genuine reason.
Hi, uh, hope you can hear me as well. I'm extremely sorry that I'm not there in person. Thank you, Amitabh. We have uploaded the video. I have to say one disclaimer that I don't do any of the operations that is being discussed. So I managed to get the videos from all the experts in the world, including from Sudhir sir's team, and I put together a video for that.
So much for the opportunity. I'm so sorry that I'm not in person with you all there. Today, I've been given a topic to talk about the advances in robot-assisted radical prostatectomy, covering some of the new interesting ways of doing radical prostatectomy. Robot-assisted radical prostatectomy is a time-tested first-line treatment option for prostate cancer. It is a challenging but a very satisfying procedure. All of us who have been doing this operation for a long time knows that very well. The most important aspect of any surgery is cancer control, preservation of urinary continence, and preservation of sexual function, which is famously called as trifecta. And we have to see whenever we introduce a new surgery, whether we are able to meet the trifecta as well. We have been trying to improve the surgical technique by introducing minimally invasive surgery, laparoscopy, then robotics, transperitoneal, extraperitoneal, in various methods of doing it, improve the quality without compromising the cancer care. The three new techniques which has come to be interestingly discussed now are hood technique, ridge sparing, and transvesical approach. So let us discuss all these things. I have to tell very honestly that I don't do any of them. Let's look at the hood technique developed by Ash Tiwari. So what you do is you primarily drop the bladder down the way we are normally doing for the radical prostatectomy to the regia space. Preserve all the structures around the prostate. You do not open the endopelvic fascia. You do not open the DVC or the puboprostatic ligament cut. So you just make a tiny incision in the anterior wall of the bladder and reach the vesico-prostatic junction. And then, dissect this out. This is an Ash Tiwari's video. As I say that I don't perform this operation. So I'm replicating what Professor Ash Tiwari is doing. So the rest of the steps are the same. You go into the posterior plane, SV is lifted, and then you do a nerve sparing approach, preserve as much of nerves you can, and divide the SV and the VAS, and then take it forward. Because the hood technique is done to preserve the nerves as much as one can, it's an almost a transfascial or an intrafascial plane, as you could see very clearly. The prostate itself is seen very clearly hanging on the roof of the surgical screen. Very meticulous surgery, very meticulously going up to the apex of the prostate. He's almost teasing out every tissue rather than, using energy or cutting anything. Then come to the side, high release, and literally walk on top of the prostate. Now the whole thing starts. As the endopelvic fascia is not open, you arch. I hope the cursor is visible. You arch on the prostate and keep the tissue that is relevant with the neurovascular bundle anterior to the prostate, keep it intact. You can see the hood there. So the hood is preserved now. This is the tissue that is arching on the prostate. So you preserve the hood there and just divide and move forward from there. Go up to the urethra and then suture the DVC from inside the hood. This can be tiny bit difficult. Sir is taking 1 or 2 stitches through the hood as well, and this suture is free from the hood. So the idea is that you preserve the neurovascular bundle going on top as well, so that it doesn't get divided at the level of the point where it is entering the penile component. So the rest of the operation is the same. Remove the prostate and then start the anatomical reconstruction. Now the anastomosis is stitched with the hood and the lateral endopelvic fascia is reconstructed back again. So what they do in hood technique is primarily put back everything to its normal anatomical position. So this is hood technique. The intent is that you are trying to preserve the neurovascular bundle on top of the prostate as well and put everything back again. Regia sparing, thanks to Amitabh who gave the video to me. As I said, I don't do this operation. So quickly going into the Regia sparing operation, many of us have seen Professor Sudhir Raval doing this operation beautifully. So the idea is that you take the colon away, go into the posterior plane. So release the SV and the VAS, and then at this point lift the flap of the bladder so that it doesn't come in the way of your operation. And this is Sudhir sir's modification. If I remember correctly, he tucks the SV inside it so that the plane is now a clean plane. All the layers or the fascial layers are so beautifully visible: denovilus, perirectal fat, intrafascial, as well as. So whichever way you want to do, you are there. It can be done in any way of your choice. Depending upon the oncology of the patient, you choose what you want to do. Here he is going into the intrafascial plane and removing releasing the neurovascular bundle. Just moving it forward so that for the sake of time. Very meticulous dissection, preserving the neurovascular bundle very nicely. At this point, you go into the lateral part and divide the neurovascular bundle and the prostatic vessels, which is supplying the prostate. And then start going around the prostate so that you enter into the lateral aspects. Now we need to disconnect the prostate from the bladder. So you drop the SV and the VAS, enter into that place where the prostatovesical junction is there, and you enter it from posterior. You go into the anterior prostate. So it's all going in the reverse here. So you go into the anterior prostate and enter into the plane, and you are practically into the intrafascial plane, the same plane that you saw in the hood technique. Whatever anterior, you are preserving all the tissue which is part of the neurovascular bundle preservation process. And you reach the urethra, divide the urethra. Now, the next step will be the most difficult, that is reconstructing the uretrovesical junction. Because the whole thing is anterior to you, you need to have stay stitch, and then you start the anastomosis. So you have to do the whole thing in reverse. First the anterior layer, and then the posterior layer, and then the anastomosis complete. You're almost suturing to the urethra here. Excellent demonstration. So once again, this is another well-established technique. Even though I don't do it, I know a lot of people in the world are doing it, especially Delhi team, Sudhir sir's team is doing a lot. Now, the last one is the transvesical approach. I have zero idea about it till I heard about it. Then I learned as well. So primarily, I think it's designed for the single port technique, where you access the bladder by a single small incision, put a gel port, and then you access the whole prostate through the gel port itself. It's an extension of the simple prostatectomy. But this time you go into the radical prostatectomy planes. So you do a circumferential incision around the urethra, then start working in the posterior plane, identify the SV and the VAS. As you could see, it is being lifted now. I do not think anybody will be attempting to do this with multi-port robotic surgery. Looks like it is a pure single port robotic surgery approach. The lateral pedicles are controlled on either side. Then you go into the anterior, drop the prostate, and go to the level of the urethra. Once again, neurovascular bundle preservation. So in every surgery, what you would have noticed consistently is that people are trying their best to preserve the anterior structures, which used to be ruthlessly sacrificed in the past, because we have realized that the anterior structures are as important as the neurovascular bundle to preserve or allow early continence recovery. So after the excision of the prostate is taken inside and left inside the bladder. That is a DVC stitch being taken now. And the DVC is being divided to access the apex of the prostate. Leave the prostate inside. A limited node dissection is doable according to Dr. Kauk, even though I think most of these patients may not be requiring node dissection, as they are all very low risk cancers. And then the anastomosis starts. So start from the posterior layer and do a circumferential anastomosis to complete the surgery. What I realized is that in this process, the bladder neck is quite big compared to a very well preserved bladder neck that we usually do, but you are not going into the extrafascial plane at all. So I just want to complete and say that there are many ways of skinning a cat, and these are many ways of doing it. My own personal view is that as long as we are able to achieve the trifecta, whatever technique we use, we should be all right. But we have to understand that there are many ways of doing the same operation. Thank you so much.
Thank you, Dr. Raghavan. If there are no further clarification question. Yeah. Okay. No problem. So next we have talk by Dr. David K. Simpson. He is a radiation oncologist specialized in genitourinary malignancies. His area of interest are prostate cancer and bladder cancer. So today he's going to talk about role and duration of ADT in salvage treatment of prostate cancer. Dr. David K. Simpson.
Good afternoon, everybody. I'm Dr. David. I'm a consultant in GI and GU radiation services at Rajiv Gandhi. The topic given to me is role and duration of ADT in salvage treatment of prostate cancer. Let me get the pointer once. And happy Holi, everyone, and welcome all to Delhi from across India. I do not have any fancy surgeries to show. It's pure theory. I'll make it as interesting as possible. So before we delve into the topic proper, let's first see the natural history of radical prostatectomy. That means, what if we do not give any adjuvant therapy? How does the biochemical recurrence happen? So for this, we have a series from Johns Hopkins in which they studied the patient from 1981 to 2010. And 1,973 males were treated with radical prostatectomy. And these patients were followed up without ADT or radiation. And we waited for distant metastasis to happen. And 315 of whom developed a biochemical recurrence had a PSA of more than 0.2. And at a median follow-up of 8 years, 134, that is 30% of patients had metastasis, and the median metastasis-free survival was around 10 years. And again, in a multivariate analysis, they found out the independent predictors for recurrence was PSA doubling time and Gleason score after the radical prostatectomy specimen. So from this, we understood that there should be something which needs to be done, to tackle this. And the same group also studied 3 prognostic factors. One is the PSA doubling time, which is shown in the y-axis here in the table. And the other 2 are the recurrence to 3 years of surgery, more than 3 years and less than 3 years. Recurrence to surgery to recurrence, more than 3 years, less than 3 years. And they stratified according to Gleason, less than 8 and more than 8. Let's see what they found out. The first column, you can see the 10-year likelihood prostate cancer specific survival was 98% when the PSA doubling time was more than 15 months. And the recurrence when it was more than 3 years, and the Gleason score when it was less than 8. Compared to that, I would like to invite your attention to the last column, which is just 1%. That is 10-year likelihood of prostate cancer-specific survival was just 1% when the recurrence happened within less than 3 years, Gleason score more than 8, and the PSA doubling time of less than 3. So this indicated that we have a heterogeneous group of patients. Some patients do extremely well. Some patients do very poorly as well. So we need to do something in the adjuvant setting. So I would like to bring your attention to the EAU guidelines, how they have stratified the biochemical recurrence into 2 groups. One group is a low risk group in which the PSA DT, that is less than 1 year or less than more than 1 year, more than 12 months, and the grade group of less than 4. And the high risk patient involved PSA DT less than 12 months and grade group 4 or 5. So we understood that something needs to be done, and adjuvant therapy needs to be done. And there is no right or wrong, it depends. We do not have any argument that radiation needs to be done. It should be part of an adjuvant therapy or a salvage. And I'm not going into the controversy whether adjuvant has to be given or salvage has to be done, but radiation has to be done. The real question is whether to add ADT to it. Should we add? Or if we add, how long we should add it. So before delving into that, let's see only with RT and without ADT, what is the survival? So in this study published in 2018, in which 464 patients were there, in which only radiotherapy was given without any ADT, the 5.9-year overall survival was 98% versus 92% in PSA if it is less than 0.1 and more than 0.1. Similarly, Jackson et al. Also studied the same thing, and the distant metastasis was 5% if it is less than 0.1, and the distant metastasis was 29% if the PSA was more than 0.1. So this has been reiterated by multiple study, and this Dr. Tendulkar's study in 2016 also said the same thing. 10-year distant metastasis was around 19% for all the patients. He further categorized into multiple levels of PSA, and distant metastasis was 9% if the PSA if between 0.01 to 0.2, and 37%, as high as 37% if the PSA goes above 2.0 nanogram per ml. So we understood that something other than radiotherapy also should be added to salvage these patients. The first article in this regard was published in 2017 in New England Journal of Medicine, the radiation with or without androgen deprivation therapy in recurrent prostate cancer. What did they do? They studied patients from 1998 through 2003. 760 eligible patients were there who underwent prostatectomy. And the patients included T2 patients, T3 patients with PSA of 0.2 to 4 nanogram per liter. And the intervention that they did was 24 or 2 years of bicalutamide or 150 milligram daily, compared it with placebo. The primary endpoint was overall survival. As you can see here in this forest plot, the effect of anti-androgen therapy with bicalutamide at 12 years overall survival, you can see bicalutamide is a clear winner. In which all the curves are, all the lines are on the left side from the central line showing benefit in the bicalutamide arm. Especially, I would like to bring your attention to the PSA if it is more than 1.5. More the PSA value, more the benefit. This line hasn't crossed the central line, showing it is significant. So they concluded that the addition of 24 months of anti-androgen therapy was beneficial, and it did benefit in long-term overall survival. In similar lines, GETUB AFU 16 trial was done, and the recent update of 112 months was published. They studied patients from 2006 to 2010, 743 patients of T2, T3, and T4A. T4A, they have taken only the bladder involvement patient. They haven't taken any patients of rectal involvement. N0, who had only biochemical recurrence, who did not have any physical recurrence. 374 patients were randomized to radiotherapy arm, 369 radiotherapy plus a short course ADT. In this case, they gave goserelin for 6 months. And they found that a huge difference in the progression-free survival, 64% in the 10-year progression-free survival in radiotherapy plus short-term ADT, compared to 49% for those patients who underwent only radiotherapy. However, SRT combined with goserelin or placebo showed similar DSS and overall survival rates. A very interesting study was recently published. This was published in 2022. It's called ESPO trial, RTOG 0534. They studied patients from 2008 to 2015. Interestingly, they divided the patients into 3 groups. In the first group of patients, they gave radiation only to the prostatic bed without lymph nodes. In the second group, they gave radiation to the prostatic bed and gave short-term ADT of 6 months. And in the third group, they included pelvic lymph nodes and PBRT, that is a prostatic bed radiotherapy, and a short-term ADT. So the idea was, if we add pelvic lymph node radiation, is there any benefit of adding ADT? This was a question that they asked. So in this forest plot, you can see the group 1 and group 2 and group 1, when they compared, group 2 was better. Group 3 and group 2, when they compared, group 3 was better. But group 3, when compared to group 1, there was a drastic difference in the benefit with ADT with lymph node radiation. So as you can see in this curve as well, on the y-axis, you can see the patient with alternative, with the biochemical recurrence failure. As you can, the green line is the group 3. Group 3 is the PLNRT plus PBRT plus short-term ADT. And group 3 became the winner. And then that established the role of lymph node radiation plus prostatic bed radiotherapy and short-term ADT. Additionally, there was statistically significant benefit in the second salvage ADT. However, there is no benefit in the metastasis-free survival or overall survival. This is the Radicals HD trial, which we all talk about. It was published or not presented in ESMO 2022. The final paper hasn't come yet. They studied patients from 2007 to 2015. And 1,480 patients were no ADT versus short course, that's 6 months of ADT. Now we need to know whether short course ADT is better or a long course ADT is better. So no ADT versus 6 months were compared with 6 months ADT versus 24 months of ADT. And they found that there was benefit with metastasis-free survival. The 6 versus 24-month comparison showed an improvement in metastasis-free survival, but no overall survival benefit. So in patients having post-operative RT after radical prostatectomy, 24 months ADT versus 6 months ADT improved both time to salvage ADT and metastasis-free survival. In contrast, 6 months ADT versus no ADT improved time to salvage ADT, but did not improve the metastasis-free survival. The next question was, is ADT enough? Should we add anything else? To address this Formula 509 trial was done. And again, the results is eagerly awaited. The full paper is fully eagerly awaited, in which they studied the role of apalutamide and its addition to ADT. Unfortunately, this is a failed trial, even though they have included those patients which are very high risk, that a Gleason score 8 to 10, PSA level more than 0.5, PT3, T4, and 1, PSA doubling time of less than 10 months, persistent PSA level, gross local or regional disease, and high decipher prostate risk score. They found that the 3-year progression-free survival was 74.9% versus 68.5% in the bicalutamide arm. I think there is a change in the format of the presentation. Anyways, so there is no benefit. The p-value wasn't significant and longer follow-up is required. Now, combining all the trials that I have talked about, the JETUC trial, the ESPO trial, the RTOG, which was published in the NEGM, they did a meta-analysis. Again, this meta-analysis also was discussed in ESMO 2022. The final paper hasn't come yet, in which they included patients from JETUC's trial, RTOG 0534, this is the ESPO trial. RTOG 9601 is the one which was published in NEGM, and the Radical Sati, which we are eagerly awaiting the paper. The 3 trials compared no ADT versus 6 months, and 2 trials compared no ADT versus 24 months of ADT. And they found that there is no clear evidence that the addition of hormone therapy improves ADT. They disregarded all other studies which was done before. And however, they found that there was a 6 months hormone therapy improved metastasis-free survival. So now again, we are in a dilemma. We are in a pickle. We do not know whether should we give ADT or not. So can Decipher help guide the use of ADT? So it is a 22 gene genomic classifier. So they applied this Decipher onto already done patients in the RTOG 9601 trial, which was published in NEGM in 2017. So retrospective analysis, but they did it in a prospective way. So the genomic score was calculated from 0 to 1, 0 being the lowest and 1 being the highest. The previous log commercial genomic GC cut points of 0 to 0.45. 0 to 0.45 consisted of the low risk patient, which in this study was around 42%. From 0.045 to 0.60, there was an intermediate group of patients, and 38% of the patients were in this group. And more than 0.6, this is the high risk Decipher, counted for around 20% of the patients. So majority of the patient, I would like to reiterate that they were in the low risk group. Now, when they studied the mortality, the first graph in the bar diagram, the blue color is the low risk patient, and the orange color one is the intermediate and high risk. And the first graph is for distant metastasis, and the last is for overall survival. Now let's see the difference in the survival. The low risk group patients were not benefiting much with ADT, while the patient in the intermediate or the high risk group, they are benefiting so much with ADT. So there is a clear cut drastic difference in the survival. Similarly, overall survival also is different between low and high risk patients. However, when they did an analysis for those patients who underwent early salvage radiotherapy, that means those patients who had an initial PSA of 0.1 or 0.2, they saw the overall survival had a negative impact on the ADT. That means when you gave ADT, that was detrimental for the patient, that actually decreased the overall survival. So you have to be very careful when giving ADT in low decipher risk patients. So result of this and other studies strongly suggest that not all men with biochemically recurrent prostate cancer after surgery derive equal absolute benefits from the addition of hormone therapy to salvage radiotherapy. So there are a few ongoing studies. One is the NRG GU008, in which they're studying epalutamide in the ADT arm. And another is Indicate trial, in which they are using PET-CT as a predictive method, and in which they are trying to study the enhanced systemic therapy in the ADT setting, along with metastasis-directed therapy. It is a 2x2 factorial study. Now let's see what NCCN says. NCCN says, as Sanjay sir also said, has got very poor value these days in Uro Oncology. The study is negative for pelvic nodal recurrence, and also those patients who have a positive fossa recurrence, they just recommend EBRT. EBRT, anyway, we know it has to be done. They just say plus minus ADT. They do not say whether it should be given, when should it be given, and the role of it, the duration of the ADT. This Dr. Alan Pry is a radiation oncologist, Miller School of Medicine. He presented the same topic in 2024 GU ASCO trial conference. In his practice, what he does is salvage radiotherapy alone. He do for those patients who has a PSA less than 0.5, low risk feature patients, and low decipher. 6 months ADT was given to those patients, that is short-term ADT was added to radiotherapy for those patients with PSA more than 0.5, high-risk patient, that is PT3B4, and grade group of more than 4, or high decipher. And 2 years of ADT he reserved absolutely for very, very, very high-risk patients. The same is reflected in the EAU guidelines, in which they say that salvage radiotherapy alone can be given in the low-risk patient with PSA less than 0.5 and Gleason score of less than 8. Radiotherapy can be combined with short-term ADT if the PSA is less than 0.7 and Gleason score of equal to 8. And 2 years of ADT along with radiotherapy can be given if the PSA is more than 0.7, more than or equal to 0.7, and Gleason score more than or equal to 8. So to conclude, there is no one fit for all. The decision should be individualized as per your clinical discretion based on the PSA at the time of biochemical recurrence, time to biochemical recurrence, PSA doubling time, Gleason score, and the decipher score if we can get a hold on it. Thank you all for your patient listening. Thank you so much.
Interesting talk. Any questions from the audience? Because the audience have been just quiet, very quiet. It seems as if we are discussing across the table. But anyway, if there are none, I have one section.
I have one.
Yeah, yes, go ahead, sir. So you go. Okay.
Now, as I was looking at your trial, which was, some 4 or 5 slides ago, and this also, what you're trying to tell us is the discussion is only on the duration of the ADT.
ADT, yes.
Correct?
Yeah.
Now, I just want to bring in the pathology of the radical prostatectomy specimen data. What do I mean by that? If you have a PT3 disease, which could be PT3A, only margin in extra prostatic extension, and B is a seminal vesicle. Years ago, Patrick Walsh always believed that moment the disease is in the seminal vesicle and they are positive, he said the disease should be taken as systemic disease. So here, if you add that parameter one more, PT3A only radiotherapy, don't add any hormone therapy. Moment it becomes PT3B, irrespective of your PSA, add ADT for 2 years. That would be one my take on this whole controversy. Timing and how long?
Yes, sir. Absolutely.
And what's your take about, after doing a radical prostatectomy, if you give radiotherapy, there might be some, some challenges regarding the incontinence in that area if you are
I
getting.
think that is being discussed in the panel discussion also, sir.
Okay, yeah.
One of the,
So is there a
Is there a-
case with this?
yes, yes, sir.
And one small query.
Yes, sir.
Your original paper which showed survival was with bicalutamide, right? The first paper was.
Yes, sir.
Why is it not being
That was the
studied?
study was initiated in 1998, sir.
Correct, but that's for 1 year and they did show benefit and now
That
subsequent
was
to that,
24 months of bicalutamide.
why is
100
it not being used in day-to-day practice? We still use
But we
LHI.
have better drugs now, so maybe that's the reason that, yeah, because that's not the standard of care anymore, isn't it?
Thank you.
Thank you so much.
So, thank you, Dr. Simpson. Yeah.
To all the chairpersons, if we can now proceed with our inauguration ceremony. I would like to invite on stage Shri D.S. Negi sir, Dr. Vinit Talwar sir. If Dr. Jagdish Kulkarni sir could stay on stage for the inauguration, and Dr. P.N. Dogra sir. Kindly join us in the lamp lighting ceremony.
शुभं करोति कल्याणं आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योति नमोऽस्तु ते दिव्यादिव्यारे दीपत्कार कानी कुण्डलमोतिहार दिव्याला पाहून नमस्कार तिळाचे तेल कापसाची वात दिवा तेवे देवा पाशी उजेड पडे विष्णू पाशी माझा नमस्कार सर्व देव देवतां पाशी ये ग लक्ष्मी बैस ग बाजे माझं घर तुला साजे घरातली इडापिडा बाहेर जाऊ दे बाहेरची लक्ष्मी घरात येऊ दे घरच्या सर्वांना उदंड आयुष्य सुख समाधान शांती.
I will request Dr. Amit Goel sir and Dr. Praveen Alawat sir to rejoin us in the stage.
So I would request RCO sir to just bless us. Sir.
Good afternoon, everyone, distinguished members of the SOGO. At the very outset, I'd like to really thank you for collaborating with the RGCI here and for holding this very important seminar or a CME on oncology, precision medicine. I'm not a science student, nor but I have been seeing for the last 17 years how the treatment protocols have changed in this hospital, especially in cancer. I used to observe about in the 2010-11 how the chemo patients used to undergo a lot of problems, side effects. Then I think slowly we found that the new medicines come, new discoveries come, new inventions come, new protocols have come. And slowly, I think these side effects have started going. So I was told that these are all effects of the precision medicine or the personalized medicine, which is being invented all over the world. So I think it's a great step forward. And that time, I think the buzzword was precision medicine. Today is a reality. So I think the next probably is the use of AI, which is probably being used in all the machines. in a limited way, but it's going to really revolutionize in the coming years that in terms of the diagnostics, the imaging, and I think in the larger interest of the patient, it will be great help to them and we'll be able to serve much better. So I think we're the cusp of revolution in medical diagnosis, use of AI. So I think it's a very exciting moment for all the clinicians that you'll be able to see much better outcome in the patient. So with this word, once again, thank you very much and welcome to all of you to this important CME. Thank you very much.
Thank you, Negi sir. I call upon Dr. Raghunath to talk about unleashing the controversy LH agonist and LH antagonist. Raghunath.
Very good afternoon to all of you. At the outset, I would like to thank RGCI team for this opportunity. My topic is unleashing the controversy related to agonists and antagonists. All of us have used agonists and antagonists. Very little controversy is there, but there is a big controversy related to CV risk. So I'm going to focus more on CV risk. What is the data available in favor of agonist and in favor of antagonist? All of you know, prostate cancer is very common in India than we thought. And in Bangalore, Delhi, and Pune, according to Globocon data, it is second common disease amongst men. Though the incidence is maybe 9 to 10 per lakh population, it is just tip of an iceberg. And we see commonly this disease in more than 65 years. However, in Uro Oncology practitioners would see even younger patients. But most commonly, we see metastatic disease even now. But more and more organ-confined diseases, we are treating only in selected centers. So for metastatic disease, hormone therapy is the mainstay of treatment. However, we utilize hormone therapy more in neoadjuvant setting, particularly before RT. Sorry, I can't. It's on. I have to bend and do it. Sorry for that. Yeah. Now there is some evidence for using neoadjuvant therapy for high-risk disease and locally advanced prostate cancers. So many uro-oncologists have started using neoadjuvant therapy for this subgroup of patients. We have so many drugs, starting from goserelin, leuprolin, triptorelin, degarelix, and now even relugolix, oral form of antagonist, is also available with us. So you know all these things, the differences between agonist and antagonist. I don't like to get into this. Just for the benefit of this is, online, many postgraduates are also looking at this. I would just briefly touch upon these things. Mechanism of action. Agonists initially stimulate LH and FSH release. That is called flare phenomenon, followed by pituitary desensitization and suppression. This is very, very important. Pituitary desensitization and suppression. It lasts for a longer period. Unlike when you use antagonists, where it is direct and immediate blockade of GnRH receptors, leading to suppression of LH and FSH. Okay. So when you stop antagonists, the testosterone recovery is faster because of this blockage. Whereas with agonists, even if you stop, when you plan to go for intermittent therapy, the testosterone recovery takes more time because of this. And there is some difference in the FSS suppression between agonist and antagonist, even with archaeectomy. The more intense suppression of FSH happens with antagonists. That could be one of the reasons why there is some difference in the CV risk, which we will discuss later. When it comes to onset of action, generally all agonists takes 2 to 4 weeks due to initial flare effect. Initial testosterone surge will be there. And when it comes to antagonists, it is rapid and we can see the results within a few hours to days. It has a prolonged action with agonists due to pituitary desensitization. by a subcutaneous route. The dosage is 240 milligram, 120 milligram vials. 2 vials you have to give in a subcutaneous site, and maintenance dose is around 80 milligram once in 4 weeks. There are different trials giving 60 and 120, but 80 is standard of care for maintenance. Because it is monthly preparation, patient has to come every month. And in Japan, 3 monthly preparations are also available, which is probably going to come to India in the near future. Injection site reaction is very common. Itching, nodularity, or even redness is felt by the patient in up to 40% of individuals. Relugolix is made available recently. It's available in the tablet form of 120 milligram tablets. Like Degarlix, you have to give a loading dose of 3 tablets followed by 120 milligram daily. It can be taken either before or even after food. Efficacy, I would not go into the details of this. All of you know, but salient, this is a RCT. This is RCT, a couple of RCTs are there. I picked up one very good RCT where let us discuss when comparing Degarlix versus agonist. So percentage of patient with median T levels, that is testosterone levels achieved in 95% with Degarlix, and Goserelin is almost 100%. Median percentage reduction, the PSA level at day 3 is more seen in Degarlix versus Goserelin. LH levels reduction is almost same, whereas FSH reduction is more with Degarlix than, it's almost 8 to 9% more with or better with Degarlix. Whether this is contributing to lesser risk of CV, we don't know. So let us discuss in the subsequent slides. The patient with PSA relapse, it's again very controversial. Here in this RCT says that the PSA relapse rates are more with Degarlix, less with Goserelin. This is really controversial, but this is the literature. This is what literature says. Again, when you are giving Degarlix initially to have the best effect, and when you switch over to Goserelin or any other agonist, what are the long-term survival? A change from gonadotropin releasing hormone antagonist to agonist does not affect the oncological outcomes in the hormone-sensitive prostate cancer. Is it safe to switch over from antagonist to agonist? The 5-year survival data says that it's almost same, whereas the equivalent of this trial is CS21A trial, in that switching over from agonist to antagonist has better survival advantage. So you, in the literature, you find, advantage, disadvantage of antagonist versus agonist. When it comes to faster testosterone suppression, you see this graph, it takes almost 28 days for the agonist, whereas antagonist reaches within 2 to 3 days. When it comes to PSA response, it almost equalizes at 56th day, and subcutaneous site reaction, injection site reaction, 40% versus less than 1%. Safety, definitely antagonists, particularly injectable antagonists, has more local site reaction, which we have already discussed. This is very important. Cardiac safety. This is an RCT published in 2021. It's called PRONOUNCE trial. It's a randomized control trial. Due to slower than projected enrollment and fewer than projected primary outcome events, enrollment was stopped, but still they could recruit more than 545 patients from 113 sites and from 12 different countries. The baseline characteristics of both the cohorts were almost similar. You see all different types of cardiovascular risks were involved, almost same, comparable when comparing Degarlix versus Lupride. So what is the conclusion? This study, PRONOUNCE study, found that there is no difference in the major adverse cardiovascular events was observed at 1 year between patients in different groups. Whereas the previous couple of studies, you see, many studies are there where they say Degarlix has lesser CV risk when you take overall patient population, Comparing with pre-existing CV risk, CV patients, its almost reduction is 56%. So in the literature, you find, advantages in favor of Degarlix and advantages in favor of Goserelin. So what is the hypothesis of increased CV risk with ADT? It is not just testosterone suppression or FSH suppression. There are so many other factors. Increase in triglycerides, decrease in the HDL cholesterol, visceral obesity, hypertension, and even hyperglycemia. All these are responsible for the CV risk. So how agonist versus antagonist, or by giving agonist, how it increases the risk of CV is it stimulates inflammatory process, and that causes block instability, and that causes thromboembolic event. This is very well documented, but in the literature, it's almost same. And the two RCT published just recently. So to conclude, antagonist Degarlix achieves rapid castration levels of testosterone and is preferred in obstructive lungs, impending fracture, and early ureteric obstruction. Flare production is not required, unlike in agonist. Local site reaction is seen in 30 to 40%. It's available only in monthly preparation, whereas 3-monthly preparation may be available soon. Relgolix is available right now as a oral preparation. The faster recovery of testosterone is seen with antagonists. Whether it has any advantage when you're planning intermittent hormone therapy, the cost per year is relatively more for antagonists compared to agonists. When it comes to agonists, particularly Goserelin and others, equally effective in achieving testosterone suppression, it needs flare protection and available as 1, 3, and 6 monthly preparations. No or very negligible local site reaction. Cost is again relatively less compared to antagonists. Testosterone recovery takes more time. Whether it's advantage or disadvantage, we have to decide. CV risk, when it comes to both agonist and antagonist, divided opinion is there in the literature. But in clinical practice, whenever CV risk is there, generally we prefer to give antagonist over agonist. Thank you.
Thank you, Dr. Raghunath. And you really made us realize that all is not lost as per the thing. Now, the question which is coming into my mind is, let's talk about this Relugolix, which we are talking about. If you're thinking that this is as a tablet form, can we use it when you are using SBRT with a short-term hormone therapy? Would that be a good way? Because the recovery, what you said was, testosterone is faster, and these patients are looking for that.
Yes, sir.
So I think that could be one.
That's where either Degarlix or Relugolix is advantageous. When you give in a even neoadjuvant setting, you are going to give hormone therapy for a limited period, like say, for example, 3 months or 6 months. The moment you stop, the recovery of testosterone is already there within 2 months.
No,
whereas with antagonists, with agonists, it takes sometimes 3 to 4 months.
No, we do have this problem of, local problem of Degarlix. So instead, can we shift it to oral?
Yes, you can shift. There are small case series where patients who are taking Degarlix has switched over to Relugolix without any, adverse events.
But then again,
and even the overall survival.
No, but you were saying the dose is, again, loading dose is with 360 milligram, right?
360. But when you are taking Degarlix,
short course,
even say, for example, you are given 120 to 240 milligram, you have given. 4 weeks later, you can straight away switch over to Relugolix, just 120 milligram. You don't have to start loading dose. So loading dose of Degarlix is 240 milligram, 120 milligram into 2 injections to be given. With Relugolix, it is 120 milligram into 3 tablets. That is 360 milligrams.
Thank you.
Thank you, sir.
May I request Dr. Talwar?
Well, now we are getting the.
Yeah.
Yes.
Thank you. Now, may I call upon Dr. Tal. So what is your problem with him?
Hello. Yeah. So this is the topic of discussion, the focus on PARPI plus ADT. As all of us know, prostate ranks 12th incidence-wise in India as per the Globocare 2020 data. And all the patients of metastatic prostate cancer, they go on to develop a CRPC, which is castrate-resistant prostate cancer over a period of time. And once you shift over from hormone-sensitive to hormone-resistant prostate cancer, the survival is very dismal. It is about 1 to 2 years. And all of us know that prostate has got certain genomic aberrant pathways, and that accounts for about 23% of all the cases. So initially, we never used to target them, but now we know that these pathways are there, apart from the standard hormonal pathways, which can be targeted. And in the CRPC, that is the castrate-resistant prostate cancer setting, we can target these patients. And you can have double-stranded breaks, you can have adducts, which are bulky, or you can have base insertions or deletions. All these can occur whenever you treat cases of prostate cancer. But amongst all of these, HRR, that is the homologous recombination repair gene, this is the one which is the sheet anchor whenever we treat prostate cancers in the CRPC category. So if you see the gene alterations, you find that about 15 to 18% of the whole CRPC patients, they harbor these genes. And amongst them, BRCA2 is the one which is most prevalent, followed by the ATM and then the BRCA and the CHEK and PALB2. So despite significant progress in systemic therapy, metastatic CRPC continues to be lethal. And these gene alterations, they can confer sensitivity to the PARP inhibition, that is the drug which we are going to talk about. And the anti-tumor activity has been seen in patients who harbor these HRR deletions. So this was the registration trial, the PROFOUND trial. This was the first randomized trial, a phase 3 study. This showed the actual benefit of PARP inhibitors in CRPC prostate cancer patients. And basically, this was in patients who had documented evidence of metastatic CRPC. And these patients were in good performance status. And they had got no prior treatment with any PARP inhibitor. And some patients had got chemotherapy prior. So these were divided into two cohorts, that is cohort A and cohort B. So as I told you, the maximum benefit was seen with the BRCA1 and BRCA2 genes. So that was kept in cohort A and along with ATM. The rest were all in cohort B. So basically it was to see whether this drug works in both the cohorts or it is working better in one cohort. And the drug was olaparib, which was given 300 milligram twice a day versus the physician's choice. And this was continued till progression or intolerance. And patients were allowed to carry over also. The primary endpoint was radiographic progression-free survival. And the secondary endpoints were the toxicity profile and the quality of life indices. So this was the gene panel which I was mentioning to you. Cohort A had about BRCA1, BRCA2, and ATM, and the rest were in cohort B. And these were the 15 genes which were the subset of genes covered in the Foundation 1 comprehensive cancer-related gene panel. These were the baseline characteristics of cohort A and cohort B, and you can see they are very well matched as far as the age, the metastatic disease at diagnosis. And you find that about 40% of patients had bone-only mets, and the rest were visceral and other mets. And almost universally, all of them had a high Gleason score. And a multivariate analysis was done regarding adjusting the previous taxanes. Some of the patients had received docetaxel, but almost none of the patient had received paclitaxel. Only one patient had received paclitaxel. And prior hormonal agents, yes, most of the patients had received either enzalutamide, abiraterone, or a combination of both. And this is the alterations which you see in cohort A, cohort B, and combination of both the cohorts. And as I had alluded to you earlier, BRCA2 is the one which is the commonest, followed by ATM, and then followed by the others, that is BRCA1 and the CHEK. So addition of PARP inhibitors significantly improved the radiological progression-free survival in patients who had the alterations of BRCA1, BRCA2, and ATM. That is the cohort A, which was the one which was taken. And you find that the median PFS was almost double. That is, it's about 8 months as compared to the physician's choice, that was 4 months. And this was a very robust hazard ratio of 0.34. If you see the benefit across the subgroups, sorry, whether you have bone disease, whether you have visceral disease, ECOG status 0 to 2, age more than 65, less than 65, across the ethnic groups, Asia and all, you find that this drug benefited in all the subgroups. And coming to the overall survival, you find that there was a difference in the overall survival, 18.5 months versus 15 months. And this has been ongoing till about 1.5 years. So even at 18 months, you find that half of the patients were still alive in the CRPC category. And mind you, these are the patients who have been heavily pretreated prior. And there was a statistical significantly improvement in the overall population when you see the key qualifying genes, and you find that median PFS was 5.82 months versus 3.52 months. So again, here the hazard ratio was about 0.49, which is very high. Seeing the forest plot, as we have seen in the OS, we find that again, all these subgroups, whether the age or the ECOG status or the ethnicity, they all benefit with the olaparib as compared to the standard controls. And this, if you see in the intent to treat population, also you find that the median OS is better than the physician of choice patient. So this drug benefited those who had these alterations, that is BRCA1, BRCA2, and ATM. And the cohort B, which was there, which had the other alteration, they didn't do that well as compared to the patients who had the cohort 1. This also had its own side effects profile, and you find that about 22% of patients had dose reductions due to adverse events, and about 18% had discontinuation. And there were about 4 deaths due to the adverse events. And this, you see the adverse event profile. Amongst the adverse events, the commonest was fatigue in these patients, followed by anemia, and after that, it was followed by the diarrheas. So even when we tried this drug in the clinical trial, we were a part of the solo trial, we found out that the commonest side effects were anemia in these patients, and in about 2 patients, we had to stop the drug because of intractable anemia in these patients. Fatigue was always there, and you had to look for fatigue in these patients to say that that side effect was there in these patients. There were no reports of MDS or AML, which was seen in the ovarian trial in these patients. So this was the patient flow. When you saw about 4,000 patients, they were screened, and out of that, about half of the patients were successful. And out of that, 387 patients were randomized over 22 months, 245 in cohort A, that is BRCA1, BRCA2, and ATM, and 142 in cohort B. And this was done in about 20 countries. And the test success rates, it could be seen that definitely it was better in the new samples as compared to the archive samples. And the samples which were less than, which were more than 3 years, they were generally not used because the DNA extraction would be a problem in these patients. And over a period of time, we find that there was a DNA degeneration. And this was the organ site from where these tissues were taken. So high proportion of prostate samples were derived from archived core needle biopsies. And they had their problems in DNA extraction. And the most frequent reason for the test failure, when it was pathology, it was the not adequate tumor content. When it was the DNA extraction failure, it was because of insufficient DNA yield. And when it was the failure after DNA extraction, it was the DNA quality was not adequate for NGS. So these were the challenges which were there whenever the DNA extraction was done in these patients. So keeping this in mind, currently what we are doing and what we are doing in RGCI also, we are doing sampling on tissue in which you look for the germline and the somatic. And if you have any doubts, if this is negative, then you can look up in the germline areas where this can be tested. After that, probably you can do ctDNA testing or CTC testing. But then at this point of time, they are not a standard of care. So you do tissue first, followed by tissue, you do germline on blood. If that is not there, then probably you can go for ctDNA testing and do further validation. And again, this is the preferred algorithm. You get the tissue, as I said, you do the tissue, you do the testing, it is successful. You take a clinical decision whether you have to give PARPI or not. If the test is unsuccessful, if tissue is not available, you do the germline testing. And probably after that, you can do the ctDNA testing. But access to robustly validation of plasma ctDNA, again, is a challenge, which we see in our clinical practice at this point of time. So at this point of time, the situation is that if you have a patient who's castrate-resistant prostate cancer, then in the first line, you can check for the tissue BRCA. If it is not there, then you can check in the germline, that is the blood. If it is positive, then you can give these patients PARP inhibitors. Either you can give them alone, or if the patient has not been exposed to abiraterone earlier, then that can be combined with these PARP inhibitors, and they can be. If the patient has been given ARs, that is abiraterone or enzalutamide in the hormone sensitive setting, then in that case, you give PARP inhibitors alone in these patients. And the FDA alert was only those patients who are BRCA1 and BRCA2 positive. Only in these patients, you should give PARP inhibitors and not in the other HRR genes, because the benefit which has been seen, that is quite abysmal as compared to the BRCA1 and the BRCA2 positive patients. You may get some response in patients who are BRCA1, BRCA2 wild, and they have other HRR alterations. But then the actual benefit which is going to accrue, that remains to be seen in those patients. So I think I'll stop here. I thank you for your patient hearing.
Thank you, sir. Thank you for enlightening us on this new drug. If there are no further questions, shall we move on to next session, next topic? Next, we have two talks on recent updates in the management of real-world evidence-based discussion. So first talk will be by Dr. Amitabh Singh on non-metastatic CRPC.
Good afternoon, everyone. So after hearing so many very interesting and excellent talks, so now it's time for just application of all these medication in clinical scenarios actually. So I'll be just discussing the clinical scenario of non-metastatic CRPC, where darolutamide works very excellently actually. So this is disclaimer from our side. Darolutamide is a second generation ARI. So it is different from first generation ARI in different aspects, like it binds with a very high affinity and selectivity to AR, and it prevents the DST binding to AR. It is strongly inhibiting androgen-mediated nuclear translocation of AR. And third, and that is the most important one, it retains antagonistic property in cell, expressing increased AR level also in prostate cancer. So that is how it actually acts also in castrate-resistant metastatic prostate cancer cells, whereas these first generation AR, they are not active against castrate-resistant prostate cancer cell very well. But all these second generation ARs like enzalutamide, apalutamide, and darolutamide, they are working on the castrate resistance also. So there is a difference in structure, chemical structures of all these three ARI, these darolutamide, enzalutamide, and apalutamide. So darolutamide has got very unique structures. That is, it is a very flexible one. And that's why, because of its increased flexibility, higher polarity, and increased hydrogen bond forming potential, it is having very low blood-brain barrier penetration. So that's how it prevents the CNS-related side effect. Whereas all these enzalutamide and apalutamide, they are known to cause various CNS-related side effects, just like sudden fall, having seizures, and all other side effects. So coming to the role of darolutamide in non-metastatic CRPC patients. So this has been established by a phase 3 randomized trial, multi-center randomized trial. So that was Aramis trial, and this is the trial schema actually. So they tried to enroll almost 1,500 of the patient, and all these patients were non-metastatic CRPC with PSA doubling time of less than or equal to 10 months. Although there were various stratification factors also, like PSA doubling time less than 6 months, more than 6 months, and use of osteoclast targeted therapy, whether they have been used or not. And all these patients were randomized into 2:1 ratio. So ADT plus darolutamide arm enrolled almost twice number of the patient compared to the ADT plus placebo. And the primary outcome of this study was metastasis-free survival, and secondary endpoint, that was final endpoint, was overall survival. So there was actually there were various other parameters, secondary endpoints and exploratory endpoints, just like progression-free survival time to PSA progression, PSA response rate also. And these are very categorically inclusion criteria that patient should not have any metastatic disease. He should have a non-metastatic CRPC. And all these patients were evaluated on the basis of only CT scan and bone scan. They were not evaluated on the basis of PSMA PET scan. And they should be high-risk patient, considering their PSA doubling time should be less than 10 months, and the PSA at the time of initiation of darolutamide should be more than 2 nanogram. Although we are running a phase 4 study of darolutamide at Art Center, and they have reduced this PSA level, and they are now including the patient who are having PSA more than 1 nanogram per milliliter also. But almost every other criteria is same for this phase 4 study of darolutamide. They compared both the arm for demographic parameters and baseline characteristics, and both groups were matched to each other. And when they evaluated the outcomes in terms of overall survival, there was definite 31% risk reduction for the death with hazard ratio of 0.69. When it came to subgroup analysis, then OS advantage with the darolutamide was found in almost every subgroup, irrespective of the characterization. When the primary endpoint, that was metastasis-free survival, was evaluated, there was almost 59% risk reduction in metastasis-free survival, with hazard ratio was almost 0.41. Again, in various subgroup analysis, it was found to be beneficial compared to the placebo. They again evaluated the patient depending on the subgroup analysis, like whether patient is having PSA doubling time less than 6 months or whether they are having PSA doubling time of more than 6 months. And darolutamide advantage was found equally beneficial in both group in terms of outcome, whether it is a primary or it is a secondary outcome. In terms of various exploratory outcome analysis, it was found to prolong time to progression, first time to start of cytotoxic chemotherapy, time to having development of first symptomatic skeletal event. Again, in terms of progression-free survival, it was advantageous. In terms of PSA progression-free survival, it was better compared to the placebo therapy. And if you'll see this chart, forest plot, this graph and this PSA response rate with the darolutamide, then almost 51% of all these patients, they had almost more than 90% of decline in PSA, whereas 32.3% of the patient had almost 50 to 90% of decline in their PSA after starting of darolutamide. So these are again various exploratory endpoint analysis, and darolutamide was consistently found to be beneficial in terms of all the survival endpoints, whether they are primary, secondary, or exploratory outcome. So it was again evaluated for the side effect profile also, and it was found as equally good, except for this asthenia, where it was not significantly very different from the placebo, but the percentage of having asthenia was almost 12%. But the most of these toxicity grade was almost grade 1 to grade 2. Only 5 to 6% of these patients, they had grade 3, grade 4 toxicity in terms of asthenia. So whether you see adverse event in terms of impacting the daily life or the quality of daily life of the patient, it was not significant. If you see the side effect profile related to the CNS side effect profile, then also it was almost equal to the placebo therapy. As I mentioned, the only fatigue and asthenia was a bit more, that is almost more than 10%. So in conclusion, Aramis was found to be efficacious in terms of survival also, and in terms of metastasis-free survival also. And in terms of safety, it was found to be as safe as placebo therapy. So most of all these side effects, there was only less than 2% of increase in side effect profile compared to the placebo. Whereas asthenia has, although more than 10%, but most of these side effects were only grade 2, grade 1 and grade 2 with preserve of quality of life. So there are various studies with the darolutamide which proved its effectiveness for the non-metastatic CRPC, but this study is very important, where this is a real-world study actually, where darolutamide was compared to the enzalutamide and apalutamide for non-metastatic castrate-resistant prostate cancer cells. And in outcome, it was found that median time to discontinuation and progression to metastatic CRPC was not reached for the darolutamide cohort, whereas it was less than 2 years for enzalutamide and apalutamide. And you can see the Kaplan-Meier curve, and all these blue dots actually they are for the darolutamide, and they are way beyond compared to the enzalutamide and apalutamide. Whereas it preserved the rate of discontinuation is much better than compared to the enzalutamide and apalutamide also. So just discussing a real world scenario. So this patient is our patient actually. He was diagnosed at the age of 68 years with prostate cancer. At that time, glycemic score was 3+4, PSA was 6.7. So I think it was way back in 2010 when Dr. Rawal was doing HIFU in this institute. So this patient got HIFU in 2009. So after first HIFU, he didn't respond. His baseline, the nadir PSA was 2.5 nanogram. So he again underwent re-HIFU in 2010, then he responded. But in between, in all these 6-7 years, he recurred PSA wise. He had biochemical recurrence several times, and he was kept on intermittent ADT. So last PSA in 2023 was 2.2. That you can see this 10th of April in 2023. So his PSA was 2.01. So before, because the PSMA PET scan which were done before in 2022, they didn't show any disease despite of having PSA 2.2. So this time actually we thought of enrolling this patient in darolutamide phase 4 study. So according to study protocol, he has to undergo CECT and bone scan, and we couldn't find any metastatic disease on CECT and bone scan. So we started him on a darolutamide trial, considering as a non-metastatic castrate-resistant prostate cancer, 600 milligram BID, that is a standard dose. So you can see the PSA response. So it has been 1 year actually by taking darolutamide, and his PSA dropped significantly. Now his PSA is less than 0.01. And the good thing and the best thing about darolutamide, he doesn't have any side effect of darolutamide. He is tolerating complete full dose of darolutamide, that is 600 milligram twice a day, despite of having any side effect. So we didn't feel like dose titration or dose modification because of the side effect profile of darolutamide. So this is for darolutamide. Actually, it is a wonderful drug compared to the enzalutamide, apalutamide. The side effect profile is very safe. The patient can continue darolutamide for very long period, actually more than 1 year. Whereas we have seen that enzalutamide is known for having this asthenia, skin rashes, and all these side effects. So thank you, sir. Thanks for your patience. Yes, sir.
Lovely presentation. So, have you used darolutamide in other patients as well, or this?
Sir, I think right now we are having 5 patients with darolutamide. In trial, actually, we have got 3 patients. 1 patient failed on darolutamide, so now he is taking docetaxel. He failed retroperitoneum with the lymph node metastasis, and there are 2 patients also which are taking darolutamide with docetaxel also. So Dr. Assis will be discussing this combination therapy.
Distinguish which patient you're sending for chemo rather than or giving darolutamide?
So if patient is non-metastatic CRPC, then always intend to do start ARI, whether it is darolutamide, enzalutamide, or apalutamide, depending on his whether he can afford the darolutamide or not. And if the same scenario, if he is having metastatic hormone-sensitive prostate cancer disease with high burden disease, then we always tend to start with the darolutamide and docetaxel, because it has been seen that it has got much better effect, much better hazard ratio compared to abiraterone and docetaxel. But the finance, actually, because it is very costly, so most of the patients, they can't afford darolutamide right now.
The approximate cost?
I think Bear Guy will tell you about this thing. So I think 1 month dose is coming around 90 or 85,000 right now.
Thank you.
Is it available, sir? Darolutamide, yeah. Nibica is available in the market, so it is darolutamide, sir.
Thanks, Amita. So our next speaker is Dr. Ashish Khanna. He'll be talking about metastatic hormone-sensitive prostate cancer.
Good afternoon, everybody. So my talk for today will focus on the recent updates in the management of hormone-sensitive metastatic prostate cancer, and it is primarily going to focus on the new kid on the block, which is triplet therapy. So when we are dealing with these patients, we have 3 things in mind, or 3 considerations: the goals, the gains, and the pains. Goals and gains, it is self-explanatory, but when we are talking about the pains, it is the pain of the pharmacological toxicity as well as the pain of the financial toxicity of the additive therapy. So we aim to extend the lifespan of the patient, but adding years to his life, but also maintaining the life to the years that are remaining. And in addition, we want to delay the progression to the castrate-resistant state. We all know that once a patient develops the castrate-resistant phase, the survival is dismal, almost around 1 year. And all our aims now are being directed towards delaying this development of this castrate-resistant phase. So we can see that from the castrate-resistant phase, the use of abiraterone docetaxel was shifted to an earlier phase. And a lot of trials, such as the Charted trial, the Stampede trial, and the Latitude trial, have paved the way for introduction of these therapies quite in the early phase. Along with these, we now have enzalutamide and darolutamide as well. Various clinical trials have used crude, although the most commonly used, but crude methodology to stratify the disease into either high volume or low volume as per the Charted criteria, where we are using the criteria of 4 or more bone metastasis with 1 bone outside the pelvis of the vertebral column, or the presence of visceral metastasis as high volume disease. The Latitude trial stratifies the disease as high risk or low risk based on 2 out of 3 of the following criteria, that is 3 or more bone metastasis, visceral metastasis, or a Gleason score of more than 8. Now coming to the triplet therapy. We have 3 trials: the Enzamet trial utilizing enzalutamide, the Peace-1 trial utilizing the abiraterone, and Arasens trial utilizing darolutamide, that have paved evidence for the utilization of triple therapy. Coming on to the Enzamet trial, it was actually a trial to prove the superiority of the combination of ADT with enzalutamide over ADT plus placebo. But at that time, the Charted trial was published and the new standard of care became ADT plus docetaxel. And therefore, almost 41% of the patients recruited in this trial were those who received ADT as docetaxel as standard of care, Along with this, they were randomized to either enzalutamide or a placebo agent. And this trial was not powered to actually see whether there was efficacy of the triplet, and it actually failed to demonstrate any overall survival benefit. There are a few reasons that may have contributed to this. We can see that patients who are taking enzalutamide along with docetaxel, only 65% were able to complete therapy. And the combination of the triplet therapy actually led to more compounding of the adverse effects of docetaxel in form of alopecia, fatigue, nail changes, and neuropathy, leading to discontinuation of the triplet therapy. Coming on to the next trial, which is the PEACE-1 trial, it is a 100% de novo hormone-sensitive prostate cancer cohort of patients that were randomized into standard of care versus standard of care plus abiraterone acetate. Similar to the Enzamet trial, the ADT plus docetaxel became the standard of care later on, and we can see that it is only in 2017 or 18 that docetaxel became a mandatory part of the standard of care. So when we were evaluating patients who have received docetaxel along with abiraterone, both populations were comparable, and we were able to see that there is a significantly improved radiographic progression-free survival with the triplet therapy, almost 50% reduction in the progression. And this was irrespective of the volume of disease. Very important here. There was improvement in the CRPC-free survival, which I talked about as an important goal. And there was also benefit in the overall survival with almost 25% reduction in the risk of death. However, this overall survival benefit was only restricted to patients with high volume disease and not so in the low volume disease, although the publication has cited that the low number of patients may have contributed to this effect. Another important thing that adds to the significance of the results is that almost 84% of patients progressing on the only standard of care arm also continue to receive other forms of therapy, and this makes the statistics even more significant. But the addition of abiraterone adds hepatotoxicity, hypertension, and hypokalemia as increased side effects when we are comparing it with docetaxel alone. Now comes the kid darolutamide, which Dr. Amitabh has already discussed about the pharmacology. So the intent behind the triplet was to target AR-dependent mechanisms along with AR-independent mechanisms. And then came the ARASENS trial. So the ARASENS trial was a well-planned phase 3 randomized double-blind trial, which was a multicentric trial, where hormone-sensitive prostate cancer patients with metastasis were randomized to receiving ADT plus docetaxel versus ADT plus docetaxel and darolutamide, with overall survival as the primary endpoint. And this trial showed that the triplet had 32% reduction in the overall mortality, giving a significant overall survival benefit, which was independent whether the patient was a de novo hormone-sensitive prostate cancer or they were a recurrent metastatic hormone-sensitive prostate cancer. Again, the benefit of overall survival was limited to patients with high volume disease, but both high risk and low risk disease patients continued to benefit with darolutamide addition to docetaxel. Secondary endpoints such as the radiographic progression-free survival, castrate-resistant progression-free survival, need for initiation to other therapies were also reduced. I would like to draw your attention to the important PSA metrics. The first is undetectable PSA, which is a PSA value of less than 0.2, which is defined as a deep and rapid response to PSA. And we can see at every time point, 24 weeks, 36 weeks, 52 weeks, the levels of achieving undetectable PSA were almost twice as likely in the darolutamide arm as compared to the docetaxel arm alone. Going on to the next metric, which is PSA 90 response, that was also significantly in favor of darolutamide. Both of these PSA metrics have time and again been proven to improve survival of these patients. As Dr. Amitabh pointed, that darolutamide, the patient is able to tolerate it for prolonged periods, and the median duration of darolutamide therapy was 41 months. Another important thing, the addition of darolutamide did not add to the additional pain of docetaxel. We can see that 87% patients tolerated triplet therapy, completed the entire 6 cycles of docetaxel, and similarly, those achieving taking placebo were able to complete their docetaxel. This translates into what is that darolutamide has adverse effects that are easily tolerated by the patient and do not add to the toxicity of docetaxel. Another important aspect related to pharmacology is that these elderly patients are having multiple comorbidities like hypertension, cardiovascular morbidity, diabetes mellitus, where drug-drug interactions because of polypharmacy are very crucial. And we can see as compared to apalutamide and enzalutamide, darolutamide has minimal toxicity or drug interactions that makes it more preferable over these agents to be used as a part of triplet therapy. So in our patient who was a 63-year-old gentleman, he presented to us with lower urinary tract symptoms and back pain. His baseline PSA was 566. We did a biopsy which was Gleason 4+4. He has history of hypertension. There is a history of family history. So he underwent a biopsy. He also requested for a genetic analysis, which from his tumor tissue came out to be BRCA2 positive. And explaining to him that he has a high volume, high risk disease, he was counseled to start darolutamide along with docetaxel, which of both of which he tolerated very well. And now his PSA has come down from 566 to 0.55, which is quite good. The patient is doing well. He is a CA by profession. He is going to his work. There is no toxicity. He has finished his docetaxel. Although this follow-up is quite short, almost 6-7 months only, the durability of response is still not is still yet to be seen, but he has done very well and has tolerated the entire therapy. So that ends my topics. Therapy is going to stay, but we have to see which patients, so a subgroup of patients are going to actually benefit from this therapy. Thank you. Yes. Yes.
How many meds?
Extensive skeletal metastasis. PSA, initial PSA 566. Almost all bones were studied. And that is why he was started on the antagonist pharmacon instead of the agonist therapy. And he's done well. Hopefully, he'll continue to do well.
So you think that now with this data or what is happening here is almost abiraterone will be
So as I said, there is
deferred for a later date or?
No, sir. I believe that in the Indian scenario where the patient has to pay out of pocket, the use of darolutamide may be restricted because of this financial toxicity. But in those definitely who are affording, this is a better choice over abiraterone. But both of the trials show actually that both are beneficial. And the actual question is, if you use abiraterone along with docetaxel, what do you give when he fails? If you give darolutamide and docetaxel, what do you give when he fails? So that data at this moment is not with us. Trials have to be conducted. Then we'll better know what sequencing actually benefits. Thank you. There is a question from the audience. Yes. 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 So that is the whole problem, that nowhere they have actually compared with either ADT, docetaxel, enzalutamide versus ADT or enzalutamide. They have not compared. Or yes. I agree. I agree. That would have been a better comparative arm as compared to docetaxel alone. Yes, Peace One trial. Yes.
Sample size will go ahead. Very honest. They were non-feasible.
Thank you, Ashish. May I call upon the dais, Dr. Puneet Ahluwalia. There's a panel discussion now on carcinoma prostate. So I'll just do the brief introduction of Dr. Ahluwalia. So he has received his clinical fellowship. He's a director and head urologic oncology and robotics at Medanta Hospital, Gurugram. Received his clinical fellowship in robotic surgery along with fellowship in Uro Oncology from Japan and University of Miami. One of the first certified proctors for Intuitive Surgical US. He has trained many established urologists nationwide for complex robotic Uro Oncology procedure.
I think that is
Oh,
enough. Stop that. We are
he's
all a close
big
group here
fan
and
of-
everyone knows everyone here. So. Thank you so much for that extended introduction, and thank you, Dr. Amitabh, for inviting me here. So I think let's go ahead with the panel discussion. I would like to invite my elite panel today. So we don't have the surgeons who were initially getting into this panel. So I would request Dr. Sanjay Adla to please come on the panel. And I think with his vast knowledge, we don't need another surgeon to answer our questions. Dr. Manoj Gupta, nuclear medicine. So Dr. David Simpson, radiation oncology from RGCI as well. Dr. Garima Durga. So she is a histopathologist here, and Dr. Arpit Jain, please.
There were 4, 5 mics. Oh.
So what I'm going to do is I'm going to present a case. There's one case, and then we'll continue to discuss that. And at the end of that case, we'll tweak a couple of situations and see the situation there. So the index case is a 66-year-old male who has moderate to severe LUTS for 2 years and found to have elevated PSA of 13.1. History of diabetes mellitus and hypertension with IPS score of 19 with moderate to severe LUTS, shim not active, DRE grade 2 hard nodule on the left side, and urine culture showing no growth. So MP MRI was done, which showed 39 cc prostate, Pyrates 5 lesion with extraprostatic extension, left SVI, fat cleanse with rectum maintained. Histopathology showed adenocarcinoma, Gleason 4+3, but it was a high volume disease, 12 out of 12 cause disease, cause positive with 100% maximum involvement. Also, PSMA PET scan, which we usually do now, is showed a localized disease with no evidence of locally advanced disease or distant metastasis. So my first question is we already know about the role of MRI now. We have been discussing it at length. MRI targeted biopsies and the role of MRI before biopsy now. So let me come straight away to PET-CT, Dr. Manoj. So what do you think the role of PET-CT now is in diagnosing or staging the prostate cancer? So is it for all cases? Is it for only for higher risk cases? What do you prefer?
I think if you look at the guidelines, so it is definitely yes for the high risk cases. So particular case.
So this particular case, if you look at the T stage, that is T3B, is involving the seminal vesicle. So it become a high grade straightforward. The PSA value though is 13. So it's a straightforward high risk case. So there's a clear cut case of doing a PSMA PET scan. It will going to give you a better identification of the lymph nodal metastasis as well as the distant metastasis.
So is it the sensitivity or the specificity which you're looking over the conventional imaging of MRI and all?
I think it's both, but it's more sensitivity rather than a specificity. If you look at the data, the sensitivity is somewhere around 70%, and the specificity is somewhere around 98% as compared to multiparametric MRI.
Yes. So this study showed it beautifully. So it is basically the sensitivity which is improved much. Other investigations like MRI and bone scan are specific, not to that extent of PSMA PET, but still they are acceptable. But sensitivity is improved a lot. If you see for the nodes as well as for the distant mets, as well as for the extraprostatic extension. And the same thing has been highlighted again in the EAU guidelines as well. If you see the nodal staging, PSMA PET was more sensitive, and also for metastatic staging. So it's a strong indication for, and Dr. Garima. So my question to you is, we all know the prognostic markers, histopathological markers for biochemical recurrence or for developing metastasis, PSA, Gleason score, all these things. But any particular markers you are doing in RGCI, or any particular marker you are interested in the coming future, which you think would help us in diagnosing it as a clinical significant prostate cancer in terms of recurrences or metastasis, developing metastasis?
In addition to the conventional markers, we have markers like P10, ERG1, and ARV7.
So what are you doing it here regularly?
So P10, as you all know, is a tumor suppressor gene, and it is associated with higher Gleason score and aggressive course. And also we have therapy against the downstream pathway, that is the PIK3 inhibitor pathway. And then ERG1, it is it is the fusion product of the Tempest ERG fusion product, and that is also raised in that is also expressed in around 50% of all SNR adenocarcinomas. It is not a very sensitive but a specific marker, and it is also a marker of small cell. If you want to look for a small cell, whether it is originating from prostate or from somewhere else. And then we have ARV7, which looks for specifically the splice variant, androgen receptor splice variant.
Okay.
In addition to these markers, we can also look for microRNAs, which also act as tumor suppressor genes. And if tissue is an issue, we can go for liquid biopsy. We can analyze the ctDNA.
Okay. And what about genetic testing? The next question is, what all genes you want to test at this point?
Genetic testing, it can be offered at the inception. Also, if we have a significant personal or family history, or it can
Actually,
be offered.
guideline says you should offer it in high risk also, and at this is the best time actually to offer. But I think everyone would agree that at this point of time, at the diagnosis, very rarely we do it. And I'll come back to that point later on. I have a point in I have a slide in that. But what genes basically at this point of view? There's no family history in this case.
Since it is an advanced disease, so we'll go for the HRR panel, which looks for the basically 15 genes. Yeah. They are the repair mechanism which looks for double-stranded DNA breaks, and of which it helps us in deciding the therapy, as well as in prognosis, and also to ascertain the familial risk both to the patient and his family.
So these high-risk mutations, we'll come back to that, especially the BRCA1, BRCA2, ATM genes, all these genes are more important. So Dr. Sanjay, please. And Dr. David, I'll come to you also. So this is a case scenario. What do you want to offer? You want to offer a surgery, or you want to send the patient to radiation?
I don't want to sit on the fence with this. So I don't want to say I will have a discussion. So if I was going to operate, why would I operate? He has got an IPSS score of 19. That's one. Second, he is a typical patient for his age. He has got diabetes and hypertension. So I can't say that he has got very extended lifespan. Average lifespan for an Indian is around 77 as of now. So whatever we do, he's going to survive for that period of time.
Yes.
So evidence would say ADT plus RT is the standard of care for him, especially for a T3B.
Okay. No, he's 66.
Yeah, 66.
Yeah, his age is 66.
T3B, I'm saying.
Okay, sorry. So you would definitely agree with that? There is no contradiction in that.
Came prepared with for a big fight. But
No.
sir has made the very easier.
Yeah.
But yeah,
So I think it would not be wrong to say that many people will do surgery also. Even in the guidelines, with this age, surgery is
Both
offered.
options are given.
So both the options are there. So you want
As he's not making a case for RT, I'll make a case for surgery.
Okay, go.
Why would I operate? He has got a IPSS score of 19.
Yes.
I know that that obstruction part will be gone. That's one. Second, for the volume of tumor, I don't want to use the word multimodality treatment. I would tell him that for a T3B, there is a 50-50 chance you will get away just by surgery. Surgery, extended pelvic lymph node dissection, and try to get clearance on the seminal vesicles. Even if it is T3B margin clear, you would say that 50% you would get away without needing any further treatment. That's the reason I would push for surgery as well.
Okay. So now you want to say?
So said 50% of patients do not require radiation. That means 50% of patients do require radiation at
Yes.
the end. And then why would you subject this patient for a bimodality treatment?
So you want to answer that? No?
Yeah. The reason why I would offer him is that I always tell the patient on the face value, both of them are equivalent. In that both of them are equally good, both of them are equally bad. Yes. I do not think you are going to tell me that 5-year radiography or biochemical recurrence-free survival will be more than 50%. It will be the same for radiotherapy as well. If he recurs following surgery, I can give him radiotherapy. If he recurs following radiotherapy, none of us will touch him with respect to surgery. He will suffer from local urinary tract symptoms and the side effects of the radiotherapy. So that's the reason I would say surgery as the first line of treatment.
But when you do the surgery, there will be complications. It's not that it's devoid of.
So we will not go that much in detail. So okay. So that is why particularly I said that moderate or severe LUTS, and the points of Dr. Sanjay has already highlighted of the and this is a practical data. This is not a literature which says 50%, but in our data also 50% of the patient with T3B disease won't require additional. So NCCN says both the options. EAU guideline says it as a part of multimodality. And this patient actually underwent RARP. The Gleason score came back as 4/5. There was also 2 nodes positive in this patient. However, 1 month PSA was 0.08. Uses 2 to 3 PATs. That was too early to say because it was just 1 month. So Dr. Sanjay, now that this time you want to observe or you want to subject him to adjuvant?
Observe, but tell him that during his lifespan, he is going to need every treatment that is there in the pipeline. Yes.
Okay.
When we use it is the question rather than if we need to use it. So 2 lymph nodes, 2 or less than 2 is where I would put a mark and say, let's keep an eye on the PSA. Early salvage radiotherapy would be, along with ADT would be my option.
Dr. David?
I agree with sir. So that's our practice as well. We will put this patient on ADT alone. And
sorry, for ADT alone?
So you would also wait and give salvage RT, right?
Early salvage.
Early salvage RT. Dr. Arpit, any role of ADT alone at there because of lymph node positivity? There are 2 lymph nodes.
I think in this scenario, both the adjuvant RT and the early salvage RT are the options.
Okay, so no ADT alone, right? So now PSA at 3 months is 0.1. It's still not 0.2. Dr. Sanjay, again, your call.
The evidence is that earlier the better, but still I would not give him.
Okay.
Yes. The reason is those were all on very, very small values of, as in, we haven't validated the micro-sensitive or ultra-sensitive PSA in a post-radical prostatectomy setting.
Absolutely.
So I would rather not push in just now.
So these are the 3 trials, RAVES and radicals. These trials are there, which says that early salvage is actually better. Also in terms of there's no difference in oncological outcome there. Also it is better in terms of side effect profile. But if you this is the evidence for this early salvage versus adjuvant RT. But if you see these later on, because we'll have shortage of time otherwise. At the end, you can give your point, please. So, however, these trials were, 80% of the patients were low risk. There were no significant high risk factors. These factors which I've mentioned here, T3B, ISUP, grade 2, positive margins, and this patient, these factors were there. So, although our practice is to give early salvage RT, but it would not be a bad idea for these particular patients to have an adjuvant RT as well. So, okay.
So one more thing, in this particular patient, the number of pads that he's using is still 2 to 3. So we would like to wait.
That is another point. We usually give radiation when the continence comes up. So it's a hypothetical situation. If the patient is continent and when the Amitabh is here doing a lot of radius pairing at 1 month, continence is good. So that situation. So N plus disease, Dr. Sanjay was talking about it. So this patient has 2 lymph nodes positive. So what is the choice for these 2 lymph nodes? Your choice is observation for two lymph nodes, Dr. Sanjay, you said? Dr.
Yeah, until the PSA tells me that it's
progressing.
Yes.
Okay. And Dr. David, your choice? Dr. Arpit, your-
prostate patient, we tend to give ADT.
In node positive area, two lymph nodes.
2 lymph nodes positive.
With these parameters, you will give ADT and you will observe. What is your choice?
ADT along with RT.
ADT along
this
with
particular patient.
for this particular.
Margins are positive and multiple pathological parameters are also favoring the risk of progression.
So see, it has been discussed in various papers. Firas Abdullah has written a paper. This has been given in EU guideline also. There are 2-3 things which you should see. One is what is the PSA value after the surgery. Okay. So like Dr. Sanjay said, and then what is the Gleason score, final Gleason score, and number of lymph nodes. If it is just 1 to 2 lymph nodes, okay, and it's a Gleason score of 2 to 6, you can observe. Okay. If it is T3B disease or more number of lymph nodes, then observation should not be done. For T3B disease and with one or 2 nodes and Gleason 7 to 10, it is better to give ADT plus RT both. If it is more than 3 to 4 nodes, then ADT alone. Then RT will not help. So both the extremes, either 1 to 2 nodes, very low Gleason score, and a PSA of less than 0.1, RT, even 2 nodes are there. You don't need to give RT, you can observe it. More than 3 to 4 nodes also, you don't need to give RT, give ADT alone. In between, you have to combine both. The benefit is both in that.
So for this particular patient, if we do a MSKCC nomogram study, so the biochemical recurrence risk is very high.
Yeah.
So definitely we at least do not observe this patient.
No, this patient is T3B, and
Along with all 12 courses.
this patient, I would personally go ahead and give it additional therapy. Because T3B and Gleason score, final Gleason score was 9. So this is just I'm taking a scenario. Suppose at 4 weeks, initially the PSA was 0.08. Now it is 0.3. Dr. Manoj, I'll come back to you. Usually the studies, what they have evaluated is that after for this basically becomes a persistent PSA. At 4 weeks, it is not 0.2, less than 0.2. So the studies have evaluated, cases or patients with initial MRIs and bone scans, not with the PSMA PET scans. So I just want to know from you that what is the correlation of the PSA value with having a PET scan after once there is a persistent PSA, and how often do you localize the if there is a persistent PSA and the PSMA PET has not been done initially, how often would you localize the disease on PET scan?
But I think irrespective to the state of doing a PSMA scan initially or not. So we are dealing with a scenario where
If the PSMA PET scan has been done initially and at 4 weeks PSA is 4.3, you would do a PSMA PET scan again here?
Sir, I think if it is making a difference in your clinical setting, like if you want to give a local radiation or you want to look for the other site of metastasis with the PSA value 4+, definitely you look for the site of metastasis. So it will going to change your management. So you need to look at where the site of metastasis are there.
Okay.
So probably yes.
Because my understanding is, because I try to read literature on this. If it has not been done, it might change your management and you will tend to localize the disease, and more than half of the time it will tell you this thing. But if it has been done just 4 weeks back, I don't think after 4 weeks the PSMA PET would be able to help you that much in localizing the disease.
So probably I think you need to look for the site of residual disease. So either you have, if the surgery has been done, maybe done somewhere else, either you have missed something significant amount of disease, maybe you have missed. Most of the time what we see, the lymph nodal metastasis in the mesorectal fat or in the obturator fossa. So these are the common sites where the lymph nodes are being, because these lymph nodes are normally 5 millimeter or less. So you tend to miss these lymph nodes. So probably if you want to look at the site of metastasis, yes. So like the another scenario, you have not done a PSMA PET scan before. Now, if the PSA value is high, so if it is more than 3, then based on the PSA values, your detection rate get varies. So the highest detection rate is when the PSA value is more than 2. as you come down to the PSA value, your detection rate goes down. So if I say that the PSA value is more than 0.5, you have a detection rate of somewhere around 60%. So 0.2 to 0.5, you have a detection rate of somewhere around 45 to 50%. So probably, you will have a less detection rate, but above 0.2, you will still pick up a disease in 50% of cases.
Okay. So the lower slide shows 67% of the times if you do a PSMA PET, you can actually localize the disease.
So this is irrespective to the PSA value. Overall, you can detect a disease in almost 67 to 70% of cases.
So in this case, Dr. David, RT alone or RT plus AD? I actually had one more scenario after that, but I would stop here because of the time. So just the last question to you.
So this is according to my presentation. EAU guidelines do recommend RT plus short-term ADT because of the high risk, the T3B status and high Gleason score.
Okay. So RT plus ADT.
short-term ADT,
Right.
6
So
months.
thank you. So last question, Dr. Garima, I want to ask you. It's a practical thing. Usually we don't do genetic testing at upfront, at the time of diagnosis. We tend to do it once a patient is having metastatic disease or a CRPC disease. So do you think sometimes it may be an issue that you don't have that quality of tissue because biopsy has been done years earlier or the surgery has been done earlier, so the tissue is not there? Do you think you're able to make out from that much tissue, or we should do it at that time? Secondly, because the patient may have undergone number of therapies, may have drugs or radiation or other treatment also. If we want to take a new tissue at that time, would that be okay, or that would not give you a true picture?
Good, because when we are looking for HRR, this is an early change. So you will pick up only even if you use archival tissue. Bone tissue and lymph node tissue is not preferable, because bone is because of the fixation issue, and lymph node because the background cells are so much, they give us so much DNA that it interferes with the DNA testing. Otherwise, we prefer fresh tissue, but if it's not available, we can also go for archival tissue.
Okay. Thank you so much, everyone, for the session. Thank you.
That concludes our session on prostate cancer. I'll thank Dr. Punit Ahluwalia, sir, for moderating the session so excellently. Thanks to all the panelists and the chairpersons. Moving on, we'll start with our session on kidney cancer. I'd like to call upon stage the chairpersons, Dr. P.N. Dogra, Dr. Shiva Shankar, Dr. Vipin Tyagi, Dr. Sunil Pasricha. We have refreshments outside. So if anyone is interested, please do join us. I'll ask one of the chairpersons to call upon stage the first speaker.
Yeah, welcome to this session. I think we are going to have some change, and you'll see some mesmerizing video in this session. And the first one is by Dr. Janil Kumar. He is going to talk as well as show us some video on the retroperitoneal approach to the kidney and the adrenal tumor, the technique. Dr. Janil.
Thank you, sir. Thanks to RGCA team for inviting me for this fantastic program. First of all, a lot of our audience will not be knowing about what is retroperitoneoscopy, because we surgeons know what it is. Basically, when we are approaching the organs like kidney, we are regularly going through the peritoneal cavity because it is easy to access there by cutting peritoneal cavity. Retroperitoneoscopy is an approach without going through the peritoneal cavity, creating space behind the peritoneum and elevating the peritoneum and creating a space and then proceeding with the surgery. So which are the important structure where we do retroperitoneoscopy? When there is difficulty to enter the peritoneal cavity like previous surgery, or when there is posterior tumors of kidney and structures like right adrenal, where the adrenal is behind the liver,
it is easier to access through without entering into peritoneum through the retroperitoneum directly. So I am presenting a few cases, videos of retroperitoneal. First, I'll discuss about the approach. So this is the vision from the anterior side. If you're looking from behind, the orientation is entirely different. That is one of the issue with retroperitoneoscopy. Second is the difficulty to make the space. Why majority of the people are not doing retroperitoneoscopy is because a lot of us doesn't have experience during our training days in retroperitoneoscopy. How I started was with Gore's technique. This technique is discussed or introduced by an Indian surgeon, Dr. Gore from Mumbai. He actually used a red rubber catheter with a glove finger at the tip, like a balloon, and used it to create the space. Now we have ready-made balloons available, and which is easier to use for creating the space. Usually in the kidney and adrenal, we approach through the lateral decubitus like the regular transperitoneal approach, but from behind. The port placement I have explained. Most important thing is the camera port, which is inferior to you in the mid-axial line, below the the costal margin. And other ports are put in a straight line, from the renal angle to the lateral rectus. Another port for working port can be put either at the petit triangle lower or just above the anterospheric spine or below the costal margin anteriorly. One of these places according to where the retraction is required. So recently we changed the technique. We usually use the ready-made balloon for creating the space. And how I create is using a VC port, enter into the retroperitoneum under vision, and use the balloon for creating the space. So this is how the balloon is used. This is made by Covidian, and air is insufflated. Instead of it, you can use red rubber with a balloon at the tip or a glove finger at the tip. So these are the balloons, different instruments available for retroperitoneoscopy. These are the balloons. And this is actually a special type of trocar with a balloon at the tip. This is not available currently. So when you are using the balloon, this is the camera introduced through the balloon dissector, and this is the vision inside. Majority of the case where patient cannot afford, I use the camera tip to create the space. I'll just show a video of retroperitoneoscopy for a partial nephrectomy. This is a very difficult tumor, hilar posterior. Another issue is multiple vessel. There were 3 vessels to the kidney. So 2 issues, posterior tumor, fairly large tumor, and 3 vessels. This is the camera placement, 3 ports in a line. This is for camera and this is for assistant port. And through this camera port, I introduce as a port-in port, I introduced the robotic port. And this patient we created without using balloon, just with the camera itself, we created the space. So after creating the space, we have to put the rest of the ports. This is the retroperitoneal space created, and assistant ports are also in. Altogether, 5 ports are introduced. One for camera. This is the first step is to dissect the gerotas. This is the gerotas fascia. This is dissected off from the muscle. Then we raise the vessels and the ureter. So this is the complicated. So what I want to show is even complicated surgeries can be done in the extrapectoral retropectoral route. There are 3 different arteries. One large lumbar was there. I used a robotic clip applicator because it is easier to manage ourselves rather than giving it to the assistant. And all the 3 vessels are looped. Rest of the surgery is almost like a transperitoneal approach. We loop the vein also. Under this is the robotic ultrasound used to mark the edge of the tumor, and we assess the depth of the tumor also with the ultrasound. Then we clamp the artery. We usually use indocyanine green to check the vascularity. We saw that one of the blood vessel was not properly clamped. So again, we use one more clamp to stop the blood flow to the tumor. And the tumor is removed without any macroscopic positive margin. So the fossa was sutured in with a barb suture, and duovical was used for closing the kidney, and the clamp was released. This is very useful in posterior tumors. So next is an adrenalectomy. Adrenal advantage is if the adrenal is dipping into the hilum, it will be very difficult to access in with the laparoscopy. Majority of adrenal retropectoriscopy we do with laparoscope, but if it is a large adrenal, if it is difficult to access over the renal artery, it is better to go with robotic surgery. So first is to trace the psoas. Second is to identify the renal artery and dissect the IVC above the renal artery. Then climb over the renal artery and lift the adrenal from the psoas. So you just climb over the IVC above the renal artery. So I'm using another retractor by assistant to lift the adrenal because sometimes it will be difficult to see the area. So over the IVC we can climb. This angulation we get better in with robot. Right side. So left side, I usually go for transperitoneal because the adrenal is draining into renal vein, and there is no advantage for a retropectoriscopic approach. So this is actually behind the liver. This dissection is easier with the robot, and robotic clip applicators are very useful in this area because the adrenal vein is very short. So we draw from the liver area. Adrenal is dropped and completely removed. So even a large adrenal, this is a 9 centimeter adrenal, we approached through the extraperitoneal or retroperitoneal route. You can see that the lesion is behind the liver. Initial dissection, we use laparoscopic instruments to create the space. After adequate space is created, this is the robot docked. And as I told, renal artery is identified, the renal artery, and it dissect above the renal artery over the psoas. And anterior dissection is done, and tumor is dissected off from the liver. Anatomy is slightly different from what we see in the transperitoneal route. So this surgery would have been very difficult anteriorly because liver is completely in front of the tumor. So this is the adrenal vein that is clipped. And the 9 centimeter lesion from behind the liver is completely removed. So we have approached adrenal in the posterior approach, that is by prawn, like doing a PCNL. This is the port placement. This is the paraspinous muscle plane, and lateral to this the mid axillary plane. The ports are in between that. So initial dissection, as I told, is using the laparoscope. And after space is created, we put the robot. Why we did for this approach is this patient had a liver transplant and later had presented with the adrenal lesion. We were not sure whether it's a recurrence of the tumor or adrenal lesion, and they want a biopsy. So since it is a solitary, we proceed with adrenalectomy. So this is the dissection from behind. This is the diaphragm, which is dissected off from the adrenal. So here there is no other structures just behind the muscle. Is only the retroperitoneal structures. So you cannot make any other complication unless we are going directly into the great vessels. So, and it is very unlikely because it is guarded by the spine. When you are, this is the adrenal vein that is clipped. Only thing is the orientation of anatomy. We have to be very versatile in identifying this is the kidney dissected down, and 2 vessels, both the vessels were clipped. And the adrenal was removed. So these are the different, this is the option we have when it is very difficult to approach from anterior aspect or in particular scenario like posterior tumor of the kidney. Thank you very much.
Well, thank you, General.
Thank you, sir.
You are really genius. It's nice to see this difficult situation. And I think with the robot, you make the things.
Robot is very useful for
better.
extraperitoneal. We could do RPLND also with the robot extraperitoneally.
But certain people I find, especially in our department, Dr. Rajiv Kumar, he's doing quite frequently adrenal tumor. So he doesn't like a robot. He say, I am comfortable with the laparoscopy.
Yeah, I also initially thought like that, but dexterity of robot is very useful once you are used to. Because why? Because we have to put one more port. More space is required for putting the robotic arm. That is a difficulty in robotic surgery. If you create space, this is easier than laparoscopy.
Yeah, naturally, you need to have then orientation. Yeah. Because you're doing in a lateral or you're doing in from the posterior approach, one need to have orientations of the tissue.
It is very easy to shift from laparoscopy to robotic in
since you are expert in retroperitoneal, so you can do it.
I've seen
The one
you
who is
say doing extraperitoneal
Yeah.
prostate.
The one who has not been into the retroperitoneal space, for him it will be night.
It's very easy.
Yeah.
Thank you, sir. Yes, sir. Hmm. So I actually, during laparoscopy days, I used to hook, but that is, I think that whatever the instruments is dissection and this one, how you understand the anatomy is more important, sir.
Yeah. I think it all depends on the surgeon. If the surgeon is good, you give him anything, he will be able to do. So it's not an issue. Yeah.
Thank you, sir.
Thank you. Move on to the next, please. Go ahead.
So next we have Dr. T. Kishore. He will be speaking on the robotic IVC thrombectomy indication and technique. Over to you, sir.
Thank you. Respected members of the chair and audience. So, just to be on the same page, the classification of the IVC thrombectomy, we say is the level 1 on the renal vein, level 2 into the IVC infrahepatic, level 3 suprahepatic, and level 4 is into the atrium. So suprahepatic level 3 is divided into 4 phases. Like 3A is intrahepatic, B is hepatic, suprahepatic, and supradiaphragmatic, but infraatrial. So first IVC thrombectomy was done in 2011 robotically, and subsequently, like many people have really ventured into this, and multiple series have been published. Especially more of the publications have come from China and then US also. So why robotic approach? Because in open prostatectomy, open radical nephrectomy, you need large incisions. You have constant ooze because of the collaterals. Where it bleeds from the collaterals, it bleeds in a torrential manner, and it's also difficult in control in renal artery upfront in many of these large masses. And again, post-operative pain, difficult to mobilize the patient, delay in instilling the systemic therapy, and wound-related complications. These are all problems with open surgical approach. So the idea of doing robotic surgery is that you need to perform a safe surgery with less blood loss and reduce the post-operative morbidity without affecting the oncological outcomes. So what I've seen is that with robotic IVC thrombectomy, when you do that, it's easy to tackle the lumbar veins. Especially on the right side, we get very early access to the renal artery. Then we have reduced venous bleeding from the collateral because of a certain amount of tamponade, which due to the pneumoperitoneum. And you get secure control of IVC upfront during the dissection itself. And the nukes and corners, difficult area to access like adrenal fossa are easily accessible. So the concerns, what happens if there is emergency bleeding, if tumor ruptures or like the thrombus is spilled over, and also the clamp time while you're clamping the IVC. These are the concerns. So when you're embarking upon such a procedure, we should have an open set. You have a vascular surgeon and bedside surgeon backup and adequate blood products, and plan to dedock if there is any emergency. So the initial cases should be ideally a level 1 and level 2 without much desmoplastic reaction around the tumor, with no infiltration of the tumor to the large vessels, with no big humongous lymph nodes or adjacent organ infiltration like liver and pancreas. So initially we did first IVC thrombectomy in 2015, a level 2, and then eventually we did level 3, and now we are doing level 4 also. So we have done few cases. Total robotic approach for renal cell carcinoma. So this is a 71-year-old female who had a weight loss. She had a thrombus which was extending onto the IVC all the way up to the atrium. And it was just projecting into the atrium. It was not involving that. So we started the procedure for the left radical nephrectomy first. And the patient was placed in the left lateral position, and then started dissecting the colon. There was a huge mass, and you could see large collaterals traversing between the plane between the gerota and the mesocolon. So we can do a preoperative embolization, especially in the initial period. I generally don't do, but I've done in certain cases. That can reduce the bleeding during this dissection. Here, as routine radical nephrectomy, we are just lifting up the ureterogonadal complex, and the IVC is being dissected. The right renal vein is being dissected, and now the right renal artery also will come into the play. So the right renal artery is being clipped with 2 hemologs and divided. And then comes the stapling of the right renal vein. Here, left renal vein, left renal vein. So this is stapled along with the thrombus. And further, the dissection was continued into the adrenal area. Then we realized that the mass was infiltrating into the pancreas. So we stapled the pancreas across. And then the mass was taken out through a fan and steel incision. The pancreatic edge was reinforced with proline sutures. And at this position, juncture, we started dissecting the left lobe of the liver. So the left lobe was dissected in the left up position. And the IVC was exposed all the way on the left side. The gastrohepatic ligament that was divided. Now the position was changed to the right side, and the stump of the left renal vein was lifted up from the right side. And then the right renal artery was identified in the interaortocaval region. And the right renal vein was looped. And then we started mobilizing the right lobe of the liver. This was done by a hepatobiliary surgeon. And the short hepatic veins were divided in between. So then we dissected all the way onto the IVC on the superior aspect. And position was changed to supine. So here, just in supine position, the falciform ligament was divided and IVC was tackled from the superior aspect. And both sides of the suprahepatic IVC was dissected, the right and the left side. And an infant feeding tube was looped around the IVC. Because suprahepatic IVC is more robust compared to the infrahepatic, so the loop may not be good enough to tighten that. That is why in this place we use the infant feeding tube. So the IVC was looped around. So we need further access to approach a level 4. We need further access to the thorax actually. So what we did was we divided the central tendon of the diaphragm. And then in this case, we got access to the atriocaval junction where the tumor was, tumor thrombus extent was there. So this will expose the tumor. So in certain cases, if the thrombus is extending more, we can divide the central tendon even further up and also divide the pericardium also. So the pericardium is being divided, and you can loop the IVC at the junction of atrium and the intrathoracic IVC. So this is one case. So here we are looping the IVC. So this is useful not for large thrombuses, only for thrombus which is just jutting into the atrium, so that we can practically squeeze the thrombus out. So you don't have to have a cardiopulmonary bypass. So there have been 2 case reports, one from US. Actually, they did an angiomyolipoma. It's almost a similar case with the thrombus. Now we started, we controlled the porta with the Foley catheter, and then the infrahepatic IVC was controlled. The right renal artery and the right renal vein was controlled. And next comes the porta. Porta was tightened. And now we had a transesophageal echo, the real-time transesophageal echo. So we monitored the thrombus through that. And we also used a drop-down ultrasound probe. So this helped to basically delineate the extent of the upper extent of the thrombus. And then we squeeze the thrombus into the suprahepatic IVC, and so that we could see the thrombus coming out of the atrium. And then we proceeded with the excision of the thrombus. So this was actually very tiny thrombus compared to the size of the lumen. So it came out quite easily. It was not occupying the complete lumen of the IVC. And the staple line was excised. And the thrombus was placed in a bag. And another control was taken in the infrahepatic IVC. And then the suprahepatic clamps were released. The porta clamps were released. And we checked again with the transesophageal echo, make sure the thrombus is completely removed. So then it's like a routine IVC thrombectomy is start suturing with the 5-0 Gore-Tex from one corner and then into the other corner. So there have been cases where there were infiltration to the IVC where we have kept small patches. Graft I haven't done so far. For IVC replacement has been done. Some of the Chinese studies, they say the IVC can be stapled quite safely. Again, I don't have much experience. Now the clamps were sequentially released one by one, and the incision we made in the suprahepatic region, that is the central tendon of the diaphragm, was sutured with the use of a 20V lock. So maximum experience with the level 4 thrombus has been with China with this technique. And in the US, what they have done, they have used 2 robots, one robot to do the intra-abdominal part and the second robot to control the intrathoracic part. So the diaphragm is being closed and reinforced with the hemolock clip. So the total operative time was about 7 hours and console time was around 5 hours, which you lost some time with the positioning. And IVC clamp time was around 11 minutes for the porta and about 23 minutes for the renal clamp time. And blood loss was minimal, barring during the nephrectomy, we lost some. And the patient recovered quite well with a T4 lesion, a Fuhrman grade 2 lesion. So these are the 2 reports that about like level 4 IVC thrombectomy was done, one in 2020 and about 7 cases from China. So this was an ideal case for like a robotic approach, minimally invasive approach. There are certain cases with large lymph nodes with extensive desmoplastic reaction. I have ventured into that, but eventually had to abort that. So this is our own experience, multicentric experience from India, where we published 4 or 5 centers, we published our old data. So I think the patient selection should be based on the extent of the disease, the experience of the surgeon, and you have to have all the equipments in your armamentarium like intraoperative ultrasound, a transesophageal echo, probably an ICG, everything, and with an adequate vascular backup. Thank
you. This is one of the most challenging procedure, I think, in the urology. What I was wondering, you are not taking the help of a liver transplant surgeon or the cardiac surgeon. You are done yourself.
The liver mobilization was done by the liver surgeon, liver mobilization. Supradiaphragmatic I did because our cardiac surgeon don't have it.
No, you were standby cardiac surgeon?
Yeah, cardiac surgeon stand.
Because the younger people are here, they will think that they can also take me like that. It's not that easy. Also, what he was doing, he is a very experienced person. But you need to have the support of this cardiac surgeon and the liver transplant surgeon. Without that, please don't attempt to do this procedure. Thank you.
I'm always worried, especially when you dismember the whole kidney first. Because that is the point where, because the intrathoracic pressure is, low, you might get the sucked in, if not necessarily into atrium, but on other renal vein. That's the danger, which is, we also attempted this, but, and again, that portal vein thrombus, portal vein time. The hepatobiliary surgeon was saying not more than 10 minutes.
Okay.
If you take it more than 10 minutes, he will have problem with the liver.
Okay. No, we have had cases where, open cases where we had like up to 45 minutes and patients have recovered. Graft and patch had to be completed. But 10, 11 minutes, even this patient didn't have an acute liver injury because 11 minutes were quite well tolerated in my experience. I think 10 is too much of a.
Because that's what he always of that. He said,
so
then there'll be problem.
Yeah, but
And
how
also the amount of desmoplastic reactions around there, because it is the long-standing thrombus. So these are the Waterloos where we have to be.
desmoplastic reaction, the only way to tackle is that you staple across the IVs. Otherwise it's very hard. It's very hard. So,
but very well. Thank you.
So next talk will be by Dr. Aparna Dhar, who is from Max Healthcare. So from surgical techniques to now molecular aspect of RCC. Over to you, Dr. Aparna. You have to unmute yourself, Dr. Aparna.
Can you guys hear me now?
Yeah, you are audible. Please go ahead.
All right. Good afternoon. Sorry, good evening, everybody. Apologies could not be there in person, but thank you, Dr. Talwar and organizers, for giving me a very difficult topic, but a very interesting topic, which is to shed light on the molecular aspects of renal cell carcinoma. I've got quite the task set forward, so let's get started. So what do we know about renal cell carcinoma? So we know that renal cell carcinoma originates from the renal cortex and is responsible for around 80 to 85% of all primary renal tumors. Cloning of susceptibility genes that are involved in familial predispositions has offered, entry points into the signaling pathways that are upregulated, especially in our sporadic RCCs. And sporadic RCCs are, interestingly enough, very heterogeneous and are classified into various histological subtypes. And because they're so heterogeneous, what really separates RCC, from our biological understanding of other GU malignancies is that there are obviously a lot of classifications, around 7 of them. And just very roughly, we've heard about renal cell, about clear cell carcinomas, papillary type 1, papillary type 2, chromophobe, we've heard oncocytic, oncocytomas, which is technically benign. And then you've got your angiomyolipomas, your translocation-based RCC, medullary collecting duct, etc. And what's very unique is that to all these histological subtypes, the genotyping, the reflection of what sort of genetic, somatic changes are coming about is very unique and very different. A lot of these are also the histopathology classification can actually help us identify if there could be a potential hereditary genetic predisposition, because some of these, like clear cell, is associated with VHL, which is one Hippolindau. We see MET with our papillary type 1. You've got with your Brit-Hog Dubé, you've got your FLCN genes. So all of these histological subtypes help us assess and understand if there could be a potential underlying hereditary syndrome. And sometimes when we kind of go the other way, which is before the subtype, if you have a good family history, for example, it doesn't always have to present as kidney cancer. It could also be something as a really strong family history of women having uterine fibroids at a very young age. And we know that's associated with our familial leiomyomatosis and RCC, which is the FI gene. And these familial subtypes, or the pathological subtypes, the genes that are associated with it, some of them even have targetable options. So it becomes really important getting a full idea of what's happening in your patient's tumor. Now, because we know that these cancers are very heterogeneous, what are our molecular targets? And this was a lovely study Sorry. This was a lovely study that came out from the MSKCC group. And what they did is that they harnessed the power of next generation sequencing to help categorize the landscape of actionable alterations in RCC. They used the MSK impact panel and they analyzed around 38,468 patients' tumor samples. And out of this, around 753 patients were actually known cases of RCC. And what they did is that the data from the NGS was stratified into levels of evidence based on OncoKB and clinical data. And in addition, they also evaluated the immune checkpoint blockades like your MMR, MSI, and TMB. And these were, analyzed separately. What was very interesting, unlike other solid tumors, is that none of the targetable alterations, they were the least targetable oncogenic drivers that were found, was actually in our renal cell carcinoma group. And unlike other solid tumors, none of the targetable alterations were identified in RCC actually consisted of FDA recognized that was the level 1 biomarkers, and most of them, over 80%, were around level 3B, which originated from studies in other tumor types. And majority of these individuals that were here were essentially your clear cell histology, which we know compromises and the maximum number of RCC, so it was around 60% papillary was coming in second at 8.6, chromophobe at 5.7, and then you had the other subtypes which were associated with SDH, FH, etc. Notably, what was there, majority of the patients with stage 4 disease, around 62-63%, and around 36% actually originated from the metastatic side. And the prevalence of targetable alterations were compared, as per the histological subtypes. Although the chromophobe tumors appear to have the lower prevalence of actionable alterations, there was really no significant difference that was observed in the rates of actionability across these different tumor types. Because you had your TSC1s, your PIK3CAs, your METs, we do know that TSC1, your PIK3CAs are part of the mTOR AKT PI3K mTOR pathway, which means mTOR inhibitors were an option. And I'm going to come to the molecular alterations in a bit. What I also want to stress on is that, interestingly enough, in the MMR MSI cohort, a very small percentage of them actually showed overexpression, which showed that these genes could potentially be targeted with those biomarkers of MSI and MMR. So, what are our molecular targets? Now, the first one, and the most important one in all of this, is our VEGF access pathway. So we know abnormal cells are related to angiogenesis, appear to be frequently related to tumor hypoxia, which is caused by an uncontrolled malignant proliferation contemporary to a poor prognosis, a poor expansion of a vascular bed. Now, among the pro-angiogenic factors, the vascular endothelial growth factor, which is your VEGF, is the pivotal heparin-binding polypeptide that modulates the angiogenesis by interacting with the tyrosine kinase VEGF receptor. The synthesis of this VEGF is induced by hypoxia, and the VEGF signaling pathway appears to be upregulated, and a well-known implication in our RCC tumorigenesis. And notably, what we see is that because in VHL genes, while 90% is sporadic, or even if 5 to 10% is hereditary, the inactivation of this particular tumor suppressor gene leads to accumulation, and this was the most common gene that we see, leads to accumulation of hypoxia-induced factors like overexpression of VEGF, and patients, which have, so because of that, we actually know that VEGF inhibitors like sunitinib are good targets to consider. The second is the mTOR pathway. And as we saw from the MSKCC study, that the pathway is overexpressed in our RCC cohort. And mTOR pathway has a very significant role in RCC. And because of the activation of this axis, essentially what you're doing is it provokes the upregulation of hypoxia-induced factor 1 alpha, which is HIF1 alpha. And this transcription factor actually helps regulate the expression of various genes, like your VEGF being one of them. And because there is an overexpression, it adjusts the mechanism to hypoxia, such as angiogenesis, apoptosis, and even leads to tumor metastasis. So preliminary data that's, there's actually looking at the efficacy of if you could actually block this HIF1 alpha in a heavily pretreated clear cell RCC. There is a drug by the name of what is it called? It's called belzutifan, if I'm pronouncing it right. And there's been interesting phase 1 clinical trial data that shows that it does kind of inhibit anti-tumor activity, very promising. Now, in addition to that, we've got other hereditary syndromes, and this is why I was focusing on germline in my start of my talk. Cowden syndrome is driven by a germline P10 mutation. This you can target with an mTOR inhibitor. Similarly, we know tuberous sclerosis complex, a TSC, either TSC1 or TSC2. This too can be inhibited with an mTOR. Then you Brit-Hogg-Dubé, which is essentially FLCN. Again, there is limited data, maybe not ideal, but where mTOR can work. My third important pathway is a MET pathway. MET is synonymous with a papillorenal cell carcinoma subtype. MET, the mesenchymal epithelial transition, or the hepatotype growth factor receptor gene, it encodes for the TK, for the tyrosine kinase receptor of the hepatocyte growth factor, which is normally overexpressed. So when it's mutated, this TKI causes the activation of the RAS-MAP kinase and the PI3K-AKT pathway, which leads to tumor growth and malignant cell proliferation and metastasis. So this MET proto-onco gene is commonly described in our germline hereditary papillary RCC. Sporadic is around 13 to 20%, and this can actually, the target that we use for the MET HGF axis, which is activated, are agents like cabozantinib, which is recommended. Fourth, and the most important in RCC, are our immunotherapy. Now, we've got several trials that have actually shown that RCC is a tumor with mild to high % of somatic aberrations. But what's happening is it's leading to overexpression of neoantigens, which in turn then leads to high immunogenic power. And there are various biomarkers, that are potential biomarkers that can help identify patients who are good candidates. So I'm going to start with PD-L1, something that we're very comfortable with. And I'm going to be focusing on 2 key studies throughout this: the Javelin Renal 101 and the Checkmate 214, that really deep dive into the potential immunotherapy biomarkers. So in the Javelin Renal 101, in the Javelin Renal 001 trial, they looked at the PD-L1 expression, and they thought that if you have a patient with a raging high PD-L1 expression, maybe they're going to respond better to immunotherapy. And this really isn't how it panned out, to a certain extent. If you look at the data and the PD-L1 positive group, and then they tend to fare just as well as the PDL overall group. So you really you don't really see a very meaningful difference whether or not you're PD-L1 positive. Now, in the Checkmate 214, one can make an argument with the Javelin, I forgot to add, that both the arms were getting a VEGF inhibitor. So you're not going to see a major significant difference in the PD-L1. However, in the 214 trial, it was a pure immunotherapy study where they looked at 2 different ways of actually assessing PD-L1 expression in tumor cells. And outside of tumor cells. And what you see here is ultimately that irrespective of whether the PD-L1 is high or PD-L1 is low, you actually saw a benefit of nivo-ipi versus sunitinib, just a standalone sunitinib-based therapy. And what about the combined positive scores, which actually looks at both the tumor cells and the surrounding environment around it? And if you look at this population again, what you saw is that there's really no meaningful distinction in terms of clinical outcome based on PD-L1 high or low. Another very exciting biomarker over here is inflammation gene signatures. And this data actually lends itself to a study that looked at a VEGF inhibitor like sunitinib and compared it to, where did it go? Yeah. What this study did, sorry? Sorry, do I continue?
Yes, you can go ahead. You have still 2 minutes.
Oh, okay. Thank you. So this was another very exciting study that came out that actually looked at the role of sunitinib, which is a VEGF inhibitor, and compared it to atezo. And what they did in this is that it was interesting to see as to how they went and they divided these groups into, it was a 300 patient study, and they divided it into the angiogenic driver group, a myeloid inflammatory group, and an immune antigen representation group. And this was based on the T cell profiling. Now, what was amazing about this was a very clever way in which they divided the cohort. So you could actually pick out patients who would have an angiogenic profile and would actually benefit with sunitinib. And you could further subdivide based on the T cell based on the T cell profiling into groups that might respond to immune therapy by itself, and then the T cell effector high group, which had a myeloid inflammation category, which could potentially benefit either from a standalone immunotherapy, or they could benefit, I think this actually better explains it. So in an angiogenic specific, they would respond well to sunitinib. If the T effector cell was high, but the myeloid inflammation was low, these patients did really well with standalone atezolizumab, but where the T cell, which is a PD-L1 inhibitor, and in the case where the T effector was high and the myeloid inflammation was high, the immune was completely suppressed. So you needed a combination of both your VEGF and immunotherapy. And the last signature that I just want to highlight before I wrap up is, they're kind of controversial, but they're also very interesting from a prognostic factor, is the PBRM1 and the tumor mutation burden. And this was an interesting study with 100 patients who got Nivo-Ipi either in the first or second line. And what they saw is that based on the tumor mutational burden, the folks who benefited versus the folks who did not benefit with immunotherapy were not directly correlating to the tumor mutation burden. But what really stood out was in all of this assessment was the PBRM1 mutation, which was present. And what it said was that in the presence of a PBRM1 mutation, it was a biomarker that was prognostic, that evaluated immunotherapy response. In its presence, the patients would have a good response to immunotherapy versus those in its absence. And that's what we also see down here in these box plots. What was a contradiction was that in the Javelin study and in the Checkmate 214 study, the PBRM1 gene did really not show that much of a benefit in highlighting if a patient would respond to immunotherapy. But there are other studies like this particular one, which did further highlight where they put patients within the immunotherapy group and standalone VEGF group. And what they saw was that in the group where the patients did have a response to immunotherapy, there was a very slight influence of PBRM1, but what was very important that stood out, in the presence of a TERT promoter, these patients did not have a good response. There's a lot of great studies that are showing that the microbiome, depending on the response as of the type of overproduction or underproduction of certain bacteria, can predict the response to immunotherapy. In some cases, overtreating with antibiotics, like in this study, can actually inhibit your patient's response to immunotherapy. This is, again, all experimental. But I think this is where we are. There is some great work happening in the realms of renal cell carcinoma, a lot of great potential biomarkers. VEGF, TKIs, mTORs, your MET are clear. We know TMB and PBRM1 are still slightly experimental, but the more we do NGS in kidney cell, in renal cell carcinomas, I think the more we'll have a better understanding as to how molecularly diverse and potentially identify more targetable options. And on that note, thank you very much for your patient listening.
Thank you, Dr. Aparna, for such a wonderful overview on such a difficult topic. If there are any questions, house is open for this. If there are no questions, then we'll move on to next topic. That is, I'd like to invite Dr. Piyush Bajpayee sir for delivering talk on how immunotherapy is making inroads in the management of RCC and how it is changing the landscape in the management of RCC.
A very good evening to all, and thanks to the organizers for providing me this opportunity. So my topic is how immunotherapy is actually changing the landscape, and my focus would be on the trial, one particular trial, which is pembrolizumab and axitinib combination, and that's the Keynote 0426 study. Thank you. So, shifting paradigms in treatment of metastatic RCC with immunotherapy, and there would be some basic slides, and I apologize that there would be, for this, very mature audience and gurus, I would say, some slides would be pretty basic, but then there would be some students, so there would be some learning points for some. So this would be the algorithm I would be going through: the epidemiology, the stages of RCC, and the guidelines, what are there, and the current treatment options, what are available to us right now. And of course, a highlight on the keynote 426. And of course, this would end with a case study. So talking about the epidemiology of RCC, we know that what Dr. Aparna was showing, the various the histological subtypes of the nephron, where from which RCC, various subtypes of RCC would actually, arise from. And 9 out of 10 would be actually renal cell carcinoma, out of which 70% is clear cell. So that's what it is. And another way of representing it is in this algorithm, how you can actually classify RCC on the basis of the cellular features, the architecture features, whether it is where is it coming from, the anatomical location, then the specific disease background, whether there was a history of acquired cystic disease, or molecular alteration like micro-ophthalmic transcription factor, or SDH deficient RCC. And then what Dr. Aparna also highlighted was the familial predisposition. So those are, various subclassifications where it is there. And talking about the clear cell RCC, which is actually one of the major ones that we are talking about today, is characterized by lipid and glycogen rich cytoplasm. So that's where it comes from. Talking about this in particular, and a lot of data for clear cell RCC is there. So this is actually ranked 15 somewhere in mortality among all cancers as per the Globocon data, and has the highest incidence and mortality in the Asian subgroup. So that's very important that in Asia, this is a big challenge. The total incidence worldwide was around 4 lakh cases, where males were more having this disease pattern as compared to ladies, and nearly 1,79,000 deaths reported. So this is the global distribution of the disease pattern. And the risk factors, as we all understand, that there are disease factors right from the rare genetic ones to obesity, the metabolic syndrome, being the most common one. And of course, there is a sex prevalence of it being more common in males. And of course, smoking is also attributing it over there. Talking about our subcontinent, our nation, prevalence over here, again, males are taking the lead over here, and median age being around the 5th or 6th decade. And clear cell RCC, again, it's quite so common as what we are seeing in the Western world. Around 7 to 8 out of 10 cases would be there. So again, going back to the basics, we know that these are the various stages where the excellent survivals are there in early stage. And stage 3, when we see that the IVC thrombus, the previous case, the surgical case, what the doctor was showing, excellent thrombectomy being done. So that particular case, and where the 5-year survival is around 30%. And as we go down further, stage 4, it was a very dismal scenario some 10 years back when these TKIs started coming in, and then eventually immunotherapy started coming in. So prognosis depends on the stage of histology of the cell type, and papillary is different and clear cell is different. So papillary type 1 would be a different, better prognosis, this thing, as compared to clear cell, which is around 5-year survival of nearly 70%. Again, the TNM, and this is what we know, so I would not delve into this right now. But yes, the NCC and what it is saying, and these are the various regimens available to us. Earlier, around 15 years back, it was only sunitinib to start with, what we had in hand. At that time, it was, one of the wonder drugs. And before that, of course, the cytokines, which we used to hear about. So it was like immunotherapy there. And then we used to read in Devita that some abscopal, some disappearance of disease pattern happening in, spontaneous regression happening. And then eventually, sunitinib came in. And then back to the journey of immunotherapy. So it has again started. So immunotherapy, TKI, and then immunotherapy again. So the interesting thing is that Modze et al., who actually presented the sunitinib data, he presented eventually, the keynote data. So what we are going to talk about. So favorable subset, when we are talking about the IMDC scoring stratification, so favorable and poor to intermediate subset, we see that even in the favorable subset, we have a category 1 recommendation currently for immunotherapy and VEGF TKIs over there. Although in the favorable subset, it is actually very hard to actually put away the VEGF TKIs. It is still a good option to consider that. Even active surveillance on the third column, you find active surveillance is still occupying a place in the NCCN guidelines. Poor to intermediate, well, here again, you would want to use your best armamentarium. Of course, depending on the patient profile, you would want to choose IO or IO VEGF TKI. So that would, of course, be there. And again, for a country like us, where not many can go for immunotherapy regimens, probably in future, many more can be affording for that, this would be more accessible. So sunitinib and pazopanib is a fair choice, and is also now being available in generic this thing. So this is an option. And of course, in certain circumstances when we are talking about certain specific type of RCC, we are also talking about temsirolimus. So that's a very rare usage though. So again, talking about principal systemic treatment over there. So for those who have not been exposed prior to IO therapy, so of course, IO therapy based options remain. And this is going to get more important, this particular slide, because now we have data from the keynote of 564 study, which is actually showing the adjuvant pembrolizumab coming in. So the benefit of overall survival being there for pembrolizumab in the high-risk RCC, clear cell RCC, we will get more patients who would have been exposed to the adjuvant immunotherapies and probably would have a metastatic disease. So this slide would be more relevant though at that point of time. So prior IO therapy, again, axitinib, cabozantinib, lenvatinib, everolimus, and tivozanib is an option, though not available in India, tivozanib. So again, systemic therapy for non-clear cell histology, preferred regimen, cabozantinib is one particular regimen, but again, the immunotherapy is permeating in this particular subset as well. So pembrolizumab, there are trials and successful trials happening now for pembrolizumab and cabozantinib even in the non-clear cell space. So we are going to talk about pembro-axitinib trial, which was actually published in NEJM in 2019, where it was comparing the standard of care, the sunitinib, and the experiment arm was actually a combination of IO and axitinib. So there are now other options, as we have discussed that, we have IO, Nivo EP, Checkmate 214, lenvatinib and everolimus were there, and evolumab axitinib is there, Javelin study. So talking about this particular study, and this is another slide to show how the various regimens have come in over a period of time. A lot of it crowding happening after 2017-18. So you can see a lot of regimens coming in over there. So different immunotherapy strategies, well, these have been there. As I spoke that, before 2000, these therapies of IL-2 and interferon were, discussed, though theoretically, a lot of it theoretically, but they were discussed. And now what we are seeing is a CTLA-4 and PD-L1 combination. So that's what is coming in. Future probably might have CAR T cells coming in. So this is how mechanism of action of IO is, that it is a PD-1 inhibitor, and PD-1, as we understand, is basically a break for these particular T cells. And when you release the break by actually blocking these PD-1, and then the green T cells, they start acting on the tumor cell on your right. So that's how the brakes are released and pembrolizumab works. On the other hand, the other drug which we are talking about for the Keynote 426 is the axitinib. This is a second generation VEGF, and it is a highly potent and highly selective VEGF receptor inhibitor for the tyrosine kinase 1, 2, 3. And basically, it was pretty popular after sunitinib, sunitinib failure, where a long VEGF inhibition was there achieved by sunitinib. So axitinib was used. Now, it has a maximal inhibitory concentration for the VEGF family receptor, 10-fold lower than the other TKIs. It has a half-life of nearly 2 to 6 hours. So this is important when once we are talking about how to manage the adverse effects of it. So its advantage over the other TKIs are it's a potent VEGF inhibitor and little of off-target effects. So how does this synergism work? Synergism works because angiogenesis inhibition leads to T cell infiltration into the tumor milieu, and therefore this basically T cell infiltration, and you actually give the PD-1 inhibitor, and thereafter these cells act and they cause the cytokill and eventually lead to the improvement of the survival curves. So combination treatment, this is how it is actually delivered. We most of you know this, that this is a IV infusion of pembrolizumab. This is given over a period of 30 minutes, and the drug is 200 milligram once in 3 weeks. And axitinib is given 5 milligram on a starting dose, and also probably up titrated or down titrated depending on the side effects. So talking about this particular study, which actually took into account stage 4 RCC clear cell subvariant, and they shouldn't have had any previous systemic treatment. IMDC was the stratification factor, and they were randomized into 1:1 distribution with pembro given for nearly 35 cycles, that is approximately 2 years. Sunitinib at that time was given as per the trial on a 50 mg once a day, 4 weeks on and 2 weeks off pattern, which by the time actually the NEJM trial got published, the way we used to practice sunitinib, it was like giving it on a 2 week on and 1 week off methodology. So the dual primary endpoint was PFS and overall survival in the intention to treat population, or the other secondary endpoints included the overall response rate and duration of response. So this was the baseline characteristics. As we can see that the IMDC favorable was there, a significant chunk of the population, 1/3. Intermediate was the major one, 55% nearly. There were certain patients who had sarcomatoid features. So these are very high risk population, histopathology, as well as aggressive biology disease. And there was a stratification of doing a PDL1. So there were certain patients who were actually where the documentation of PDL1 was there, not in all, but nearly 410 patients, and more than 2 metastatic sites. So nearly 72% patients had more than 2 metastatic sites. And there were nearly 82% patients who had a history of prior nephrectomy. So coming to the primary endpoint, which was overall survival in the intention to treat population. So this this trial got published in 2019 in NEJM, and the median follow-up period was nearly around 13 months. So there was criticism for the trial that why such a short follow-up we are having this data, but then eventually what we see that after down the line 5 years, this data seems to be pretty good. So overall survival for both the arms was not reached at the time of NEJM publication in 2019. So sunitinib and pembro-axi both were doing great, but the forest plot did show for the overall survival that there was a in favor of pembrolizumab, axitinib. The population, all the subgroups were actually favoring this particular combination. So talking about the PFS, well, here it was a clear distinction, and the pembro-axi was around 15 months versus 10 months for sunitinib, 11 months for sunitinib, which was statistically significant, clinically and statistically significant. I would say hazard ratio of 0.69. So again, the forest plot over here showed that the combination was benefiting in almost all the subgroups. You can see that Dr. Aparna was trying to tell that PDL1 could become one of the markers. We do not do PDL1, but then you can see slight benefit of PDL1 over there as compared to less than 1. But this again, as she rightly said, you might not find the differentiator if you're using a VEGF TKI. So here, more mature analysis, a 5-year data. So what do we see over here? Nearly 860 patients, again, the similar randomization. What we see with the more mature data is that we are finding similar PFS. Of course, at the time of initial publication, PFS was achieved. So hazard ratio continues to be the same. What we find is the complete response or the overall response. Nearly 11.6% patients had a complete response, and nearly 49% patients had a PR. So this is so important because we want immediate responses, and we want responses when we are talking about TKI plus IO combination. We want the tumor to shrink, and this actually is what we achieve. When the 2019 publication came into the paper came, the CR was around 6%. At that time, there was this IO study of Checkmate, and in that publication, the CR was around 12%. And therefore, we used to think and discuss at that point of time that are we actually getting more CRs with the IO combination and lesser with the VEGF and this combination. But eventually, with more mature data, this is what the CRs probably over a period of time this happened. And duration of response, nearly 2 years for Pembro-Axi and sunitinib, nearly 15.3 months. So this is how you do your scanning, and that would be determining this. So overall survival, again, this time you had figures over here, 47 months versus 40.8 months, and that was statistically significant. The hazard ratio of 0.84, so in favor of the combination. Now talking about the various subgroups, the favorable subgroup, as we understand, it's very tough to actually go beyond the standard of care in a favorable subgroup. So sunitinib still continued to give a good fight over there, and overall survival was, quite equivalent, but numerically it was slightly better for the Pembro-Axi combination. Vis-a-vis, if we look at the IO combination, where actually in the favorable subgroup there was a detrimental effect of using in the favorable subgroup. So that one particular point in the favor of this particular regimen was there. And then in the overall response, if you look at the overall response rate, so if we want to argue for giving this particular regimen in a favorable subgroup, the points would be that you could probably achieve a CR. So that is what it is, that you could achieve a CR of nearly 13% versus 6% in sunitinib. So that could be probably achieved. And in a young individual or a patient with no comorbids, one can probably consider this. So subsequent anti-cancer therapy. So most of the patients were actually getting it. So more than 2 lines, nearly 50% got it. So that was there. And the sort of therapy given, for the Pembro axitinib, it was more of VEGF inhibitors. But for sunitinib, it was more of the PDL1. So they weren't deprived of the immunotherapy. So once those patients, talking about those patients who completed, nearly 2 years of treatment. So if you look at that, they had nearly PDL1 was more than 1 in 50% of these patients, and more than two metastatic sites. So that's important that these patients continued to do well, and the baseline had a good good disease burden. And what we understand with immunotherapy is that once you are going up to the complete protocol, probably these are the patients who would really do well. And that's what happened at the end of 5 years, you see such patients who are actually completing the entire protocol treatment. Nearly 70% of the patients continue to do well. And talking about adverse effects, yes, there were slight more adverse effects with the Pembro-Axi combination. But now we are learning how to, we have we know how to sort of manage these side effects well and catch these side effects. Patient education is so important, and that is how we can actually prevent or a higher grade side effect. So to summarize, Keynote 426 represents the longest follow-up to date of the combination checkpoint inhibitor plus VEGF TKI in the first line clear cell RCC, and pembrolizumab continued to demonstrate. So it did show what it showed in 2019 and then 2023, that overall survival, PFS, and overall response rate continued to impress. A substantial percentage of patients completed 35 cycles, that is complete protocol of immunotherapy with good clinical outcomes. And these data should support that pembrolizumab as the standard of care for patients with previously untreated clear cell RCC. So just running quickly through the case study, which is showing a 67-year-old gentleman who actually presented to hospital with abdominal pain, and CT scan showed lung masses and left renal mass. So clinical radiologically, it was looking like a RCC, and histopathological examination confirmed a clear cell RCC. IMDC was intermediate risk, and his initial baseline parameters were pretty okay. The patient was started on this particular combination, and after 6 cycles, the patient started developing abdominal pain, and lab investigations showed that the patient had developed some hyperthyroidism. And apart from that, he was having a lot of GI toxicities, rash, mucosal inflammation, hepatitis, and decreased appetite was there. So in such a patient, just how things are managed, like pembro and axitinib, both were withdrawn over here. He underwent a liver biopsy, which showed some inflammatory cells, and the clinical diagnosis of immune-related hepatitis was made. And then he was started on what we usually start, 0.5 to 1 mg per kg of a prednisolone. This was started, and it is gradually tapered, not immediately tapered, but gradually tapered. And the combination therapy was reinitiated. So this is how this combination is actually working, and that's what we have. Yeah.
Thank you, sir, for such a crisp and clear presentation. Just one question, sir. In your practice, if it is a moderate to intermediate to poor risk, what do you choose? Do you choose IO or IO-TK, and how do you approach?
So first is the patient factors. I would say that what is the patient factor and the tumor factor. So
intermediate to poor risk.
Yeah. So talking about the tumor factors, I would beyond the IMDC, because IMDC in IO era is not giving a complete information. So I would want to also choose. I mean, it's very hard to decide which one to choose, whether to choose, pembro lenvatinib or pembro axitinib, with so many options on the table, if we are to choose among the VEGF TK and IO. So sarcomatoid features, if it is there, and the patient's entire disease bulk is not high, although it might be intermediate to poor risk as per the inflammatory markers. But if the bulk is not high, probably one, and a younger patient who's understanding things can come for immunotherapy side effects to you, then probably a IO combination could be chosen. If it's a brain metastasis, then cabozantinib combination along with immunotherapy has shown to be better. After a SBRT said, you do the SBRT or the SRS, you can then use the cabozantinib based combination. Pembro-axitinib is one of the favorite combination amongst most of my peers, what I discussed, because most of us have used it, and it is easier to manage the toxicities of it, understanding the toxicities of it.
Thank you, sir.
Yeah, I had one question. When you look at PEMXZ from the stats point of view, if you talk of the CR rates is best with lenvatinib and pembrolizumab. If you talk of the depth of response, then that is the best with cabozantinib and nivolumab. If you talk of the durability of response, then it is ipilimumab and
nivolumab.
So how would you put this in this whole scenario? How would you choose? Would you go for the depth of response? Would you go for durability, or would you just go for complete response rates? Like how do you?
So again, sir, if in case it's like a brain metastasis, so cabozantinib has some data based on that you have a better intracranial penetration. So there, that impressive data is there. So probably one can choose Nivo Cabo. Also, there is data for Nivo EP for brain metastasis, but then it is largely for small few brain metastasis. For number of brain metastasis more than 4, there is data, good data for Cabo.
Why I was putting so much stress is that we generally talk of complete responses. They do not translate into durability. We have seen about 27 to 30% of patients.
Yeah.
The complete response rates in EP-Nivo were not so great, but those 30%, they are doing very well, even over a 5-year span.
So that's what patient education, and that is also important if the patient understands the immunotherapy side effects. Yeah.
Thank you, sir. We understand that without direct comparisons, it's very difficult question to address. Now we move on to, now we heard that IO-TK, now we'll move on to IO plus IO. Achha, panel. Achha, sir is there. Okay. So next we'll move on to panel discussion on metastatic RCC. I'd like to invite Dr. Amlesh Sheth, Dr. Jinil Kumar, Dr. Meenakshi Kamboj, Dr. Sarthak Tandon, Dr. Varun Goyal, and Dr. Sarbarata Pratir. And panel will be moderated by Dr. Ganesh Bakshi.
Yeah, thank you. So good afternoon. This is a panel discussion on metastatic RCC. So all our friends are equally important. Can you take that bar down, zoom, or hide it? So we have Dr. Ginil and Dr. Sabartha as the surgeons. Dr. Meenakshi is a pathologist. Dr. Varun is a medical oncologist, and Dr. Sarthak is a radiation oncologist. So we'll try to cover some maybe questions and get the view of experts here on basis of what has been already discussed in the past 3 lectures, including the geneticist or the immunologist who was discussing. Thank you. So 61-year-old who had a backache since 2-3 months, and this was kind of caught on a health checkup. 61 we consider pretty young, and the sonography showed well-defined right kidney lower polar lesion, 2.7 by 2.4 centimeter, very juicy for Dr. Ginil. After showing all those nice surgeries, retroperitoneoscopic, for the backache, except the last sentence is very juicy for the medical oncologist. So MRI LS spine, where mild expansile L3 lesion with altered marrow signal, and again L1, L2 vertebral bodies also showing altered signals. So it's not advancing. It's not advancing. Okay, got it. Thank you. So, I mean, let us ask Dr. Ginil. So and the medical oncologist also, because we have 2 things here. Which imaging are you comfortable with grossly with this now? We have 2 investigations in hand already.
So in this scenario, if it was not showing any metastasis or symptom for metastasis,
yes,
I would have preferred a CT. But in this case, I will have a PET CT and request the radiologist to have a complete images of the abdomen in the CT phase. So
FDG PET CT.
FDG PET CT with the complete images of the abdomen.
So with our experts, we are on that line. Okay. So we'll go ahead. So this FDG PET CT shows a well-defined, I'll show in the next image, renal lesion, right renal lower pole, and lytic lesions on the L3, also on the left ASIS and left ala of the sacrum. So the renal lesion is absolutely like Dr. Ginil wanted.
So this patient had not come actually with all these things. He had a right renal biopsy done with all that. So is that the standard management you would refer to?
Considering is to be a metastatic RCC and having few skeletal mets, probably this patient, most of us will think he will receive upfront systemic therapy.
Okay.
To go on for the systemic therapy, renal biopsy is must, so everyone should do renal biopsy.
One more thing is we have to prognosticate with the IMDC scoring. So
Absolutely.
those also has to be in the first line.
So ISUB grade 1 clear cell RCC positive for PAC-SET. I think the reporting, Dr. Meenakshi can put her inputs, but the reporting pathologist was also slightly confused because ISUB grade 1. How often you see such kind of disease in a MRCC? It's, for me also, it was very rare.
Grade 2 at least metastasis.
Right.
And I would just point out here, we do a marker BAP1, which is a poor
Right.
prognostic marker, and we have recently found in a partial nephrectomy, just 1.52 centimeter tumor, it was showing a
Flap.
BAP1, good BAP1 loss, which is a
Okay.
poor prognostic marker. So maybe this is a case which has some poor prognostic
So,
features in it.
okay, so I don't have many questions for you, but since you said this, you are doing. Ek minute, let me ask one question to her. So PLAP1, so why did you think of doing it in partial nephrectomy? Because you had the IHC or the
Yes,
clinical
now-
features were different?
Yes, we are routinely doing it in all our cases.
So you are routinely doing it?
Now we are doing it routinely as a poor, as a prognostic marker.
Okay. Okay, because not many people are doing it. I don't know whether.
BAP1, it's a full form is BRCA-associated protein. It's known to be a poor prognostic marker for
Okay.
RCC.
So,
Not
so since Ashish is standing there with a question, Ashish, has the treatment changed after she is doing that marker? But after that, has the treatment changed? No. Okay. Ginil, you are saying something.
To the pathologist again, if we are getting great disparity, will you go for what are the indication for you to go for a IHC in a clear cell, in a papillary? What are the other tests? So depending on the pathology, what are the extra investigation you will do in RCCs, like clear cell in a papillary?
If it's morphologically clear-cut clear cell RCC, so then we write morphologically clear cell RCC, but we still advise for confirmation because sometimes you do have surprises. Like TFP3 RCC, it can have any morphology. It can have clear cell morphology. It can have papillary morphology. So we do always do a PAC-SET, even if it's a clear cell RCC. And if it is a papillary, then go for CK7 along with CA9. And we also do CK. CK, the most common marker for the cytokeratin, is usually not seen in TFP3 associated RCC. And we have seen such cases, patient presented with a lung mets, and it was not showing any other marker, just PAC-SET was positive, TF3 was positive, but CK was negative. So that was a clue. And later on, there was a tumor in kidney, it was found. So Dr. Sunil had reported that case.
That's okay.
Yeah.
So this we got reviewed actually, and it was the same ISUB grade 1, but not going, we'll go next. So we felt it was quite an unusual presentation. We had a doubt initially whether it was a metastatic RCC because of the size of that small renal mass, but we often see and ISUB grade 1 along with that. So this multiple myeloma workup was negative, and then a bone biopsy was done which showed metastatic deposit of clear cell RCC. So going ahead, sorry, that oligometastatic was supposed to be out. That's not for the panel. It's metastatic RCC basically. If this presents to surgeon, Sabartha, do you routinely do a risk stratification?
Yes, I will definitely consider it to be.
The surgeons find it very difficult to see 6 parameters and then, really do a classification.
So
Our colleague is smiling at us.
Being a metastatic disease is already, it is at least intermediate risk as per the IMDC criteria.
Okay.
So I will consider doing other.
So let me go to the medical oncologist directly. I mean, which is commonly used score which you would use?
We use usually IMDC criteria only.
Then the next
That is
question
the
is
most
more
common.
important, which is this is the better score IMDC, or you need to get better scores actually to decide. My previous speaker also said the same thing.
In the era of immunological now, there are few
Or
more scores
IMDC
there.
has been there for a good time now. So
Yes.
not only in the
So-
era of ICIs, but as you are having your own experience built up, what do you see? You need a better score?
Yes, sir. We need better score because we know that even in intermediate score group, there is a disparity, that is a heterogeneous group. There may be difference in the responses and survivals if there is one risk factor positive versus two risk factor.
Yep.
So there is a need for fine tuning of these IMDC, and we need better response criteria.
Okay. So this was IMDC 2. Sorry. Okay. Now, Ginil, we have come to the management. So would you consider surgery, cytoreductive nephrectomy?
At present, I am against
It's
because
very attractive. There are three
clinically-
lesions in the vertebra and small renal mass.
clinically, small renal mass, multiple tumors, likely there is a very aggressive tumor. If IMDC score is also showing a intermediate or poor, I will just take a biopsy and hand over to a medical oncologist.
So another question to our other surgeon, do you routinely discuss these in MDT?
So practically speaking, we don't discuss these in MDTs, but if suppose this patient progress and some unusual finding comes, usually discuss in MDT, but routinely, practically speaking, we don't discuss routinely.
Okay. So,
Ganesh, I think it is a individual this thing. We actually, according to the
no problem. So I just asked this question. So Ginil, to you again. So since surgeon might see such a case earlier, which trial data would you consider while discussing with the patient? The most commonly we know is Carmina. So, I mean, we can just have a 1-minute discussion across.
So two trials were Surtime and Carmina trials. Actually, Carmina trial is but the issue is these are all trials before the immunotherapy era. Current immunotherapy era, whether Carmina trial holds good, we don't know. We have got a lot of retrospective data having both sides, like some of the data shows that a nephrectomy has got a benefit. Some of the thing shows that there is no benefit by a nephrectomy. So these two controversial data is there in the post-immunotherapy era. But pre-immunotherapy era, we know that in the TK era, the Carmina trial showed that in intermediate and poor prognosis, there is no benefit by going for a cytoreductive nephrectomy. Intermediate itself, there is a good category intermediate where there is a single factor. Probably in that, according to the condition of the tumor, clinically we can decide whether we can go for. Otherwise, in a bad more than one factor intermediate or in multiple bad factors, there is no role for a cytoreductive nephrectomy. That is
Just
PKR.
to ask you this and summarize, when would we do a cytoreductive nephrectomy? So I'll just begin with saying, say, a solitary met is there.
Yeah. So
let Dr. Ginil answer.
So cytoreductive, I will have when we can completely eradicate the tumor. If there is a solitary met, we can remove that, like a lung solitary met. If liver, we
Right.
can remove that. In that case, I'll go for a complete, that is not cytoreductive, our intention is curative. Otherwise, if there is a good prognostic RCC, IMDC criteria shows good, large tumor with less number of tumors, and if there is a possibility of there is symptoms, and it is half palliative
Or
and
symptom.
half
And
cytoreductive.
post hoc analysis of the Carmina, which said IMDC score 1, which can go for potentially. So the next question is to our medical oncologist. So can you just briefly tell us, these are 4 eras we have seen in MRCC: pre-cytokine, cytokine, TKI, and ICI. So some few sentences on each, because the previous speaker has already covered a lot.
So, sir, treatment of metastatic RCC obviously have started from the cytokine era, and it's before 2000, and after that TKI have come into the picture, and that have changed the landscape totally. But in the last recent, I may say 4-5 years, now with the coming of immuno-oncology drugs, And with the combination of IO versus IO TKI, now picture is totally changed, and now most of the patient receive IO drugs either in the first line or second line, wherever possible in the first line. And with the addition of IO, we have achieved overall survival benefit, and the response rates also have better. So if there is no contraindication at present, every metastatic RCC patient should receive IO.
To receive IO. Okay.
Either,
So
IO.
contraindication in the sense either
So either-
genuine or financial.
Otherwise, if patient already having some autoimmune disease, or pregnant patient, or any previous
Okay.
history of grade 3-4 reaction to any other IO drug like that.
So I was going to ask that. So
No, sir. So still in the good risk patients, so because we have.
how much % of practice will be sunitinib in such a situation?
Still,
Because I
in-
still see people giving. Anybody from the audience?
Still in good risk patient, we can give only TKI, because with the addition of IO, there is a PFS benefit, response rate benefit, but
Absolutely.
there is no OS benefit.
Yeah.
So if patient are not affording, or we can still treat those patients with TKI. That is sunitinib.
Yeah, because the graph shown in the 426 also showed pretty good results with sunitinib. Maybe
So-
Dr. Vinit
so-
Talwar can add his words.
So we have done a study of over 800 patients, which we have seen over the last 3 years, and we have found that only 10% of the patients who actually deserve IO, they take IO. Because of the financial toxicity, which is obvious, because
That is
India
very
is
enlightening.
So that is the study we've done.
Sir, but nowadays with the availability of very good patient assistance plans with the both all three companies, now more number of patients are taking these drugs.
We agree. I mean, with patient assistance, a lot of people are going to increase surely, but there are going to be various problems at all. So I'm not going into this, but this one line, checkmate 214 and Carmina results were somewhere opposing. Carmina result was a median OS of 13.9 months in cytoreductive nephrectomy with sunitinib and 18.4 with only sunitinib, presumably because there were more poor risk disease. Checkmate 214 had patients who were nephrectomized and given nivo-EP versus sunitinib, and the sunitinib arm there had a median OS of 26 months. So this was one of the problems in the Carmina. The evidence still supports actually a role for cytoreductive nephrectomy before targeted therapy in appropriately selected patients. And these two trials, Nordic and Probe, which are with ICI, probably they would give a lot of data. I don't want to waste time on this. So cytoreductive nephrectomy does still look beneficial except a small group. And what happens is it's a balance between an MDT where you are going to use this with your ICIs and all these drugs. You are going to get wonderful responses. So for those patients who were not upfront nephrectomized, they are going to probably come sometime for a nephrectomy. This patient was started after an MDT discussion on cabozantinib and nivolumab by our medical oncologist. And generally, if I ask the medical oncologist, so what kind of counseling you would tell the patient? Because we don't know, it might be endless. So how do you manage to tell them?
We counsel the patient that according to risk criteria, he comes into the intermediate at least.
Agreed.
And,
But the most
there
difficult
are-
part is how long?
About that, sir, first of all, we need response and we need patient symptom free. And if with the further follow-up scans show that disease in the bones have resolved, and
Absolutely.
kidney disease in any way was very small. So we usually counsel the patient to take it indefinitely, obviously, if there is no contraindication and if there is no side effect in between. But after 2 years, many patients hold immunotherapy drugs if they are in CR.
Right. So as he says, I think the data shows like that. It should be given endlessly, very honestly. Let me ask the medical oncologist also this thing that when will you involve the radiation oncologist?
So, sir,
Because this is kidney, we don't upfront give radiation to anything. So apart from palliative.
So, on the first interim analysis, if response is there, patient is still symptomatic. So, for symptomatic, for palliative, we can refer them. Otherwise, if good response is there, but still disease remaining in the one or two bone spot, we can consolidate with the local therapy.
That is treating the metastasis. So let me ask him, where do you see the role in MRCC?
Exactly what he said was like, if there is no
I mean, let me
oligoproliferation.
add to you, then help you. Because when I was in TMH, my medical oncologist, Dr. Amit Joshi, used to refer to my radiation oncologist in those cases who were poor risk, going on, doing well, and we felt they were not for surgery at all. So we would still give a radiation to the kidney.
No, we don't.
There is data published.
Right, that's what I'm saying. So there is data published.
There is good data published.
You
So-
can treat for primary RCCs, but then if you're talking about this data set and this patient per se, looking for a good favorable factors and
This patient, I'm not asking you. This patient, if has a good response, Guinea is sitting there.
So any disease which is left on probably interim scan, going for now the important part is that if you can treat it with something which is radical dose, that's the key important. That's where I can
Agreed.
help probably with the immunotherapy and you can increase the time. So probably the time to change to the second line increases, and that's what the data suggests. So if I mean whatever the initial data says that you can probably have a systemic therapy change line free for about 12 months. So you can delay that change of line therapy for 12 months and ablating the treatment.
Maybe in this patient, if we have
By treating the renal primary.
Sites, then all the sites need to be treated, total ablative treatment.
If this patient, we have already nephrectomy have been done, then maybe after 3 months systemic therapy, if response is there, we can.
That is
create-
true. The vertebral lesions. I agree with that. That is true. So in this patient, the cycles went on. And Nevo. Sorry, please,
Shilpa from US. So
please.
on the duration of the immunotherapy, actually the maximum is 2 years. And like in my practice, if a patient has a major response or near CR, even at like between 6 to 12 months and couple of scans sustained show that, then I stop the immunotherapy. So especially like in places where it is really expensive, I think you need.
So would you totally stop? You would
I would
offer
totally
for a
stop.
surgery, you would give TKI in continuation.
Decrease the dose of TKI because once therapy they'll maintain that response even when
Okay.
stop. Also to the point of SBRT, I think it is coming back in focus, but
It's
we are
coming
not
back.
consolidating unless patients have symptoms. You know, but if they are for palliation, we are doing that. And now new oligometastatic disease from the beginning, you can consider SBRT and then.
So one question
the
to you, Dr. Shilpa. Suppose you stop, you are always giving TKI or sometimes not giving anything.
I give them breaks from TKI too.
What happens after something comes up again?
Then you can always re-challenge.
Challenge. Okay.
I've never really seen that add back immunotherapy because if they had a really great response.
But there is a possibility that something will recur.
Yeah, then you
I mean,
can
we have seen this in patients on TKIs. Earlier, sunitinib giving fantastic response and then disease coming back somewhere.
Right. For VEGF, it's a well. Let's continue to stop the immunotherapy as per even the label indication.
Another point,
Yes,
just to
please.
go on one point further, what she said was, and that's the reason why adding SBRT, because your chances of stopping IO becomes higher. I mean, in the data set, if you want to really think about stopping your IO, that's how
Okay,
you.
but we don't know if that data is published. I don't think so.
Phase 1, phase 2 data that is
So-
already published for that.
So Ganesh,
Stopping.
one case, I'll just take 1 minute. There's a gentleman who was on sunitinib for about 4 years. After that, he relapsed. We put the patient on Nivo and as second line. So now he has a very good partial response, but he has mediastinal lymph nodes, which we have biopsied. It is positive. Now he is about 3 years on Nivo, doing very well, good quality of life. Will you stop Nivo or will you continue?
So immunotherapy in any settings, if 2 years, you can stop it and then monitor. But with continuing it, it's not decreasing it anymore, right? So I think you can consider stopping and then scanning.
So Dr. Vineet, in that situation, would surgery help you? I mean, mediastinal, somebody can do a nice VATS.
I think, but the data for asymptomatic disease, you don't need to do surgery.
No, he had a biopsy positive with asymptomatic. So
But
that's why I
yeah.
said that disease is bound to increase sometime or the other. I
Actually-
don't think it's an immunity from disease.
Ganesh, I think according to clinical scenario, we have to decide. I got a patient who was initially on TK stabilized and single lymph node in the retropancreatic area was there. We did a retroperitoneoscopy and excised that entire area. After 2 years after that, he is completely without any treatment. He is
Agreed.
a urologist actually.
So that might help. Because again, somebody, you stop it, the disease flares up, there is a disease on biopsy, somebody can sue you. I don't think any literature will protect a doctor.
Like, for example, disease in asymptomatic
Right,
small
but then it
nodules.
depends on how the people see it. I mean, like Dr. Genil said, treatment also would be good. No, so if that is the only place of disease, then that's what we said, surgery.
That's a major surgery, right? Patient is not symptomatic.
It's done routinely, but routinely done. Okay, so if we have time, I'll continue. We had a response scan which showed the disease again after 6 months at the 3 spots. And we did continue systemic therapy till 18 cycles. And again, a response scan which did show a slight increase in disease in the spine. So that is how the disease went. He was on Nivo and Cabo. Compared to previous, there was increase in number of metabolic activity and metastatic lytic skeletal lesions in the vertebrae. So in such a situation, Varun, what?
Same number of lesions in the bone or number of lesions also have increased? Like same number of lesions have increased in the size only?
Increase in number and metabolic activity both in the spine only.
If we can radiate them, we can do that and we can continue same treatment. One option is that.
This was what was done actually. Now, you continue, please. I just said because the next speaker has also come and we'll hurry up a little. So this is adjustment.
If
You
that
please
is not the
continue.
case, if there are multiple lesions, can't be radiate, we can't radiate all, then
Right.
we have to change over to second line treatment, second line TK.
Okay. So this is what was decided in our MDT. Obviously, surgeon was not opining. Palliative RT and Pembro-Axi. Please.
Yes, yes, ma'am. So I think if we can radiate all the lesions in the bone, we can continue same regime. There is no need to change the regime.
So here the spine was radiated, not the sacral ally. So I have one last question till before we finish. So this is what I had found. I was reading while making this trial. We have doublet, triplet in prostate cancer, and just I was hearing the previous presentations where doublet was going on. So this was a clinical trial of triplet in MRCC. So how would you place it? I think let me ask Dr. Vineet only for his opinion. Let's ask her. How do you look at these trials which may prove successful?
L2 sir, this is a HIF inhibitor.
Pembrolizumab, belzutifan, lenvatinib, and pembrolizumab, covanlimab, and
Cosmic trial.
I think we take your words for that, because while I was reading, only one sentence I got, which was very important. They were trying to target the various ways of action in which the tumor would, propagate. So that will decide what is the science in future, actually. Ki how many molecular pathways you are targeting, rather than probably that will be told by the final result. So I think
One
let's
question, this oligometastasis criteria of 5 tumor, actually 5, in
5.
the RPOG criteria, is it applicable to kidney also in the same scenario, or is because it's not responding to other modalities?
So I think that's the real question and the debate, that 3 or 5. But most of the trials which are coming up for SBRT and RCC, they've taken up 5, less than equal to 5. And so I think that's the definition that we have to go by, and that's the evidence we have. I mean, if you ask me whether this is sacrosanct definition, it's not. But that's the most.
So guineal prostate also we say 5 roughly.
5, yeah.
5.
That's-
3 to 5, but now it is
That's how trials
universally
are taken.
accepted
Is not
5.
organ specific, is.
Yeah, agreed, sir. I think we end the panel discussion here. You can ask the question and we can finish with that. Please. Mic do na, please.
Oligometastatic 5 is fine, but if you look at all the trials or the meta-analysis of all the trials, the majority of trials have given radiation in a cases where it is single or double, not more than that. So technically it is 1 or 2.
Thank you, everybody. Thank you so much. Thank you.
Thank you to all the panelists. I would like to call on stage Dr. Sushant Mittal, Senior Consultant Medical Oncology, Max Shalimar Bagh, to deliver the next talk.
So good evening, everyone, and thank you for inviting me. As the previous panel discussion was happening, I think we all have an idea of the role of immunotherapy, and we have plethora of immunotherapy drugs along with the targeted TKIs, and how to use when has been already been discussed. But I'll be taking you through one of the important data which has improved not only the PFS but overall survival as well in advanced metastatic RCC. So we all know 90% of the kidney cancer cells are clear cell carcinomas. 10% are non-clear RCC, which are chromophobe and collecting duct. And staging workup is very important. Stage 1 is just less than 7 centimeters. Stage 2 is more than 7. Stage 3 is extends from the kidney to the perinephric tissue. Stage 4 is including the Gerota's fascia. And then N1 is metastasis to renal lymph nodes, and M is to organs, different organs. Now the incidence is 1 year survival is just about 36%, 2 year is 22%, and 5 year is just 12%, which is very dismal. This is when I think we were 10, 15 years back when we were just having sunitinib as a drug of choice. This was the data which was available to us. But then came the trial Checkmate 025, in which a phase 3 study was done. Nivolumab was compared to everolimus. 1:1 randomization was done, and it was given till disease progression. And the endpoint was about PFS. And we can see that not only PFS, but overall survival was also improved in second-line RCC when Nivo was compared to everolimus, and 27% reduction in risk of death had occurred. So hazard ratio of 0.73 in second line with immunotherapy agent was something to look forward. So unmet need was long-term survival, quality of life. We all know that everolimus is a difficult drug to tolerate. The complete responses we haven't seen with everolimus or sunitinib in RCC. And of course, the durability of responses after 6 months or 9 months, patients do progress. And then we are again at the crossroad as what is to be given. So this background led to thinking of adding immunotherapy in first-line RCC. Why? Because we all know that spontaneous regression of RCC has been seen after removal of the kidney, probably because of the immune system. It exhibits immune cell infiltrates, and several immune escape mechanisms have been reported in RCC, and hence this pathway was studied as to how immunotherapy can be utilized. The mainstay of the treatment previously also has been interleukins or interferons, which are again a part of immunotherapy protocol. And the evolving treatment modalities helped us to know as to how we can add one IO versus IO-IO combination. So RCC tumor cell itself, about 1/4 of the cells express PD-L1, and it is significantly associated with responses as well. The tumor infiltrate lymphocytes, more than 50% of RCC patients do have PD-L1 positivity. So anti-PD-1 with anti-CTLA-4, ipilimumab, which is anti-CTLA-4, induces and makes an environment which is beneficial for Opdita. Dendritic T cell interaction happens in lymph nodes, which is inhibited by anti-CTLA-4, and hence it restores that anti-tumor T cell functions, helping nivolumab to act better. So these both have complementary mechanism of action, ipilimumab with nivolumab. As the patient walks into our OPD, the risk stratification is very important. And we have been using this IMDC stratification, which is easy: performance status, diagnosis to the metastatic stage, hemoglobin, calcium more than 10, neutrophils, and platelet count. All these stratify the patient into favorable risk, intermediate risk, and poor risk. Why do we need so? Because the overall survival because of this risk stratification differs a lot. Majority of the patients who present to us in Indian scenario have one risk factor. So majority of them have intermediate risk. Hemoglobin is low in them. And we can see as the risk factors increases, the overall survival decreases by almost 20%. So favorable risk is 40%, intermediate is 20%, and poor risk is just about 7.8%. So with this background, Checkmate 214 trial was designed, in which Nivo EP was studied in a phase 3 randomized trial versus sunitinib. It was an open label trial. About 1,000 odd patients were included. Combination therapy of Opdita with Yervoy followed by monotherapy with Opdita was continued till disease progression versus sunitinib. The primary endpoint being overall survival, overall response rate, and PFS. And secondary endpoint was overall response rate, PFS, and OS in intent to treat population. So we all know the drug has to be given for 3 mg per kg along with 1 mg per kg of Yervoy for 4 doses, followed by single agent Opdita. It is both the drugs can be administered over 30 minutes, and we have to give nivolumab first, followed by ipilimumab on the same day itself. Almost 80% of the patients had received all 4 doses of Yervoy and no pre-medication is required. Why I'm telling you this? Because it reduces the burden on daycare as well as the compliance in the patient also improves. That is just about 60 minutes of an injection. So at the end of 4 years, almost 50% of patients were still alive, which is remarkable, which has not been heard in RCC. So this superior overall survival, even at the end of 4 years, gave it FDA gave approval for combination of IO in this category of patients. So even at 60 months, the extended follow-up, Nivo-EP showed a 20 months overall survival benefit compared to sunitinib. And we can see that graphs are still separated. Patients who continue to respond at the end of 2 years, they continue to respond at the end of 5 years as well. So this plateau can be seen that patients, if are able to reach till 2 years, then we can confidently convince them that even at the end of 5 years, you'll probably be on the same plateau and continue to respond. CR in metastatic RCC, almost 11% of the patient in this setting had CR, which is unheard in RCC. And 85% of these patients are still continuing to be in CR at the end of 5 years. The disease control rate is about 42% versus 26% with sunitinib. And the median time to respond is 2.8 months. That is before we do a next PET scan, which is probably about 3 or 4 months. We do see a response by the 2.8 months that patient will respond and have a good scan on the PET, on the report. However, versus sunitinib, which is 3.6 months. So even after starting the therapy, probably when we do a PET scan after 3 months, patients are not showing responses. The duration of responses and durability of responses had not been reached with the IO-IO combination. And this durability of complete responses, as I told you, 85% of these 11 patients continue to show response. Safety and quality of life, we have been using this drug in and out. Nivolumab we have been using. However, I had some mental block of using ipilimumab, thinking that it has some infusion related reactions. But when I used, my fear was dismayed, and patients have responded very well, and they do not show any infusion related reaction or even grade 1 or 2, which are manageable. So side effect profile, hypothyroid is one of the most common side effects which I come across, and that too was seen in the trial. So it is only 20% of the patients in this trial required corticosteroid for the management of side effects. Grade 3 side effects were 48% versus 64% in sunitinib. And as I told you, 80% of the patients continued or were able to take the 4 doses of Yervoy and nivolumab. This mnemonic of champion helps us to remember the side effects, that is colitis, hepatitis, adrenal insufficiency, myocarditis, pneumonitis, infusion reactions, ophthalmologic reactions, and nephritis. And out of this, I have seen colitis and pneumonitis in few patients and infusion reactions in majority of the patients, but that is also manageable. To summarize, no new toxicities have been identified with the combination therapies. Toxicity with combination is manageable and reversible. This approach is consistent between treatment combination Nivo-EP versus Nivo monotherapy. And most of these reactions are manageable with adequate uses of corticosteroids wherever required. Overall survival was not impacted even in patients who discontinued the therapy because of adverse events. So it shows that the memory T cells have been created and patients continue to show response. Early and sustained improvement in health quality related index also showed that this drug does not affect the quality of life, unlike for sunitinib or everolimus. So NCCN guidelines, category 1 recommendation of Nivo EP in intermediate and severe risk category. In favorable risk, Nivo EP or sunitinib, any drug can be used. It has shown a overall survival even in sarcomatoid variant, which had a dismal prognosis with the gold standard, which was initially sunitinib or everolimus. So even in sarcomatoid, patients had complete responses with this combination therapy. So 30 months overall survival probabilities by the risk stratification, we can see that in good risk, even sunitinib is giving a good response. However, as I told you, in majority of the population, Indian population, hemoglobin or anemia is there. So they fall into intermediate risk. And in that category of patient, IO-IO combination is definitely superior versus just sunitinib. Objective response rates are also higher for the IMDC risk factors. So to summarize, Opdita and Yervoy is the only IO combination with a chance of durable survival and durable responses at 5 years. Almost 50% of patients were still alive at the end of 5 years. It offers a CR rate of 11%, and long-term survival continues to demonstrate durable responses and efficacy. So it also offers early and sustained improvement in health quality related index. Thank you so much. Continue to show them. So the plateau is maintained. Thank you.
We'll move on to our next session of 2 keynote lectures, both of which will be delivered on Zoom. I would like to invite on stage the chairpersons, Dr. N.P. Gupta, Dr. Kundan Singh Chufal, Dr. Saurabh Vashisht, Dr. Gurudat Gupta, and Dr. Anindo Mukherjee.
Hello. So, good evening, everyone. So this session is for keynote lecture. So the first talk both the talks are quite intriguing and quite interesting. Acha, he's already there. So yeah, I'll just first invite Professor Shiv Srivastava. So he contributes in an advisory role to various academic institutions and also serve as an adjunct professor in the Department of Molecular and Cellular Biology at Georgetown University in Washington. He was a professor at Uniformed Services University of Health Services, where he served as a founding scientific director and co-director of the Department of Defense Center for Prostate Disease Research for over 25 years. He earned his PhD from the Indian Institute of Technology, IIT Delhi, and completed fellowship at the MSKCC. And he has co-authored over 477 papers and over 12 patents in the field of cancer biology and research. So his initiative have inspired a large cadre of next generation researchers. So he continues to serve the cancer research community as a consultant and reviewers for a leading cancer journal. So he would be speaking on prostate cancer genome, emerging actionable targets and new research opportunities in India. Dr. Shiv Srivastava.
Thank you. Thanks, chairs and the meeting organizers for having me do this talk. Special thanks to Dr. Sudhir Rawal, who has been a longtime collaborator and a personal friend. And thanks, Sudhir, for having me present in this meeting. And before I go on to my talk, I would like to thank Dr. Dan Theodorescu and Dr. James Moeller for graciously accepting to speak in this meeting. And I'm sure attendees will greatly enrich from their presentations as they are pioneers in their field of expertise. Can everyone hear me? Just want to make sure.
Yes, yes. Yeah.
Okay. So I'm moving on. So my talk, I don't have any disclosure, and my talk is going to focus on prostate cancer genome. And the focus is going to be mostly in the areas of race and ethnicity associated differences, and we'll give some global perspective. And along those lines, I'm hoping that the biomarkers and therapeutic targets, which are being especially in the new ones, been looked into, will help the precision medicine for all prostate cancer patients. And then I will show a few slides on the, some of the work which has been initiated at Rajiv Gandhi Cancer Institute under the leadership of Dr. Awal. I'm excited to show that and hope they'll create more interest. So in terms of race and ethnicity associated differences in prostate cancer, it's well known. It has been taught for many, many years. And men of African descent are at the high, they show the highest incidence of prostate cancer, followed by Europeans and then Asians. It's a multifactorial, say contributions, related to screening, access to care, socioeconomics, as well as biology. And my focus will be on the biological aspects of some of the differences, which we are seeing, and the impact of that both in the diagnosis, prognosis, as well as treatment, at least from the precision medicine perspective. So among the biological mechanisms, also hormonal pathways as well as immunological differences have been highlighted in terms of race and ethnicity associated differences. But my talk is going to focus on primarily on molecular genetic alterations. So summarized in this slide is a lot of information. It's over a decade of prostate cancer genome evaluations, 10 plus K prostate genomes have been evaluated, but the large proportion of the say specimens are from men of European ancestry. So I think that's something to keep in mind when we are applying the knowledge, which is great, but I think it's important to still keep that in mind. And the arrow which I'm showing is kind of progression of the prostate cancer from onset to advanced disease. And on the top of the arrow, I'm showing in early stage disease, genes like GSD5 and X3.1, ERG, E10C, MYC, and SPOP, they are frequently altered, and there's a consensus about that. I'm going to talk about ERG in a few slides in my talk. And then in advanced disease, of course, androgen axis inhibitors, AR, they play a very important role. And also you'll hear from Dr. Muller about say inhibitory molecules in the androgen biosynthesis pathway. So and then more recently, DNA damage repair genes such as BRCA1, BRCA2, and ATM, have found a place, as a therapeutic options for the advanced prostate cancer. But androgen receptor inhibitors and the androgen axis remains the mainstay. So that's kind of, the overall summary in terms of, looking at a lot of prostate cancer genome evaluations across the spectrum has been done. And one thing I just wanted to highlight, and I'll talk a little bit more about it, that the two most common genes, which get altered, either by gene fusion or by deletion/mutation, they show very significant, I guess, say focus, and especially from the perspective of this slide, my presentation is that genomic evaluations of underrepresented populations are needed to enhance the understanding of prostate cancer biology, as well as, especially in the context of racial and geographical differences. So in this slide, I'm showing, a summary about TMPRSS gene fusion, ERG activation in prostate cancer. This is one of the most common and validated oncogenic alterations. my group and myself, got involved in this early on in the discoveries when our group showed that ERG was most common overexpression in epithelial transcriptome of prostate cancer specimens from a large series. And soon after that, Dr. Arul Chinan's lab showed that ERG was a common partner in gene fusions. And it's a pretty high frequency for a given gene in solid tumors. So this occurs in up to 60% of specimens from men of European Americans, European ancestry, and 20 to 25% men of African ancestry, especially in African American patients. And Asians, the frequency is much lower. I'm going to show this data above. So there's a lot of work has gone on in the field for good reason. This is one of the most common oncogenic change in prostate cancer. And we were very lucky early on to develop a monoclonal antibody to ERG. And fortunately, antibody came very handy and useful, for many, applications, especially in the context of using it in pathologic specimens, for informal fixed specimens, and also, all kind of applications in the biology, we have utilized this antibody. So we were very fortunate. Up until then, there was no real good handle to study ERG quickly, in tissue specimen. That also led to a lot of collaborations. I'll just talk about it. And that also led to, thinking about the, prostate alterations more globally. And why I'm emphasizing ERG, because before ERG, a lot of genomic changes have been defined in prostate cancer. But because of the heterogeneity, it was difficult to kind of say generalize, in different contexts. So, but this really gave us good handle. So despite heterogeneity with target prostate cancers, this was pretty homogeneous in terms of its staining as well as. So within the tumor focus, we'll find nearly all tumor cells will be positive. And of course, there is a intertumoral heterogeneity in prostate cancer. So in the multifocal context as shown in this slide, on the left panel, panel B, with ERG staining that two tumor foci, one is ERG positive, one is ERG negative. And the specificity of the antibody was almost 99%. So it's very good. So Dr. Sestrahan in our group, did a large series and continues to look at it over nearly 2,000, it's a whole more specimens. And it's an early change we will see in pins. In the 1/3 of patients, even in multifocal context, all the tumor foci will find positive, but the heterogeneity does exist. And this work was really possible only because of long-term collaborations within the DoD healthcare system, equal access to patients. Dr. Sestrahan, Dr. Jadmol, myself, late Dr. Mosofi, and late Dr. McLeod. We had a great team, and we were able to do quite a bit of work, very productively and great interactions. So because ERG is one of the major, say change in prostate cancer, and in European Americans, you can see up to 50 to 60% of men have this alteration. So it's a very, say important, molecule from a precision medicine perspective, both for looking at it as a biomarker and therapeutic target. So shown in this slide is some of our work using the same antibody. At that time, we developed a very innovative high throughput screening platform using in-cell Westerns. And our goal, many strategies have been used to look for ERG inhibition in prostate cancer cells. We used, this siRNA and also small molecules that were screened, using the platform I just said. And we found a couple of small molecules that were very, very effective in inhibiting only ERG positive prostate tumor cells. So it was more or less like a synthetic lethal context. And there's a promising clinical data from our group. Other groups have shown, other strategies. So essentially targeting ERG is a good strategy. Problem is that it's a transcription factor. So still, it has not caught up, but I'm hoping, in future, ERG, we are able to handle, ERG targeting because of the, the frequency of this alteration in prostate cancer patients is early, just like in CML, BCRC-able fusions. So if there's a good handle, and we can translate preclinical data in clinical setting, one could really hope for, great opportunity for new targets in precision medicine context. And then this slide is showing a lot of international collaborations we developed because of the antibody, which was very simple assay for pathologists as well as in the lab setting. And so, within US as well as internationally, we had a whole bunch of collaborations that really helped us fully understand, the overall frequency of work in a global context. And our collaborators are very helpful and very interested. And many of my international urologic oncology fellows who worked in my lab, I took advantage of that and got their, help. And everyone was very, very, say, helpful in assessing and collaborating with us, especially with Dr. Sestrahan. And so here, just shown a lot of data in a summary format. The bottom line is that men of European ancestry, they have much higher frequency. Men of African-American men here, that's where we had most of the data, much lower frequency. And then Asians in general, have a lot lower frequency. The studies in India, they initially showed some variable results, but looked like the frequencies may be a little bit lower than European ancestry men, but it's somewhat higher within the Asian groups. So that's something to kind of keep in mind. Perhaps more needs to be done. And so shown here is a couple of genes, which I earlier mentioned, ERG and P10, shown in this slide. They're the most common genomic alterations. And you can readily see in the top panel, the red heat map, spots, heat map in the heat map in a multifocal tissue microarray context. In African American, lower frequency, and in the bottom panel, you can see both these genes have much higher frequency of alteration, up to, say 40 to 50%, and depending on the stage and ancestry, ERK can go up to 65%. So I think, that's something, is really, say, keep in mind. And so a lot of these data, have continued to emphasize that there is, even for some common genomic alterations, we are seeing ancestry-related changes. And then some of the genes which we discovered using the genomic approaches in this context, whole genome sequencing. So the two genes, LSAM and CHD. So I'm showing the data here a little bit more in detail for CHD1, which is in DNA damage repair gene pathways. And this gene is frequently deleted in African-American patients, almost 3 times as much, as compared to Caucasians. And a deletion of this gene is associating with a rapid disease progression. And actually, this is in the DNA damage repair pathway. So there is an opportunity for, say, in precision medicine context, if we have CSD deletion, one could try PARP inhibitors as well as platinum-based inhibitors. So that's something, so things like this, if we know the frequency in a given, say, racial or geographical context is going to be quite useful. Similarly, many of you may be aware of gene expression panels which have been used in the context of urine and prostate cancer diagnosis. So based on the background we were seeing, especially based on ERG and P10 data, we try to look at, some of those gene expression panels in between African American and Caucasian men. And we found that, if you look at the panel A, just at the very top is African-American patient cohort, where we're looking at the gene panels, which some of in the urine assays, been used. As you can see, it's a spotty, not all the patients are nicely captured, as opposed to just the panel below that, we have very high frequency in Caucasian patients, and that panel works very well as expected. So I think, this thing needs to be kept in mind when we are analyzing biomarkers, as well as, say, especially the new panels within the new patient populations. It's important to really look at this. And so in our group, more recently using urine exosome panels, we had developed a panel, in which, a gene which was PCA3, which was more commonly expressed across ancestries, and the PCGM1 that was enriched in African Americans, identified in my lab many years ago. Panels like this, are going to help, say, broadening the biomarker panels that may work across, ancestries. Here shown, that in this context is this panel was responding really good in distinguishing indolent versus aggressive cancer biopsy. When the assay was done in the urine context. Many of you may also know the Genomic Health Oncotype DX prostate cancer assay has been established and been in use for some time. And they early on, they had done pretty good job, looking at the performance of assay in across the race in larger patient populations. Starting, I think initially they did the work in our group, and then later on they have many independent studies they performed with other groups, and the data was looked very good for this assay performed in both in Caucasians and African Americans. So I think this kind of, say, emphasis there that if you're having a new patient population, new country, the biomarker panels, there's some of them work very well in the discovery phase, and in the validation in the context, it has been validated, and we need to really look more carefully. Finally, we also looked at germline mutation landscape. Up until now, what I showed was somatic mutations like ERG and PTEN that happen during the lifetime of an individual. So germline changes, for that, we did whole genome sequencing in a cohort of 500 plus patients, half of them African Americans and half of European ancestry. And there's a lot of data still we are analyzing, but basically here we focus only on the DNA damage repair genes. And this is not a small panel. We looked at all the known DNA damage repair genes, which is about 276. And so a lot of data summarized very quickly here is there's a distinct germline DDRG mutation spectrum we see in the men of African American and European ancestry. So, we did not expect at this level, but, so this was quite intriguing. And this area is further needs to be, say validated, but at least in our, say data sets was pretty good. And we did find some of the known genes, in the DNA panels, which we are already, used in both germline context and advanced prostate cancer cases. So the genes in the homologous recombination pathway, for example, in the DNA damage repair gene, overall broader pathway, when we look at data, mutations in germline mutations in those genes nicely correlated with the disease progression. The kind of summary of our germline data is that only 13 of the 46 DDRGs, we identified with pathogenic and lightly pathogenic mutations were present in both African American and European ancestry patients. So again, I think emphasizing the need for carefully looking at some of these aspects. And in this study, we find that the RAD family of genes, which are potentially targetable, like inhibitors like PARG, because this is the DNA damage repair pathway, they were among most frequently altered DDRGs in African American and European ancestry patients. So we hope that the expanded DDRG panels will have promise, in further enhancing, at least in the targeted therapy area in the DNA damage repair pathways. And then I picked a couple of these things from literature, recent data and statements that tumor genomics differed by race, even after accounting for clinical characteristics, and equalizing access to care may not fully eliminate such differences. The therapies for such alterations are, which are more common in racial minorities are needed. So I think, that's the overall message was in the second study I'm going to put out here. They did show that in advanced cases, the AR alterations and DNA damage repair pathways as actionable targets were similar across in ancestries in this system. Finally, I think show a few slides, which under Dr. Raval's and Dr. Mehta's leadership at Rajiv Gandhi Institute in Delhi, Dr. Shashwat Sharad, who was a staff scientist with me, he worked with them, for a year and, did some work, and that catalyzed our, some of the thoughts we had over the years, especially with Dr. Raval, looking at the prostate cancer genome focus in the Indian prostate cancer patients. So here I earlier mentioned, ERK frequencies were somewhat variable, and I think, what happened perhaps maybe the first two papers are actually from Rajiv Gandhi Cancer Institute. In the early studies, the frequency was somewhat lower, when perhaps maybe had more advanced cases, that frequency does fade in advanced cases, perhaps due to AR androgen signaling alterations, or maybe even say genomic fusions is of lower frequency in advanced cases. And then there was another independent study from, I think, from IIT Kanpur, showed a frequency about 40 to 50% in their prostate cancer series. And then studies regarding genome focus, I think it's coming out, but I hope, the more gets done in that area. So I just want to give a few slides, very, very early data from Rajiv Gandhi Cancer Institute, Dr. Raval's leadership. Dr. Sharad provided me the slide. So they used a panel of about 24 patients, frozen specimens, pathologically well annotated for whole exome sequencing and RNA sequencing. And then data was then analyzed by both for new, novel and known mutations, and then hoping that this will catalyze, future studies in this direction. Just from the top, the data, just looking at the chromosomes from a genomic perspective, these are circus plots. And I was surprised to not find some of the common chromosomal alterations highlighted in West, especially this is a TCGA data. Chromosome 8 is one of the most common alterations. Here we did not see that in the Rajiv Gandhi Cancer Institute patients. Also, in this study, we did, I think there's confidence because we did find known mutations. And so Dr. Sharad is reporting here in a relatively lower frequency of tempus ERK mutation and P10. And then, as expected, the DNA damage repair pathway gene, I mean, they are generally at low frequency and more higher in advanced cases, but this was a localized, prostate cancer specimen. So that's kind of expected data, so which is good, but ERK and P10 are at lower rate. So I think, larger series probably will be needed to further, compare with the data from the patients, European and African ancestry, as well as Asian ancestry. And then there are some novel recurrent mutations, which I think, in my opinion, I think they need to, further validated both in silico as well as experimentally. Because one caution is that when we are looking at this genome data, the reference seq still is not predominantly, reference sequences are from European American patients. The newer ones are more diverse. So I think, more careful bioinformatics analysis is needed when we are looking at, other patient populations. So I'm going to summarize here the RGCI data. So I think it looks, at least I'm happy that Dr. Rao's group, has pushed ahead and started this focus area. And I'm hoping other groups, some of the colleagues attending the meeting, will be interested in joining. And my overall thought process is that there has to be a more integrated effort for large patient series, like TCGA data here. It was developed, in the US, and I think the need probably is there from in the different regions of India, knowing the probably also variations in the context of race and ethnicity. So I'm going to stop here, and thank you very much.
Hello. Shiv, this is Dr. N.P. Gupta.
Oh, hi, Dr. Gupta. How are you?
Thank you very much for your excellent lecture and highlighting that the genomic profile in cancer prostate patient can be different in the Americans, Europeans, and Asian population. But as a clinician, I'm asking this question. It means that the gene panel, what we study in all these three regions, should be different, and or you think the same, because cost is an important factor.
Yes, absolutely. So that's a very important, I think, question. So they're not completely different. You won't expect them. But I think the caution is that I think, when we are using the new, say therapeutic target or new biomarker panel, at least there needs to be clarity about that in the patient population you're looking at, is going to work. So I think, so I'm not saying that they'll be completely different, and one would not expect that, based on the genetics, but I showed you the data that if you use ERG as a biomarker in diagnostic panel, perhaps, it won't be very good across ancestries because there's a very significant difference. And some of the urine panels, we have primarily they are PCA3 and ERG, and now, they are broadening and including newer genes, both in our group has done, other groups are also doing it. So I think that's the importance here.
Thank you, Shiv. Anyone else like to ask any question? Thank you, Shiv. Thank you.
Thanks so much.
It's a morning for you.
It's morning for me, and I need to run. So I'm hoping, Dr. Theodorescu will be, I think, giving his really, you guys will be really excited to hear his talk, and I think he's next.
Okay. Can we change over to next lecture? It gives me great pleasure to welcome Professor Dan Theodorescu. He is the director for the Samuel Austin Comprehensive Cancer Institute at Cedars-Sinai Medical Center. He was director for the University of Colorado Cancer Center and a distinguished university professor from 2010 to 2018. He graduated from Queen's University, Ontario, and completed his fellowship from MSKCC. He is known for his work on molecular mechanisms underlying bladder cancer, biomarkers, and discovery of newer therapeutics such as immunotherapy of cancer. He has published more than 300 articles in various journals, reputed journals like Nature, Science, Cancer Cell, PNS, and JCI. Dr. Theodorescu, we welcome you, and you can start your lecture now.
Well, thank you very much for this opportunity and a pleasure to meet with you today. So I'm going to share my screen. Okay, is everything looking okay?
Yes.
Okay, thank you. I'm sorry, repeat that?
Slideshow. You can go to slideshow.
Okay. Let me put a pointer on. Laser. Okay, good. Okay, so what I'd like to discuss with you today is really some recent observations that our laboratory has made, which I think have very significant.
Can we request you to enlarge your screen? You can go to slideshow and push that
Yeah,
button.
no, I'm on slideshow right now.
Okay.
I have a very
You
wide
need, huh?
screen at home,
Okay.
so maybe that's the reason. Is it really small? I could
Yeah,
just
yeah.
run it on the laptop.
No problem. You can go on.
Are you sure?
Yes.
Yeah, I've had this issue before occasionally. If you can't see it, I'll just run on the laptop only. Are you sure?
Yes.
Yes, laptop, no, or yes?
Yes, laptop.
Yes, yes.
Laptop.
Okay.
Yeah.
Yes, now it's okay.
How is that? I have to switch.
Yeah,
Hold
this is
on.
fine. This is fine.
Okay, I'm gonna have to switch the okay. I have to switch the cameras around.
You can see us.
Well, sorry about that. Oh boy. Okay. Okay. Can you hear me okay?
No, we can see you.
But can you hear me?
Yes, we can hear you.
Okay, and I'll put the projector. I'll put the slideshow on. Okay, so this should be better, I hope.
Yeah, this is perfectly right.
Okay, great. I want to share with you some findings from the lab that I think could have a pretty foundational importance in how we treat cancer. And that is really the science and clinical implication of losing the Y chromosome in cancer. So these are my disclosures. So I don't think I need to tell this audience of this what this slide shows. But essentially, we know that bladder cancer occurs differently with different frequency in men and women. As you can see on this, let me put the laser back on this side here. Unfortunately, in terms of mortality trends, the mortality has been improving, but not as much as the cancers that you see above here. So the bottom line is we have significant amount of work to do. So, but what this also says is that bladder cancer is really a sexually dimorphic cancer. So what does sexual dimorphism mean in normal biology and in cancer? Well, it turns out that you could see on the left, sexual dimorphism is very, very clearly depicted in animals, with the male and female looking very differently. But also, sexual dimorphism occurs in people, specifically, not only normally, but also in terms of their cancers. So we have the things that drive the sexual dimorphism are genetics and epigenetics, and those two impact basically, you can't see my hands, those two things impact sex chromosomes and sex hormones. So there's been a lot of work done on sex hormones. We're all familiar with bladder cancer being sensitive to androgens, to estrogens. There's a lot less done on sex chromosomes. And so I wanted to show you this paper that to me was very important, really, to anchor the rationale for doing this kind of work that you're about to see from my lab. So this is a type of mouse called 4-core genotype. And what this mouse does is that it's a very interesting mouse because you can get, by virtue of genetic engineering, you can get an XX female and an XY female, as well as an XX male and an XY male. So what that does is allows you to look at both the impact of chromosomes and hormones on carcinogenesis. So we have a model that we use in bladder cancer called BBN, which is a carcinogen that we feed the mice and they get bladder cancer. So here you could see the Kaplan-Meier curve survival of the various mice. So you see at the very extremes, you have the XX female and the XY male, which is basically normal males and normal female mice. But when you reverse the sexes and you dissociate essentially the sexes from the genetics, the curves, come together. And so the analysis statistically, what this means is pretty simple. It would appear that the Y chromosome is bad and that androgens are bad. And
we looked at this and we we wondered whether this was in fact the correct interpretation. Here's why. If you look this very, very carefully and critically, the growth promoting effect of Y is only seen in mice with one chromosome, one X, okay? And we know there are tumor suppressor genes on the X chromosome. That's why Turner syndrome, which is XO females, have increased chances of various cancers, including bladder cancer. And so the other point is that the XX male and the XY male eventually have the same survival in the end. So the take-home message that the way we interpreted this paper is that Y chromosome may be protective. So what's the evidence for this? So we went back to the literature and essentially looked at papers that implicated the Y chromosome in a variety of different things. And we came across a very interesting study in 2014 that showed that in a very large population of men, 1,000, they're elderly, that we analyzed, the authors analyzed their blood. Those men basically had a significant loss of the Y chromosome in their blood cells. And so because of that, and because of the comparator with other genomic changes, you could see here, the Y chromosome was the most frequent loss, somatic loss, in men that are just walking around of that age. So that was pretty interesting. But what was even more interesting was this. So when you looked at survival of these men, and this was a Swedish study, by the way, a national Swedish study. So very, very racially homogeneous pertaining to the previous talk. Excuse me, I'm recovering from a bit of a cold. So very, very homogeneous. And I draw your attention to both the table and these striking Kaplan-Meier curves. So like they say, the data speaks for itself. And if you lose your Y chromosome in blood, you die of much, much more with higher frequency and sooner. And you die both of cancer and non-heme cancer tumors. So these are epithelial tumors. These is all cancer, and this is epithelial cancer. So we're obviously very intrigued by that, and the fact that on multivariate analysis, the loss of Y showed up as one of the most powerful predictors, as you could see on this side. So we went to the literature and essentially found other studies that showed this. This is the original one I just showed you, but there are other studies that implicated bladder and prostate, colorectal, prostate, and bladder with risk adjustment. And I'll tell you in a minute what that means. The risk adjustment obviously has to do with age. And the reason is because as you get older, you have progressive loss of the Y chromosome, which is, again, a very interesting finding. But bear in mind that in men, at least in most of the studies, the loss is 15 to 20%. And I just want to put a plug here. I'm now trying to put together a study that looks at loss of Y in a variety of ethnicities and races. And if anybody's interested in collaborating, I don't have a large cohort from India or Indian patients here in the US. So I would really welcome a collaboration if you have it, if you're interested. So, but what about other animal models? So older men get loss of Y, but look at this. This is the rat. So rats don't live as long, of course, 2 to 4 years, but it's pretty clear that there's a very big difference in loss of chromosome in rats. And the interesting thing is that it occurs in both PBMCs, so just like in men in blood, but also occurs in other tissues. So that was the first clue about something bigger happening here. So the other big thing that people noticed is that loss of Y in the blood is strongly associated with smoking. But in all the studies that I showed you earlier, smoking, loss of Y is independent risk factor in multivariate analysis with smoking. So it doesn't mean that, in fact, the cancer is caused because all the ones that die sooner are all smokers and the ones that don't are non-smokers. That's not true. So smoking is important, but it's not what is driving the biology of loss of Y. So the other thing that is, I'm not going to get into, is the germline risk. There are multiple SNPs that have been identified to be associated with loss of Y. Okay, so then the question is loss of Y just a biomarker, or does it impact somehow the immune system when it's found in blood? So you can imagine that it could be just a biomarker, right? It could be telling us that you have DNA damage. Is a perfect lead into the prior talk, that you have DNA damage and the particular person there's inefficient DNA maintenance and repair. Or it could have an impact on the immune system potentially, and the white cells in the blood that have lost the Y chromosome may actually somehow distort or mess around with the immune system in such a way that it makes the person more likely to get cancer. But the third option, and I put it under option 1, is that because it is a biomarker, is that it could be proxy for the processes of DNA damage in other tissues. So in other words, if, like in the cartoon shows, if you smoke, you can get loss of Y in the blood and loss of Y in epithelial cells, leading to cancer. So we want to look next, because of this, we want to look next at cancer. So this is a table from a paper that came out after ours. I'll show you our data, but it's a nicer table than ours because what it does, it surveys all the cancers. And what this shows is clearly that certain cancers lose the Y a lot. And there's a huge spectrum. And prostate cancer is here, by the way. And as you'll see in a minute, prostate cancer, loss of Y is very significantly driving prostate cancer, and we're looking at that right now. But bladder is right here in the middle. So significant losses, some gains, so clearly important. So this is the overall Kaplan-Meier curve from the TCGA in terms of prognosis of the various cancer types I showed you on the previous table. And I've put in red a number of studies that have a number of tumors that are when Y is lost, the prognosis is worse. Right here towards the top of the list is prostate, there's bladder, there's head and neck. Interestingly, some of the lung cancers and stomach cancers that were found in other studies to be associated with loss of Y in the blood, when they lose Y in the cancer, they're actually not a worse prognosis. And you see here, there's quite a few cancers where loss of Y either does nothing or is better, actually. So that's a very, very interesting issue. And again, we're looking at that as well. But it's a very, very interesting issue that loss of Y could be actually have different meanings to different cancer types. So since we focus on bladder cancer, basically our hypothesis is that LOI, loss of Y, is a driver of bladder cancer. So overall, LOI, so overall, the Y chromosome is a good thing. So we started our studies to really investigate this and test this hypothesis by taking a cell line, cloning it by limiting dilution. So this is basically getting on all these little wells are a different cell. Then looking at expression of the SRY protein, which is the transcription factor that determines male. And then doing PCR on 4 key genes on the Y chromosome. And I think you can clearly see here that we had a whole bunch of clones positive and a whole bunch of clones that were dead for the Y chromosome. So then we grew these cells in vitro in tissue culture plates, and they grew the same. But here's the interesting thing. When you grew them in mice, the Y negative cells grew faster. So then we did single cell sequencing of these tumors, and that allowed us really to get a gene signature of loss of Y that we can then use, and I'll show you how we used it, to examine TCGA and other data sets, and also characterize the populations. So here is the data where we use the signature. This is from a study that did whole organ mapping that we had the data from, and you could see the male and the female endpoints, if you will, when we applied the Y chromosome signature. So the signature is applied on RNA in these samples. But the really interesting thing is that if you see here low-grade, high-grade intraepithelial neoplasia and then cancer, there's a progressive loss of the Y chromosome, which says to us that loss of Y chromosome is an early lesion in bladder cancer. And of course, in established bladder cancer, not surprisingly, it is a much worse prognosis. Okay, so then this slide actually contains probably 4 panels in the paper, but I'll summarize it to say that when we tried to get at the mechanism of how this all works, we came to the conclusion using a single cell immunoprofiling and genetically engineered mice that are missing various pieces of the immune system, that in essence, the effect was due to T cells, and that the reason why this was happening is because the Y loss is triggering immunosuppressive environment with anti-inflammatory macrophages and significant CD8 T cell exhaustion, which is a major reason why these tumors in general, human and otherwise, grow. Okay, so that was really interesting. And then the question arose, which of these genes are actually driving the phenotype of loss of Y? So we looked at all the genes that are expressed in the Y chromosome in patients, in bladder cancer patients, and 4 of them were significantly associated with worse prognosis when lost. And then we looked at TCGA for muscle invasive and non-muscle invasive, and only 2 of them were bad prognostic factors in both tumor types. So of course we prioritized those. So then what we did is we took cell lines that were missing Y chromosome and overexpressed UTY and KDM5D, and then we took, in parallel, we took bladder cell lines that had the Y chromosome and knocked out KDM5D and UTY. And I think the data here is showing the knockout and expression basically says the same thing. So it's basically a rheostat. So when you take overexpression, in this case, the tumors grow less well. And when you knock it out, the tumors basically grow better. And so that's really the idea here. And so it proved essentially that the Y chromosome loss, likely in bladder, not fully, but likely in bladder, we basically have a situation where it drives the phenotype of loss of Y, these 2 genes. Not completely, but a lot of it. So then the question is, okay, so if we have a lot of exhaustion, what does that mean in terms of immunotherapy with checkpoint inhibitors? Because we know that checkpoint inhibitors reverse exhaustion, and we're very delighted to see when we compare Y-positive tumors to Y-negative tumors that the Y-negative tumors respond a lot better to checkpoint. But the question is, does that matter in people? So what we did is we took data from InVigor 210 and analyzed it in this with respect to our RNA signature, and lo and behold, it looked just like the mouse studies. And both for the overall signature, LOI, and for the two genes that we talked about. So that was really an exciting development. So I'm going to wrap it up now, and I'm happy to take questions because I skipped a lot of really deep, more mechanistic data in the interest of time. So our conclusion basically was that loss of Y occurs in multiple tissues with aging in both men and rodents. It occurs in normal men. So normal men are walking around. 20% of men over 70 are walking around with this thing. And it basically is associated with higher cancer incidence. And when the loss of Y is found in cancer itself, the tumor itself drives a more aggressive phenotype with poor prognosis. When it's in bladder cancer, it drives this a more aggressive phenotype through immunoevasion. And the fact that it does that through immunoevasion, the good news is that it could be reversed more effectively with immune checkpoint blockade, which obviously is clinically used for bladder cancer. So, so where are we going next? And well, we're going a lot of places. So we're developing a test for both urine and blood that we're pretty close to testing. Again, I welcome collaborations if anybody is interested. So the test will be hopefully deployed soon for testing and then potentially in clinical use to predict immunotherapy and prognosis. So we also want to find out what makes Y cells more sensitive to checkpoint inhibitors. So we're doing a lot of screens in vivo. We also, number 3, we want to figure out what is really the relevance of loss of Y in the immune populations, the white cells. Not all the cells, we know this from preliminary data, not all the cells have lost Y in those populations. And we're now trying to figure out mechanistically what's the relevance of loss of Y in the various populations in regard to cancer biology. And one of the tools that we're going to use is we've developed a transgenic mouse that could be induced to lose Y chromosome in a variety of tissues with induction with tamoxifen. So it's a very, very, very sophisticated mouse. It took us a year and a half to make, and we're testing it now with a variety of things. But we're very excited to be able to use this mouse to test what all these compartments are doing. So the last slide is really the acknowledgement. I'm very pleased to have been supported pretty much my entire career by the NCI. In this case, we have the PO1 supporting this. The paper came out a few months ago in 23, describing the work I showed and my collaborators. And then I want to thank all our patients worldwide that helped with various databases, et cetera. And with that, I'd like to conclude. I apologize a bit for the technical troubles and for going over time. I'm happy to take questions.
Thank you, Dr. Dan, for excellent presentation. The floor is open for any questions from the audience. This was a very informative presentation. Sir has a question.
Hello.
Hi.
According to your study, Y is very important and there is 20% loss in the population. So will you recommend that every man should have a checkup after the age of 40 or 50 to check whether Y is present or absent? And if it is absent, what measures can be taken to bring it back?
Yeah. So of course, you asked the, like they say, the elephant in the room question. So let me explain to you how I look at this elephant. We have another study that's going to look at about 5,000 men. And the reason why we're looking at these 5,000 men is because they're ethnically diverse, which I mentioned earlier, but also because we have the ability to actually take their blood and analyze it both for the Y chromosome and for other markers, metabolism, proteins. And what that will allow us to do is to actually increase the level of resolution of loss of Y, because not every man, excuse me, not every man with loss of Y is going to get cancer. And because that, I currently would not recommend that people do anything with the loss of Y till we know better, till our positive predicted value in men with Y is going to be, excuse me, till our positive predictive value is better. So I can imagine a scenario where we do loss of Y and 2 or 3 other markers, and then we could tell that that the patient will be at much higher risk of getting a cancer. Then we could use it clinically. But right now, it's not, its predictive value on the individual patient is not as good. Of course, I'm optimistic that we'll be able to do this once we
Thank
analyze
you.
this part study.
Thank you. It's really
I just have one
thought-provoking topic for us, actually.
I have
And,
one question.
thank you very much. We enjoyed.
Excuse me, sir. One question. Dr. Dan,
Yeah, I'm
is
here.
there I have 2 questions actually. Is there I mean, there is chance of loss of chromosome Y in near future? And second part is, uh, when you say that there is loss of chromosome Y, is it in the pseudo-autosomal area of the Y chromosome, or it is in the sex determining region? Where is the major loss of the genetic material?
Yeah. So great questions. I didn't quite catch the first question. I caught can you repeat the first question?
The first question was, actually, I read a few years back that there's going to be loss of chromosome Y, and then there will be only females.
Yeah. Yeah. Well, the Y chromosome has progressively shrunk over the years. And so I don't think we need to worry about this yet, because that took millions of years. So I think we're fine. Okay. So the other and I'm not going to get into the mechanisms why potentially we could be male without the Y chromosome, but that's a little off topic. But we'll be fine because it's millions of years. But the second question basically is really important as well. 2 things I would like to mention. Number 1, when we talk about loss of Y, these are mosaics, okay? So a man with loss of Y means that they have greater than, depending on the paper, greater than 10 or greater than 15% of blood cells in that have lost Y. So it's not that they're men, these 20% of men over 70, it's not that all their white cells have lost Y. No, they're mosaics. That's the threshold that shows the increased cancer. That's number 1. Number 2, these mosaics have complete loss of the chromosome. So it's gone. And you asked about the pseudo-autosomal region, the whole thing is gone. Yeah, the whole thing is gone when but they're mosaics. So, and a man that is technically loss of Y, we call it M-loy. I didn't want to get too complicated given the talk, but technically it should be M-loy, which is mosaic loy. So you're basically dealing with 80% positive cell in the blood and 20% that have no Y chromosome. That's the cutoff.
Thank you, Dr. Dan, for excellent talks. Thank you so much.
My pleasure. Thank you for having me.
A very enlightening keynote lecture. I'll request Dr. N.P. Gupta, sir, to stay for the next session. We'll move on to the bladder cancer sessions. I'll call the chairpersons on stage, Dr. Rishi Nair and Dr. Vivek Vasudev.
Guys, I have no clue.
Hello. Good evening, everyone. So moving on to our next session on bladder cancer. The first talk will be by Dr. Arnav Stenzel. He is a medical director at University of Tübingen, Germany. He is a Secretary General, European Association of Urology. He has worked at renowned medical institutions such as University Hospital Graz in Switzerland and University Clinic Innsbruck. He has received the Theodor Billroth Prize of the Austrian Society for Surgery, the Werner Steller Memorial Prize of Southwestern German Society of Urology, and the prize in the German Society of Urology film category. With over 800 scientific publications to his name, Professor Dr. Stenzel has made significant contributions in the field of urology. His research and focus include carcinoma of prostate and bladder cancer. And today he will be going to deliver a talk on best urinary diversion after radical cystectomy. Over to Dr. Arnav Stenzel, please. Thank you.
Well, thank you very much. It's a great pleasure to present this here. Now it's getting a little bit more practical. It is just let me get my screen to you. And okay, can you see the first slide?
Yes, yes, we can hear you. We can see the slides as well. Please go ahead.
Okay, so you can see and hear because I couldn't hear it.
Yes, yes.
Okay,
We can.
excellent. Well, what this is meant, and that's why we start out with, is those patients that do have bladder cancer and that do have an advanced type of cancer, which we think is local regional. Eventually, they may have surgery, and that surgery means to really treat in a way that we take out the entire tumor laden bladder out. But that is, for many patients, means what is going to happen afterwards and what type of urinary diversion do I get. And that decision by the treating physician as well as the patient is sometimes the actual reason why sometimes patients refuse to have a cystectomy, or they may even go out of tumor therapy at all because they fear a mutilation, so to say, with a type of urinary diversion. That is not really something they think about when talking about or when thinking about a curative treatment. Anyhow, these are my conflicts of interest. When we talk about the type of urinary diversion, of course, then we have to really think about the tumor in itself. That is something which is, of course, the major driver. You have to think about treating the tumor before you think about the type of urinary diversion. Then it's life expectancy, frailty, desire, and motivation of the patient, any comorbidities. And of course, then also, because it's a major surgery, it means also which surgeon, what is the experience of the surgeon, but not only the surgeon, but also the hospital. And okay, I cannot
I cannot advance. Is there any? Mhm. Then, and then you have to make the decision between an external urinary diversion or an internal urinary diversion where they can be active, but not every patient is active. And we know that, some patients, they want to have a very simple lifestyle, and they cannot think about this change of certain habits and this weekly or several week long type of physical therapy, and they do not think about an active lifestyle like some other patients do. The main thing, as I said, is of course, the important thing is when we take a bladder out, we want to be curative, but curative means we're talking about urothelial cancer of the bladder most of the time, and there is some involvement of the adjacent urethra and the ureters at times. We try to make it safe by making biopsies at the bladder neck, because if there is tumor in the bladder neck, then at least part of the urethra and should come out. And of course, when you do a frozen section and you find a tumor in the distal ureter of carcinoma in situ, most of the time, if there is any tumor, then you just have to resect that part of the lower ureters as well. And that really makes a decision what type of urinary diversion should be done. However, once the bladder neck is free of any tumor, then the solitary urethral recurrence, if the urethra stays in, with a orthotopic neobladder or without, then the urethral recurrence is rather low. It's higher in those where there is a blind ending urethra, where there is no, for example, orthotopic neobladder is hooked up to that. So that is, we can, by staging already, and of course, most of those patients will be able to get pre-neoadjuvant chemotherapy, then we'll find out which patients are more prone to have a problem of a recurrent tumor in the adjacent urothelium covering organs like the urethra and the ureters. The other thing is life expectancy. Of course, we're seeing more and more older patients, and we have the life expectancy on average. I don't have the data for India, but I just have it for the US, and as an example here for Austria. And I always put that in here because we live a little bit longer here in Austria than probably in the US. But anyhow, this is not the message here is think about what is the comorbidity of the patient, what is his general status, what is his average life expectancy. I always tell that the patients, that is, how long are you going to live? And for that remaining years, and we have to talk about that, those remaining years, what do you expect in your life style? Anyhow, but that is not the only thing. We all know there are like patients, and I've done cystectomy way over 80 years old, and I've also done orthotopic neoblasts. Very few, but what it depends on, what type of urinary diversion is. What is the frailty scale? What's the frailty score? And you see here there are several ways of assessing the frailty score. There is the a frailty score from 1 to 11 in the literature, and there are actually several ones where you can by asking question, having the patients do performing in your office a simple tasks like standing on one leg and getting up and down from their chair a couple of times. Anyhow, there is ways of evaluating the frailty scale. Sometimes the anesthesiologists have that very nicely in their armamentarium. Now, then the question comes, cystectomy, that is not the question of this talk. There's been an indication, there has been chemotherapy, yes or no. And then what type of urinary diversion. And there's so many different ones. There is the orthotopic neobladder, which is, of course, for most of the patients when they're more fit and younger, the preferred option. But then there is the simplest one for the very comorbid elderly frail patients, which is ureterocutaneostomy, because if you don't have to use any bowel, then this patients will fare better. And then there is the most common one, that is prolonging the ureters with a segment of ileum to an external application, wet application, that is the ileal conduit. And then there is still the possibility of doing an internal urinary diversion in those patients where the urethra cannot be done, or where they have some other forms of malformation. Anyhow, there are different ones, and that is what it really makes it important for the patient, that he gets the information on all types of urinary diversion. Why? Look at this. This is a young patient I did, 29 years old. He was a photographer. He had a non-organ confined tumor, he carcinoma in situ. And with the expectancy, when he is cured, he has a life expectancy of something about 50 years, 50 years. And those 50 years, and you'll see that in a minute, with an ileal conduit, the most simple, not the most simple, but a simple and possible urinary diversion, will have quite some changes in his lifestyle, but also some comorbidities. I'm sorry, this is moving back. He is very fit. And so, number one, he needs and if possible, an orthotopic urinary diversion, but that only works if the sphincter, as you can see here, is really something which is preserved well, so he will be continent and still be able to volitionally void and empty his neobladder. And we have done work, and we have been able to show that the external sphincter does not really stop here, but it goes all the way on the upper side of the prostate. So you can preserve with your technique more of that sphincter. You can also preserve some of the internal sphincter, as you can see here on this on the inner side. And all that will really help him to get a really good continence with that orthotopic neobladder. And also with this is a fetal dissection, which we did many years back. You're looking from the left side into the pelvis. This is the prostate, the bladder, the seminal vesicle, and you can see the autonomic nerves engulfing the seminal vesicles. And these nerves are not only important for potency, which you may have heard in the prostate cancer session, but it is also for the continence, because there are sensory afferent nerves running in these nerve plexus, and they tell the patient, once the urine goes from the bladder into the urethra, urine is acid, and that acidity really creates a sensation, and that sensation makes the patient react with a contraction of the pelvic floor muscle. And if it doesn't have that sensory afferent nerves, then the urine will go on, and it will be in the penis when the patient feels it. He contracts, but it's a little bit too late. It creates ugly yellow stains in his underwear. So that is possible. That can be done with the knowledge, with what we have done here with dissections, and later on also shown that this here is where the crucial points are, where we should then really work on the sphincter and its function for having continence, not only potency, but continence as well, and it's early drop continence, which is then really created. But not only men, also women have bladder cancer, as we nicely seen in the previous talk. But it's also, why should they not have the benefit and the possibility of an orthotopic neobladder, like this lady, you know? And you can create that through a Pfannenstiel. She can go with her bikini to the beach, and nobody knows that she had a major surgery and she has an orthotopic neobladder. She is at that age, as you can see here, as you would assume, she is very fit. And with that, with the knowledge of that we can create an orthotopic neobladder to a functioning urethra with volitional voiding. But that means you have to preserve those nerves next to the urethra here, and you see that in purple. Sorry, in violet, and in purple you see the nerve that is actually going alongside the vagina into the urethra and helping her to have a real good functioning urethra. At the same time, having also the possibility of sexual intercourse with the preservation of the autonomic nerves. And that is created by preserving the autonomic nerves that go to the urethra by really having some of the adrenergic nerves going to the proximal and mid urethra that is preserved, and still have that preserved and have a good quality of life. And then what about the elderly lady? And really here depends on, here we need to know about frailty. This lady with an organ confined tumor that as you can see, she still has with her family an active lifestyle, and she is not as fit, but adequately fit. She's doing walking and not sports and stuff like that. But we still know that these patients will have a quality of life with their orthotopic neobladder, provided it's done in a good way, that it preserves continence and volitional voiding, again by carefully preventing or preserving the urethra, the urethral sphincter, plus the supplying nerves. With that said, there is also now the new way of doing a cystectomy, and that is robotic cystectomy. But then many of our colleagues, they don't stop at doing a robotic cystectomy, but they're also doing intracorporeal urinary diversion. Fine, great. I do robotic cystectomy, but what I don't see is, and you look here at a very recent study from the UK, and that very recent study from the UK showed that the majority of patients in both arms, in the robotic cystectomy and open cystectomy, those that were actually taken or screened and admitted to that prospective randomized study, the majority were organ confined patients, and the majority were also were at an age that was less than 70 years. So you could consider that a large portion of them was fit, and clinically frailty would be 1 to 2. Still, the minority of these patients, 10 to 12%, only got an orthotopic neobladder. And that means, sometimes we have a new technology, and we sometimes bend the indication for urinary diversion based on the technology and not on the desires and motivation of the patients. And that is the message I want to give. That is, it is the type of urinary diversion the patient will remember after 5 years or 10 years and for the rest of his life, and not the type of technology that was used for doing his cystectomy. But it's not everything can be done with an orthotopic neobladder. It can be done that the urethra is just a mess. It cannot be used due to carcinoma in situ, due to changes due to previous treatment, maybe also radiation, BCG, and other forms of final things. That is, then we can't use the urethra. We may have, in that case, and also in the comorbid elderly patients with a frailty, we'll see that in a minute. Of course, then a prolongation of the ureters with an ileal segment as an ileal conduit is a preferred form of urinary diversion. And If that is not desired, then the patient, of course, does have an option, very seldomly, but I just show you that armamentarium should be present. You can do an internal urinary diversion with the ureters hooked up to this, not to the sigmoid, but to an ileum segment that is connected to the rectosigmoid. That is uretero-rectosigmoidal coloscope, colos or the rectal urinary diversion. This is very seldom, but that can be done. It can be done without the fear of having adenocarcinoma of the rectal colon, which otherwise, if you put the ureters directly in there, would ensue. What about the very elderly, old patients, which we see more and more, and these, like in this lady, you wouldn't do a cystectomy unless she had really a miserable life and she was adequately fit for a cystectomy, but then she needs a urinary diversion. And if that is the case, then we would have to really think about that the nutritional status, spinal anesthesia, maybe for the cystectomy, so it is not, it does not affect your brain. Really, cystectomy should be then followed by ureterocutaneostomy, which means, this is the most simple urinary diversion. Yes, you can do it, and it's not the only thing that you have to be careful about. It's geriatric rehabilitation. You have to be careful about the ward. Just don't leave it too long in the IMC. That is also what patients are deranged. And so this patient, for example, of course, it's a well-selected patient, but she had a frailty index, modified frailty index, which was unchanged after 3 months. So she came back to her normal lifestyle. No nicturia. She did not have anemia. She did not have a pain. She had a normal social life, and she still comes with her younger sister, 86 years old, to the clinic and sees me, and she is really happy with her lifestyle. That is what a ureterocutaneostomy looks like. And that is something which we have to have in our type of urinary diversion as the most simple form of life. This is the most complicated one. Just show that. That is a very young or 6-year-old boy with a rhabdomyosarcoma. And because of his young age and all the metabolic changes, each of a gastrointestinal segment has decided to have he had a previous ileal conduit, which he did not tolerate. And I did an underversion, and we used the stomach, part of the stomach, part of the sigmoid and ileum all together just to counterbalance. And that's the most complicated way, but that is also a very selective thing. But coming back, what is the thing which we have to look for when we do a ileum conduit? Well, ileal conduit, if the patients have a long survival, then these patients do have a complication rate which is quite high already at 5 years, but it gets like almost every patient that lives 15 years and longer will have some form of complication. This is it's an open system, so it has a urinary tract infection. There may be a stenosis. There may be an elongation of the ileal segment and stuff like that, which then really may lead into renal insufficiency, stomal problems also, and some forms, other forms which need a reoperation. If you look at an orthotopic neobladder, the same thing. What is happening after like 10, 15, and here you see up to 10,000 days, roughly 30 years, 25 or 28 years. And it is, after the first 5 years, the urinary, the complication rate really stabilizes. There is a complication rate, but it's not increasing as we have seen after 5 or 15 years with the ileal conduit. So They have more or less acceptable GFR, and the mean time to GFR was especially in the first 2 years, and this may have been probably due to the neoadjuvant or adjuvant cisplatinum-based chemotherapy here. That is stomal problems, which we have an external application. This is just a terrible way of if you have that, it's a mess. But of course, everything can be treated, but especially the skin problems, that is something if a patient has that, then you really have to be careful. The other thing is recurrence of the upper urinary tract. As I told you, it's geothelium in the upper urinary tract, and if that happens, you need to have access to the upper urinary tract, and that can be done if you have a type of urinary diversion where you actually can access the ureters by a certain type of urinary diversion, which we use actually to have a direct access to the upper urinary tract. And if there's tumor stones or any other problems, then you may do it endoscopically without a reoperation. I do do a conjoint implantation of the ureters into the ileal conduit or into the neobladder, but nothing is without complications like here, a tumor recurrence right at the insertion of the ureters here. Just cut it out, and the patient really did survive with, in this case, with his neobladder, and it was not as simple, but it was an acceptable operation, and for being free of tumor, that is something which I would say is acceptable. Again, last thing is, as I've shown you, different ways of urinary diversion. There's not only one urinary diversion. And this is what the EAU guidelines say. And this is also what the experience is. The surgical outcome is depending on the surgeon, but also on the hospital. And it is also very mandatory that both have an experience with all common types of urinary diversion. Only then the patient, it can be a urinary diversion that fits the expectance and the lifestyle of a patient. And so again, we have to think about the patient. We have to think about his lifestyle. And with that, that should be my message. And I thank you very much for your listening. Thank you very much.
Thank you, Dr. Stenzel, for a very illustrative and informative talk. I think you gave a correct message that there is scope to increase the use of neobladder in our practice. But sometimes the issues are beyond the frailty index, why we choose the ileal conduit over a neobladder. Sometimes the patients do not have as much access to the healthcare, or their nutritional status, especially in India, does not allow us to the nutritional side effects of using a larger segment of bowel. All those kinds of issues are there. So do you choose your patients based purely on frailty index, or how do you go about that?
Yeah, absolutely. This is the frailty index. It's not as complicated as it sounds. It sometimes gets borderline in, let's say, in a 75 and plus year-old patient. And of course, I can see that. The only problem I have is you have patients that are younger than 70 years. You have patients that have an organ-confined disease. You have patients that are they have a lifestyle, they're working, they're managers, they're whatever they're doing, and even doctors. I've colleagues, yeah, and I do not see why 90% of these patients still do get an ileal conduit. I absolutely see the point that an ileal conduit is simple, but it's sometimes not as simple. If you think about the costs for the bags, for the plates, and I've seen bills here. If you think about 10, 20 years, how many bags and how many plates you need, it's quite a lot of money. And it is sometimes, even in remote areas, it is sometimes difficult to get it. And a good urinary diversion does not need any external appliances.
Thank you. I think in the interest of time, we'll move on. Thank you once again, and maybe good afternoon to you.
Okay, we have snow here, so it's different. It's just snowing outside.
Okay. Okay. Thank you so much for joining us.
Thank you. Have a nice meeting, a continuous meeting.
Thank you, sir, for the nice presentation. Next speaker, Professor Badrinath R. Koneti. He is the president of Alina Health Cancer Institute, Minneapolis, and professor of urology at Rush Medical College. He served as the Henry P. Rush Dean of the Rush Medical College, Rush University, and Senior Vice President for Clinical Affairs. He served as a past president of SIU. He was associate editor of many journals. He received various awards, notably Janningen Career Development Scholar Award. He authored and co-authored over 300 original publications and numerous book chapters. His talk today is on BCG refractory invasive urothelial cancer treatment options. So over to you, Dr. Badrinath Koneti, for your talk. Thank you.
Thank you for the opportunity to join you all, and hope you can hear me well. I'm going to try to put this on. You can see my slides, but there you go. Can you see my slides, and are they looking okay?
Yes, we can see your slides, and you are audible quite well.
Perfect. Thank you. Well, thank you again for the invitation to join you. I'm actually in India, but in Bangalore, and I had some other commitments, so I couldn't make it Delhi. I apologize. I wish I could be there with you all in person. But this is a great opportunity, and I really appreciate being connected with you all. I was going to give you an overview of salvage intravesical therapy for NMIBC, or non-muscle invasive bladder cancer. Now, why is it important to worry about non-muscle invasive bladder cancer? Of course, it's not invasive. Should we be concerned? If you actually look back, this is an older paper, but it's really important to highlight one fact, that if you don't do anything about patients with high-risk non-muscle invasive bladder cancer, maybe the low-grade ones, you can perhaps treat them conservatively or even with surveillance. But the ones that are high-risk, high-grade TA, T1, etc., untreated or undertreated, they can have a very high mortality rate of up to 34%. So though they are not invasive, and we have even seen patients with CIS who go straight to muscle invasive disease or go to metastatic disease. I've even had patients who show up with just CIS consistently in the bladder and bony mets in the spine. So you cannot ignore some of these high-risk non-muscle invasive patients. And so therefore, the only real treatment that works very well in these patients has been BCG. Chemotherapy doesn't work as well, but not everybody responds to BCG, as we know. About a half will respond the first time for induction BCG, and with the second induction course, you may salvage another 20%, but eventually a lot of these patients do recur. And we have developed a cohort of patients now who are considered to be BCG unresponsive, and this is the consensus definition of BCG unresponsive disease. Patients who have persistent or recurrent CIS alone or with Ta/T1 disease within 12 months of completion of adequate BCG. Adequate BCG is considered as a full 6-week induction course plus at least 2 of 3 of one maintenance course. So at least 8 total installations, ideally 9. Now, patients who fail 2 successive induction courses are also considered BCG unresponsive. And if patients develop a recurrent high-grade Ta/T1 disease within 6 months of completion of adequate BCG, they're considered BCG unresponsive. And then all patients who have BCG refractory tumors who've received 2 successive installations and nothing has happened, or they go through an entire induction course and there still is residual disease. They're all potential candidates for additional therapy beyond BCG. That doesn't seem to work. Now, for the last 20 or 30 years, BCG got approved for CIS treatment in the United States in 1987. So since that time, we have identified a group of patients in whom this doesn't work, and many things have been tried. The most recent attempts, historically, they've always been chemotherapy-directed attempts in patients who have not responded to BCG. But over the past couple of decades, several other innovative modifications have been tried in this subset of patients. Heated mitomycin C was tried. This is, as you all know, mitomycin C in solution form that is irrigated through the bladder. Initially showed great and promising responses, but more definitive trial reported last year showed HIVEC-2 showed no response or inadequate difference between the two arms. So that really, I feel, doesn't work as well as we thought it would. Then radiofrequency-induced thermochemotherapy has been tried. Here, the idea is to place radiofrequency needles within the bladder, heat it up to a temperature of about 40 degrees, and prep the bladder for mitomycin installation with greater cytotoxicity and absorption of the mitomycin. Now, that also didn't really work. The Wright trial was one of the largest ones. All the earlier studies had shown promise, but this trial had to be stopped due to a much higher than anticipated recurrence rate in the CIS arm. The other thing that has been tried was BCG plus interferon alpha 2B, and there was about a 900 or 1,000 patient trial that Mike O'Donnell did. Initially, lots of great responses in the one-arm large cohort, but then when they randomized and compared it to BCG alone, it really didn't pan out. So that doesn't seem to work, though it is less toxic than BCG alone. And better tolerated by patients. So you can actually reduce the BCG dose and substitute the interferon alpha 2B, but the response is not great. Mycobacterial cell wall has been tried with the idea that all the antigenicity of BCG comes from the cell wall. And so we retain that and get rid of the DNA within the cell, which avoids the cytotoxicity. That also didn't really work. It was called M-Flay, or Mycobacterium flay. And initially, there was an expected response rate of 40%. Instead of that, the response rate was about half of that. And the FDA asked the company to go back and do another phase 3 to really find out if this works. And that has not yet happened. Vicinium is an interesting ADC, essentially. It's an antibody drug conjugate. It's got an antibody targeted against EpCAM with a payload of the Pseudomonas endotoxin attached to it. Achieved quite reasonable complete responses of about 40% or so at 9 months. But there were lots of issues with the trial, and the FDA did not approve it. They issued a complete response letter and asked the company to go back and do some studies to ensure that the manufacturing was accurate. And they also asked for additional phase 3 data, which has not yet been forthcoming. And historically, valrubicin has been tried as a single-agent chemotherapy. It's a relative of doxorubicin. And for a long time, it was the only drug FDA approved for patients who had, with CIS, who had failed BCG therapy. And the original 90-person study had a 21% complete response, which is only sustained in about 7% of patients at 30 months. So it was quite pathetic, and the cost was enormous. It was $3,000 in installation, so it's never really caught on. The other hot agent right now that everybody, or agents that everybody is using in the US and has become the de facto standard in patients who have failed BCG and either cannot tolerate or get one of the other FDA-approved treatments. This has become the go-tos. Gemcitabine plus docetaxel has been promoted by Mike O'Donnell, who initially did a lot of the studies. Mike and I did a lot of studies combining gemcitabine and mitomycin initially. That seemed to work, but the mitomycin is a lot more toxic and causes a lot more side effects. The docetaxel is much better in that context. So you instill a gram of gemcitabine, drain it, leave it in there for about 60 to 90 minutes, drain it, and then instill 37.5 milligrams of docetaxel, leave that in for another 90 minutes, drain it. So this is once a week for 6 weeks, followed by monthly maintenance for up to 2 years. So in this study, which had about 107 patients, Mike and colleagues reported very, very impressive response rate. So this is in all patients taken from the beginning of the trial. At 24 months, 80% of patients had responded. And if you take only the subset of patients who had shown a complete response after the initial 3 months or the initial induction course, 91% maintained the response at 2 years. I mean, this is blowing every other treatment out of the water at this point, given these incredibly high response rates. And both papillary disease and CIS seem to respond equally well, which is quite unusual because oftentimes many of these new treatments do not get as good a response in CIS patients as they do for papillary disease. I don't know how common CIS is in India. In other places, for example, in China, CIS is very uncommon. Only about 10% of patients report CIS there. In the US, it's about 20% of patients, 20 to 22% of patients will have CIS, either concomitantly or individually. And if you do systematic biopsies, it may be slightly higher even. But regardless, the response rate for patients with CIS alone, as well as, and Mike even believes CIS may respond even better than papillary disease to this combination therapy. But still, that is only a cohort study of single arm with no comparator. So to really address whether gemdosi is a better treatment, there's an ongoing trial sponsored by ECOG in the US. It's called the BRIDGE trial. It's actually designed as a non-inferiority trial. And it's a phase 3 conducted in patients who are BCG naive. So these are newly diagnosed bladder cancer patients, and they're going to get treated with either BCG or with gemdosi in a one-on-one randomization. And because it's a non-inferiority trial, the sample size is large, about 870 patients. And they're going to look at overall event-free survival as a primary endpoint, and several others, cystectomy-free, progression-free, et cetera, and also safety and toxicity. So this is still ongoing, and we await the results of this trial to definitively understand the benefit of gemdosi. Having used it in many patients, I will say, and many of you may have also done that, the safety and toxicity are quite good. I mean, it's a very tolerable regimen, and patients tolerate it quite well. Now, on to a couple of FDA-approved treatments for BCG unresponsive, high-risk non-muscle invasive bladder cancer. The Keynote 057 trial, which used single-agent pembrolizumab, which is a PD-1 inhibitor, in patients every 3 weeks for a total of at least 2 years, was done. And in this is the report for cohort A. Cohort A was CIS only, CIS plus minus papillary disease. And then there was cohort B, which was only papillary disease without CIS. And in this cohort, which was the first to be reported out, they had 102 patients, of whom 40% responded at 3 months. And what was considered a complete response was if you give them 3 months worth of therapy and then do a cystoscopy and biopsy, and there's no evidence of a high-risk disease. They could have low-grade recurrence, but that was not considered a disease for the purpose of this trial. Only if they had high-grade recurrence, CIS or high-grade TA or T1, that was considered a non-complete response or a disease recurrence. So 40% of patients had lack of high-grade disease at 3 months, and luckily nobody progressed in that short time period. Now, if you look at the data as it's gone through, and of those patients who responded, about half, maybe about 20% or so, retained their response at 12 months or 1 year. And at 36 months, about 28% of this group went on to retain that complete response. So there was a benefit to patients with CIS alone. And based on this, the FDA granted approval for use of the pembrolizumab in patients with BCG unresponsive disease. But as you can imagine, it's every 3-week therapy, it's expensive, and about 13% of patients had a grade 3 or grade 4 SAEs or serious adverse events. So there is a fair amount of toxicity with these systemic checkpoint inhibitors, as one can imagine. So not everybody may be able to tolerate it. Last year, Andrea Necki reported out on cohort B, which was no CIS, just papillary disease. And this cohort had 132 patients, of whom 43% had high-grade T1 disease. And the average number of cycles patients received was about 9.5. So that's every 3 weeks. It's less than 9 months, maybe about 8 months or so of treatment on average. And patients were followed for about 4 years, almost 45 months. And the response rate seemed to be a little bit better because 43% had a complete response or were disease-free or for high-grade disease at 12 months. And any disease-free, even low-grade disease-free, was 41%. So that's quite impressive. At 12 months, 41%. So that's almost double the number and as compared to cohort A. So clearly papillary disease alone responds better to pembrolizumab systemically than the CIS plus minus papillary disease. And other parameters, PFS and overall survival, are also quite reasonably good. The other drug that has been used, checkpoint inhibitor that's been used in this context, has been atezolizumab, which is a PD-L1 inhibitor. Generally, this is gestalt, no head-to-head comparisons. It seems as though PD-1 inhibitors seem to work better than PD-L1s, but that's just my feeling, and some other people seem to think that based on data. And atezo is a PD-L1. This trial, which was sponsored by SWOG, had 172 patients. As you can see, 6-month complete response with CIS was only 27%, as opposed to almost 40% with Pembro. And some patients did retain this response at 12 months. And overall, CIS did fairly poorly, only 17% responded, and the non-CIS papillary disease seemed to do well. But the treatment-related adverse events were very high. The prevalence was 86%, so pretty much almost everybody got some level of toxicity. And in this secondary study, GU123, they combined atezo with BCG to see if there was any benefit. So there were 2 cohorts. One cohort got only atezo monotherapy. The second cohort got atezo plus BCG, and a very small study, only 24 patients, 2 years of atezo were given in these patients. And the duration of response in cohort A, which was atezo alone, was not great, only about 6 months. And at the point of time in which this was reported, cohort 1B, which is the combination arm, the duration of response had not been reported. We await some follow-up on this as well. Nadofaragene faradenovec, which has a trade name of Astelitrin, is another drug that's been FDA approved. This was a trial again in BCG unresponsive patients. They had 103 patients in this study who had CIS, and then 48 patients who had high-grade T or T1. So they had 2 separate cohorts, and as you can see, the responses shown in the table were better for the papillary disease patients, or almost 73% responded at 3 months, and only 53% responded with CIS. So there's a 20% difference in response rates. But overall, about 60% of all patients who received the agent, of the 150 or so, 151 patients or so who received the medication, did get a complete response or freedom from high-grade disease at 3 months. And the duration of response was about 7 months. And at 12 months, at 1 year, about a third, almost 30% of patients retained the response at 1 year. So based on this, the FDA approved this agent. This is some data at 5 years out that we're in the process of preparing for publication. This has just been submitted. And as you can see here, papillary disease does seem to respond better to this medication. Nadofaragene faradenovec is really a gene therapy. So it is the adenovirus that has the gene for interferon alpha-2b incorporated within it, and also has SYN3, which is a surfactant on the surface. The SYN3 allows the adenovirus to bind better to the bladder epithelium, and that allows the integration of the virus containing the interferon alpha-2b into the cells, and local production of interferon alpha-2b, which excites a response which enhances the response in cell kill. The other advantage of nadofaragene is that it's just 1 instillation given every 3 months. So during a year, you just have to give 4 instillations, as opposed to most of the others. If it's systemic immunotherapy, it's every 3 weeks. All the others, including BCG, are all once a week for 6 weeks, plus maintenance doses for 3 weeks duration, multiple times during the year. Whereas this is just 1 instillation 4 times a year. So it's 4 treatments per whole year. So it's a lot less. This is another agent which is not yet FDA approved, but has caught a lot of interest. It's the IL-15 superagonist, which has an unpronounceable name, in my opinion, nogapendekin alpha inbacicept, or N803 for short. It is a fusion protein of a human IL-15 bound to the Fc fragment of IgG, which allows it to bind to natural killer cells and memory T cells. What this IL-15 does is serves as a co-stimulant to enhance the trained immunity by which BCG is thought to act. So BCG is thought to act by a trained immunity mechanism, which recruits all of these other cells. And this helps speed up that process as well as enhance the response. And in the QUILT study, there was a 3-arm study where they this is interesting because in BCG unresponsive patients, they still gave them BCG plus this BCG enhancer, if you will. So 1 arm of CIS plus minus papillary disease got the combination of the 2 drugs, NAI and BCG. Second cohort was high-grade Ta/T1 with NAI plus BCG, and the third one was just NAI, no BCG. And it did seem like the combination worked quite well. 71% of patients responded. 45 at 3 to 6 months, 45% retained the response at 12 months, and another third at 18 months. Women, interestingly, had a much lower response. And one thing about this was patients could be re-induced. So after the initial 6 weeks, it didn't work. They got some more. They got another 6-week course. And in cohort B, which was patients with papillary-only disease, median disease-free survival was a little over a year and a half. But the drug alone, NAI alone, did not work. So that cohort was stopped early due to futility. So if this has to be given, it has to be given in combination with BCG. And it does seem to work. They did not get FDA approval because of some questions about the manufacturing process. They got a complete response from the FDA, and they're going through some of their data and checking some of their manufacturing, and they may go back to the FDA to get approval. And if they do, then that will be something else that becomes available to treat patients with significantly higher response rates than the other two treatments that were previously approved in the recent past. Another one that's really promising is crestimogene granadenorepvec. Again, another unpronounceable name. This goes by CG0070, and this has been in development by Cell Genesis for almost 2 decades, I would say. And this, again, is an immunotherapy. This is an adenovirus that contains the gene for GM-CSF, along with the E2F1 promoter. And the adenovirus will actually bind to the CAR, or adenovirus Coxsackie receptor, and then the virus replicates internally, producing a lot of GM-CSF locally, which recruits immune cells, but it can also cause toxicity and cell death. This is the BOND trial that is ongoing currently. The target enrollment is 116 patients. And in this too, patients get weekly doses of this drug for 6 weeks. And if they don't respond, they get another induction for 6 weeks, and they keep on maintenance, just like for BCG, 3 weekly maintenance for a total of 1 year. And then you do every 6-month maintenance for the second year. Same sort of targets for assessing response. And this is an early report, or actually an interim report at last year's SUO, with only 66 patients analyzed of the 116 that enrolled. Enrollment has stopped in this trial. And at that time of report, complete response rate was 75%. So this is even better than the NAI trial. So as you can see, as these newer agents are coming on board, the response rates seem to be getting much, much better as time goes on. And about 63% of patients had a complete response at 6 months, and the duration of response was respectable. With almost 2/3, actually 3/4 of the patients retaining a complete response for over 6 months. So we'll wait to see what the final trial report shows us. Just a quick recap of all the therapies that have either been reported out in some measure or even taken all the way to FDA approval. As you can see, there's the ones that I've highlighted are the ones that are of the most interest at this point in time. So the N803, which it's a high complete response rate, Gemdosi, with almost 100% reported response rate in the original trials, and then the BOND trial, which has reported out on CG0070. So these are the ones to watch. All the others, as you can see, are in the 40s and 50s, whereas these are much higher initial response rate with much better disease-free survival at 12 and 24 months. A couple of other ones to keep your eyes on. The TAR-200 is literally, it's called the pretzel. Essentially, it's a polymer tube that is folded into a pretzel and has an osmotic mechanism. Urine flows into it and displaces the gemcitabine that's contained within this tubing. And this has to be implanted cystoscopically into the bladder. You basically take the tube through a cystoscope and basically inject it into the bladder, and then it folds over automatically. It has some memory in the material that folds over, and then you have to go back in and retrieve it every 3 weeks or so. So it has to be replaced. And the TAR-200 trial uses just one of these pretzels with gemcitabine. It's a 200-patient trial. There was a preliminary report of only 22 patients. The trial has 3 arms, and they are combining the TAR-200 with a PD-L1, with a PD-1 inhibitor, setrilimab. But there's also a cohort with TAR-200 alone and the checkpoint inhibitor setrilimab alone. And they reported on cohort 2 and cohort 3 as a preliminary report last year, which again showed great, or at least very promising responses. They had 72% complete response rate, so in line with some of the other ones that we've seen, which are more recent. And just the PD-1 alone elicited a 38% complete response. So that was excellent and it's promising. So we'll keep eyes peeled for this. And they're coming out with several other versions of the pretzel containing different drugs. Another one they're coming out with is the pretzel containing erdafitinib, which is a FGFR3 inhibitor. As we all know, FGFR3 is widely expressed in bladder cancer, particularly in lower risk bladder cancers. It's one of the first things to be expressed as the cancer transformation occurs. And there's a trial using oral erdafitinib, which is a FGFR3 inhibitor used in many other diseases, but it's now being tried in bladder cancer. And the TOR2 trial, which in its first cohort was using oral erdafitinib at the dose of 6 milligrams in patients with non-muscle invasive disease, which is high risk. And they actually stopped the trial early because of poor accrual after enrolling about 73 patients. The problem with this is you can only use the drug after you test the tumor for FGFR3 positivity, and it has to be positive, and then you can use this drug. And it's only in patients with papillary TA or T1 disease. And they had to screen a lot of patients to actually get enough or a reasonable number of patients with FGFR alterations. And they randomized them to either erdafitinib or chemotherapy. And they had treatment of choice as a comparator arm. And what they found was erdafitinib did work. So it had an impressive response rate compared to the others, but side effects are quite significant. So while it seems promising, we have to worry about a lot of the side effects. Lots of other trials ongoing right now.
Hello.
And yeah.
Yeah, can we just move a little quickly?
Yeah, I'm almost done. This is my last slide. And this is all the trials that are ongoing right now. Several of them, we'll see what they all show, but lots of activity in this space. So to summarize, BCG unresponsive disease is now much better defined. Clearly with BCG shortage, there's a lot of search for alternatives. We have at least 2 FDA-approved agents and 2 that have been fast-tracked. We have at least the first gene therapy and maybe the second one for cancer, particularly for bladder cancer. And there is some evidence now that systemic immunotherapy, either by itself or in combination, may be quite beneficial in this population. But if gemcitabine docetaxel combination works, then that's going to be cheap and plentifully available and easy to use. And there may be also, based on the type of disease, whether it's CIS or Ta/T1 papillary disease, we may need to design specific treatment types. So not all these drugs may work in all of these disease states equally well. Thank you very much for your attention.
Thank you, Dr. Badari, for your elaborated presentation. I think the slides were quite good and self-explanatory, all the options you have described. Audience has any question? So no question from the audience. Now we will move to our next talk, which will be presented by Dr. Shilpa Gupta, who is the only speaker in this session who could join us physically. She is the director of the genitourinary medical oncology at Taussig Cancer Institute in Cleveland, Ohio. Dr. Gupta obtained her degree from India, Lady Harding Medical College, and then completed his residency in internal medicine at University of Connecticut Health Center. Then she completed hematology and oncology fellowship at Georgetown University, followed by a genitourinary oncology translational research fellowship at Thomas Jefferson University. She is actively involved in research. Her interest focus on novel drug development and understanding biomarkers of response and resistance to therapies in bladder cancer. So over to Dr. Gupta for her lecture, please.
Thank you. That was a great presentation by Dr. Konedi. A lot of progress is going on in the field. Can you? Yeah, okay. I'm really glad to be here and sorry to miss so many people in person, including Dr. Sudhir. Sorry. So I'll talk about novel therapies and their toxicity management in urothelial cancer. And I know in India, the novel therapies that is available are the immune checkpoint inhibitors. The antibody drug conjugates are not available yet, but I'll briefly touch over that. And then there's the FGFR inhibitor or the fitinib. I don't know if that's available or not. I don't. It is available, so I'll talk about that as well. So immunotherapy related adverse events are really important to know for everyone because these drugs are now being more available in India. And my personal experience, my uncle who was being treated with atezolizumab got actually severe myocarditis back in Lucknow, and he died from this toxicity. So it's really important, and it was a lot of interaction with the doctors to go over how to manage this. So immune checkpoint inhibitors have really changed the way we practice bladder cancer, but immune related adverse events can really happen from head to toe. Unlike chemotherapy, it is predictable, and it can sometimes be fatal if not really caught in time and treated early on. And the fatal immune related adverse events include neurotoxicity, cardiotoxicity, and pulmonary toxicity. And everyone is familiar with this, but this is a picture showing that pretty much any organ from head to toe can be affected, and sometimes we may not even suspect that it's an immune related AE, and when it could be and can be potentially life threatening. For example, uveitis and a lot of conditions like Sjogren's syndrome. These are the rare ones. Encephalitis can be fatal. Pneumonitis is what we see most commonly, although it does occur in only less than 5% patients. Colitis is quite common, and a variety of skin rashes and dermatologic toxicity is common. Myocarditis here in bold is really very, very dangerous IRAE, which requires more than steroids and is not a very well-known side effect that we know how to manage, and it's more invariably fatal if you talk to the experts, even in cardio oncology. Then there's rheumatologic side effects and hematologic and GI toxicities. So this is just showing, what is the most common side effect. We see that rashes or skin toxicity accounts for about 40% of toxicity, followed by colitis or other forms of GI toxicities. And then there's the other rare, each around 10% of hepatic, pulmonary, hematologic, etc. Now, this is showing, the duration of treatment and when some particular side effects occur, especially with regards to PD-1, PD-L1 inhibitors. So we see that colitis occurs at around week 5 or 6, and initially we see rash. So rash is something that occurs early on, and pneumonitis does tend to occur a little bit later. But not to say that even after patients have stopped immunotherapy, cases of fatal CNS toxicity have been described even 7 months after stopping immunotherapy. So we have to always be careful that just because somebody is not on active immunotherapy, they cannot get a delayed toxicity. And the basic framework is that anytime an IRAE is suspected or immune-related adverse event suspected, rule out other etiologies and then grade them. Grade 1, of course, is very mild, where we usually don't worry about it much, but follow cautiously. Supportive treatment is given, continue the immunotherapy. Grade 2 is a little more severe, where I tend to hold the immunotherapy and consider steroids. If it's a rash, do topical steroids. If it is more severe, we do systemic steroids, which is grade 3, grade 4. With grade 3, really cannot continue immunotherapy while being treated. And we need to do a really long and slow taper of high-dose steroids, which could be 0.1 to 1 milligram of prednisone equivalent, can be Solumedrol if patient is inpatient, and consider other immunosuppression agents if steroid refractory. Grade 4 is really the most severe form, where we really worry about deaths. We need to permanently discontinue the immunotherapy, keep the patient admitted till they show signs of recovery. And the main thing is to consider all these specialties involved. A multidisciplinary team of medical specialties is key. So in the interest of time, I will go a little quickly. So let's talk about endocrine toxicities, which can be very commonly seen: hypothyroidism or hyperthyroidism, thyroiditis, hypophysitis, adrenal insufficiency, and diabetes. Now, in cases of hypo or hyperthyroidism, for the most part, it's a lab diagnosis unless patients get some severe fatigue. when we also need to work up for pituitary dysfunction like hypophysitis. And adrenal insufficiency is really very common and goes unnoticed. So in my practice, I do check for serum cortisol, LH, FSH, TSH, free T4, T3, and many times we figure out the cause of fatigue was adrenal insufficiency, in which case you can put on hydrocortisone and they can still continue treatment if they don't need additional steroids. Diabetes can be seen pretty frequently, even in patients who are not diabetics at baseline. And that is, in a way, easy to manage with insulin, and still you can continue immunotherapy. You don't need steroids for that. And same with hypothyroidism. For hypothyroidism, you do hormone replacement. And these can actually linger on, and patients may require lifelong hormonal replacement. Just to give a framework of how to manage the thyroid toxicity, and when patients are symptomatic, you start the hormone replacement and go from there. So again, the same framework, grade 1, grade 2, really grade 1, you don't need to do thyroid replacement. If TSH is only more than 10, you consider that. Grade 2, grade 3, grade 4, you really need to start treatment. Adrenal toxicities, again, you have to hold the immunotherapy for grade 2 or higher, start the adrenal hormone replacement, also refer to endocrinologist for close follow-up, and go from there. Rheumatologic toxicities, many times patients will report myalgias, arthralgias, joint pains, and really have to make sure that nothing more severe is going on. Even polymyalgia rheumatica can occur. So it's very crucial to involve a rheumatologist for management and a proper diagnosis, because with steroids, everything is manageable and treatable. But if left untreated, it can become disabling. I've personally seen a patient who had a great response to cancer but got debilitating rheumatoid arthritis. Dermatologic toxicities are important because they can occur in a wide variety. Grade 1 can be just maculopapular rash covering less than 10% of the body surface area, in which case we use emollients, topical corticosteroids, and topical antihistamines. Refer to dermatologist. Grade 2 will be 10 to 30% of BSA involvement. We really need high potency topical steroids and oral steroids for the most part. If we are using more than 10 milligram dose of prednisone equivalent, we should not give immunotherapy till we have tapered it down to 10. And most of these times, it's important to understand that patients who get these side effects, which are severe, are also the best responders. So many times, even if you're not able to resume immunotherapy, they'll keep responding. And it's better to take care of the adverse event adequately instead of rushing to resume immunotherapy. And for grade 3 and grade 4, very important to consult dermatology. Really, it can be bullous dermatitis, which can be fatal. It can be toxic epidermal necrolysis. These are some of the serious kind of skin toxicities that patients can have and can become really difficult to handle without the help of a dermatologist. Hepatic toxicities, for the most part, we'll see these as abnormal lab abnormalities, and these are the grades defined by the level of AST, ALT elevation. Again, the general framework is to hold the immunotherapy for grade 2 or higher, start steroids, and the teaching is that be in no rush to taper the steroids. Many times they need about 8 to 12 weeks of steroids. And then even so, they need to remain on 10 milligram of prednisone for long term. And I'm usually very cautious about rechallenging and in no rush about rechallenging for grade 2. Grade 3 or grade 4 hepatic toxicities, I don't rechallenge them because it can be really dangerous. Gastrointestinal toxicities, anytime you're starting treatment in patients, do a good teaching about what frequency of loose stools they should be worried about. Less than 4 stools a day is grade 1, where you can manage easily with symptomatic oral fluids, loperamide, avoid high fiber lactose diet. Grade 2 can become quite concerning. You have to hold immunotherapy, start steroids. In fact, many times we have to admit these patients to the hospital, give them aggressive hydration, and start 1 to 2 milligram per kilogram of steroids. And, in my experience, many times a lot of physicians are hesitant about high dose steroids. I think you just have to let go of that hesitation and be bold to just start steroids. If there's no response seen within 3 to 5 days, start infliximab, and in refractory cases, use vedolizumab. Of course, you need to consult GI oncologist. Now, this can happen with any PD-1, PD-L1 inhibitor like atezo, nivolumab, durvalumab. But when you add CTLA-4 inhibitor like Yervoy, the toxicity risk of colitis is really increased tenfold. And the rates of hospitalization increase as well. So that is really key to note. They many times need complete bowel rest, they need a colonoscopy, and really need close follow-up in the hospital. This is a case of enterocolitis with severe ipilimumab, nivolumab combination. Pulmonary toxicity, again, can be from asymptomatic to symptomatic to severe. Asymptomatic, if you just do an imaging and see some ground glass opacities, patient is asymptomatic, you can continue treatment but monitor closely. But when patients become symptomatic, you really have to start steroids, again, at half to 1 mg per kilogram prednisone dose. But if symptoms are severe, then even go higher to 1 to 2 mg of prednisone equivalent. And if it's grade 3, where they become hypoxic and you need to have them admitted to the hospital, start oxygen, and permanently discontinue immunotherapy. Of course, start higher dose steroids. They also need stress dose steroids many times, like 1 gram solumedrol every 8 hours if they have severe life-threatening toxicity. And this is some of the manifestations of the pulmonary toxicity, as you can see, depending on all these ground glass opacities. So it's important for having a pulmonologist involved to do a bronchoscopy and rule out other causes of infection. And it goes without saying, when we are doing these high-dose steroids in anybody for a prolonged time, they need to have the prophylaxis with Bactrim for PCP. They also need viral prophylaxis. So that's why it's really important to involve infectious disease and the related specialties. Neurologic toxicities, really, we have to stop the immunotherapy immediately because these can become fatal and there is no role for rechallenging and they require high-dose steroids. We have seen cases of Guillain-Barré where they don't need steroids and do well with IVIG, but you cannot rechallenge with immunotherapy. Cardiac toxicity, in my opinion, really is the most life-threatening, and I've talked to cardio-oncologists even in the US who, when you have that cardiac severe myocarditis and the triple M syndrome of myocarditis, myasthenia, and myositis, that's really a death sentence, and you really need to get these patients in the ICU and start pulse dose steroids with 1 gram solumedrol every 8 hours. And there needs to be no hesitancy in doing that. Have to monitor their troponins, do echocardiogram. It's really patient belongs in the ICU if they have any signs of cardiotoxicity. And this tells us how it can also result in electrical disturbances, pericarditis, myocarditis, and temporal arteritis. So need to have a multidisciplinary intensive care team. So if you're suspecting immunotherapy-induced cardiac toxicity, immediately admit to the hospital, do the regular workup, troponins, and depending on the severity, start steroids. And if with solumedrol, it is not even controlled, consider ATG, infliximab, or mycophenolate mofetil. And these are also, you need a team to manage these kind of immune suppressants. Typically, people dealing with heme malignancies are very aware of these. Renal toxicities, again, can happen. Nephritis for grade 2 or higher, hold the immunotherapy. And if you've ruled out other causes of renal toxicity, then consider a renal biopsy, which will show immune infiltrates. Start high-dose steroids, taper them slowly, and don't re-challenge for grade 3 or 4. Ocular toxicities can happen. It could just be sometimes just, mild vision changes, but severe changes can be uveitis, can also result in blindness. So it's very important to include ophthalmology since these are really beyond our expertise. So in summary, key points are to carefully monitor patients for immune-related adverse events. Even when patients are doing well, it's not a guarantee that they will not get IRAEs later on. Do not delay starting steroids, and multidisciplinary team management is very important for IRAEs. Now, antibody drug conjugates are a newer class of drugs. These are really the latest drugs in US and in India. I believe it will be launched in December. And enfortumab vedotin, which is currently used for immunotherapy refractory or platinum refractory bladder cancer, and more recently it got approved in combination with pembrolizumab for frontline treatment. But of course, cost might be a big prohibitive factor. So platinums may still be used here more, but this will be available. Then this has some unique side effects, with this. As you know, this is a anti-Nectin-4 antibody, which also has the active agent of MMAE, which is a microtubule disrupting agent, and that's what results in bad neuropathy, which is even severe, more severe than cisplatin. And it can become disabling. In fact, it's not just peripheral, but it can also be motor neuropathy. Rash is another big side effect of this drug, which can become fatal. There have been toxic deaths from rash. So every time I see a patient on this agent, I do a skin exam, make sure that they don't have a rash. And it can also cause dry eye and other ocular disorders, which are not life-threatening. But the other unique toxicity of this agent is catastrophic diabetes in a non-diabetic patient. So we've seen patients develop diabetic ketoacidosis who are baseline not diabetic. So there's once you have experience with this, you'll know that if sugars are over 250, you cannot treat the patient, rule out diabetes, go from there. And peripheral neuropathy really becomes very disabling, may not even resolve. So it's very important to stop this drug and be in no rush to resume. So this is kind of some of the worrisome toxicities, and the mechanism is that Nectin-4 is expressed in the skin, and the antibody causes these off treatment effects through the Nectin-4 mechanism. And over 50% patients get some kind of rash, but the serious ones which can lead to death are Stevens-Johnson's and toxic epidermal necrolysis. Very important to have dermatology involved. So when a patient presents like this, we immediately start topical and oral steroids, refer to dermatologist, go from there. FGFR inhibitors are the newer agents for patients who have FGFR alterations. Really only about 10 to 15% patients have those in their tumor. So it's not a widely used drug, but it is a very toxic drug. Even though it's an oral drug, we see a lot of mucositis with this. We can see retinal detachment in this. So it's very important to have ophthalmology involved, especially in diabetics who already have retinal problems. Hyperphosphatemia is a lab abnormality. Have to monitor, start low phosphate diet. And it can also lead to really bad peeling of the nails and skin toxicity. So I have to monitor patients for that, stop the drug and reduce the dose and do symptomatic management. I would like to highlight that this app is through the Society of Immunotherapy Treatment Guidelines. It's a free app. It's good to have it on the phone, and it guides you what treatment to use for immunotherapy-related adverse events. And I'm actually part of those guidelines. So is Dr. Kennedy. And I keep it on my phone because it's really very handy to use at the point of care. There's also the ASCO guidelines for immunotherapy side effect management, which you can access for free. So bottom line is to be aware of all these unique side effects as we get used to more of these drugs. Thank you.
Thank you, Dr. Shilpa, for highlighting the issues. So do you really recommend that beyond the realms of the trial setting or a multi-speciality high-level hospital, one should really venture into trying these immunotherapy agents? So beyond the realms of the trial settings where the patients are being constantly monitored, giving this immunotherapy to the patients can be really without the support of a multi-specialty care. It may be
The patient during their every infusion and do a good physical exam and take a good history. And if the patient is
How
complaining.
frequent do you get the patients investigated for?
So
once you
I
give
see,
this?
if let's say we see them every month, and in between they contact us if they have any side effects. But if you're using atezolizumab, it's see them every time they're coming, and in between as needed. But the key is that if they're complaining of fatigue, mild fatigue is normal, but severe fatigue you really have to do workup. So I think if you're seeing them every time, that is a good practice.
Thank you.
Thank you to all the chairpersons. If Dr. Vivek could stay over for the next session. I'd like to call upon stage Dr. P.N. Dogra sir to chair the next session.
Let's go ahead with this program. We are already running late. And the first speaker is Dr. Gagan Prakash.
Online.
This is online?
Yes, sir.
Okay. Is it? Okay.
Good evening, everybody.
Good evening.
Hi, sir. Good evening. Good to see you.
Yeah, please go ahead.
I hope my slide is seen.
Yes, we can see that.
Right. So, thank you. I would like to thank the members and office bearers of SOGO and Dr. Rawal and Amitabh for this invitation, particularly for the cancer that I'm really keen on managing. And also it comes at a good time because just a few days from now, we are in the Testicular Cancer Awareness Month that happens to be in April every year. So when the topic was shared to me, I actually had to think about, what the title meant and what was required from me for this talk. The incidence of testicular cancer in India is actually not as bothersome. It is still included as one of the rare geotumors. But in some parts of the world, particularly in many of the European countries, we can see that there is a rise in the incidence in the last few years and decades. And in some of the countries, particularly, the rise has been rather concerning. And there's been a correlation to, with whether the country is a low middle income or a high income. And in the high income countries, the incidence seems to be rising. Now, this is a great read on the history of testicular cancer by Larry Einhorn himself. This was like an editorial in the Journal of Clinical Oncology a few years back. Now, if you look at the last few decades, then the testicular cancer main studies and main landmark things which have been done has been generally to get good oncological outcomes. But if you see in the recent years, most of the research which has been focused on testicular cancer is looking at mitigating the long-term toxicity because there's been more and more realization that that is a concern. Now, as oncologists, we are always in this dilemma or in this, trying to create a balance between getting the best oncological outcomes for a patient and at the same time minimizing the treatment-related toxicity and decisions whether to treat or to keep these patients on surveillance or which modality of treatment should be better based on the stage that the patient with testicular cancer is, or if the chemotherapy is to be given, whether it should be how many cycles of chemotherapy, or if surgery is to be planned, what should be the technique of surgery, whether it should be an open one or it should be a minimally invasive one. But essentially, it's just trying to create a balance between oncological outcomes and the toxicity. Now, one of the important things that happened recently was an update of the IGCCG stratification or classification, which happens to be the first step when we are treating our testicular cancer patients. We don't go ahead unless we have risk stratified these patients. And in a more contemporary series with the more stringent use of guidelines and the way these patients should be treated, there has been an update of what these risk stratifications, whether they are valid today also or no, and what are the contemporary outcomes. And it was found that in the non-seminomatous germ cell tumors, the outcomes are actually better in the more contemporary series, particularly in the poor risk patients. Also in the seminoma patients, the outcomes have been found better in both the groups. Additionally, a cutoff of LDH less or more than 2.5 times of the upper limit has been found to be a reasonably strong predictor, prognostic predictor in seminomas. So this is a request and a reminder, and that the IGCCG risk calculator is available online, and it is now available with a nomogram where for an individual patient one can actually risk or better prognosticate these patients, and one must use this risk calculator in the clinic. Biomarkers in oncology are a very, very integral part of all cancers, and at all stages, prognostication and treatment decisions, and further, and in testicular tumors also they're important. Now, if one had to talk about an ideal biomarkers, there have been certain criteria which has been suggested. These markers should be exclusively produced by the malignancy, should be secreted into body fluids, the measurement should be reproducible, the levels in body fluid should correlate with the actual tumor amount. The marker should be detectable in early stage disease. The marker should correlate with treatment response and should preferably have a short half-life. Now, if you look at testicular cancer, probably this biomarker, which is miRNA, has hit the jackpot when it comes to all these criteria. And within the miRNA also, there is a cluster which is called the 371 to 373 cluster, and that seems to be having the most promising results. So, I mean, there's actually quite a few mRNAs which have been looked, but this particular one, the 371 to 3 cluster, is the one which has been found to be the best so far. Now, mRNAs in germ cell tumor has been used for to help in the initial diagnosis, for monitoring and adjuvant treatment, for diagnosis of relapse, for management of non-specific radiological changes where we are not certain based on the radiological findings what's happening, for the management of post-chemotherapy residual masses, and also in monitoring response to chemotherapy. The same cluster has actually, this is one of the most cited paper of the same cluster. And what they found is that this particular biomarker, the miRNA 371 to 3, is certainly far better than the existing biomarkers, that is alpha-fetoprotein and beta-HCG, which we're using in terms of their sensitivities and specificities. It kind of fulfills many of those criteria. So, this cluster has been found to be biologically specific for germ cell tumors. The marker expression has been well correlated with the clinical stage. The mRNA levels have been, so in a clinical stage 1 disease, once an orchidectomy has been done, the marker actually drops down within the first 24 hours. So it really has a good shot, the desired kind of a half-life. Also with metastasis post-chemotherapy, it drops down. And a failure of therapy is something which it can kind of indicate at. It's got a negative predictive value of 75% and a positive predictive value of 100% when it comes to predicting the final histopathology in patients undergoing primary RPLNDs for seminoma as well as for NSCCD. Now, if we had to add on some numbers or some conclusions to the things that I showed earlier, then in terms of the initial diagnosis, the numbers are pretty good. So we are talking about numbers upward of 90% sensitivity, specificity, and positive predictive value. For relapse, the numbers are even better. So we're talking about negative predictive value of 98% in terms of predicting relapse using this biomarker. For adjuvant therapy, the role has been less clear. It has not been very accurately predictive. Management of non-specific radiological changes also, there's potentially a role, but we are yet to establish it. For post-chemotherapy residual masses, it seems to be doing really good. So it can kind of a very good negative predictive value. So it can kind of really accurately predict if a viable cancer is present or no. However, with teratoma, the differentiation is difficult, so whether it's teratoma or no is something which is, the numbers are not very good. Now, for the subsequent slides, I would like to, really acknowledge and thank Dr. Aditya Bagrodia, who also happens to be a good friend now, and who has spent many years, particularly researching this particular biomarker, the mRNA. And he was kind enough to share things which I was not aware of, the ongoing trials and things which are likely to happen, in terms of research focused at mRNA. So there are two trials which are currently enrolling, the AGCD 1531 and the SOG 1823. And there are two which are in the process of, starting the enrollments soon. The AGCD 1531 is a phase 3 study of active surveillance, in patients, adult as well as pediatric patients with germ cell tumors. And essentially, it's looking at stage 1 germ cell tumor patients and trying to, follow up them through the treatment with the mRNA assay being done at various time points. Whereas the S1823 is a prospective observational cohort study to assess the same mRNA for outcome prediction in patients with newly diagnosed germ cell tumors. This is also including the stage 2A patients in addition to the stage 1, and is again using the mRNA at various points during the diagnostic and the treatment plan. This is something which should start enrolling soon, called the Patriotism, is a phase 2 comparison of standard treatment approaches in operable stage 2 seminoma incorporating the mRNA. So essentially in stage 2 seminoma, stage 2A and 2B, normally we would have these three options, the radiotherapy, the chemotherapy, or primary RPLD. So this is, a non-randomized, this part of the trial is non-randomized. So based on the, the patient, the physician's choice, the patient would be in one of these arms. And after this, the role of the mRNA is being used to see if these patients need to be on surveillance or are later randomized to, if the mRNA is positive, they're randomized to having additional chemotherapy or surveillance. The other trial, which is soon should be starting, is a phase 3 randomized trial of adoptive dose-dense or dose-intense treatment for high-risk germ cell tumors. So, I wouldn't go into the details of the design, but essentially, after an initial first cycle of BEP, the patients are being, classified as favorable, those having a response, and those not having the response as unfavorable. And then later on, they're kind of randomized to high dose chemo versus conventional chemo based on the mRNA findings. The other big concern based on which most of the research is focused now is the concern about the long-term toxicity of chemotherapy and radiotherapy in testicular cancer patients. So whereas we have achieved really good oncological outcomes, cure rates of more than 95%, today the threat of potential late adverse effects is kind of really, really concerning, particularly the risk of second malignancy. So we're wondering if we kind of rejoice too soon with having, very good oncological outcomes in the first 5-10 years. But when these patients were followed up longer for, 20 and 30 years, we realized that, the toxicities were still coming up. And of late, in the last few years, there have been actually quite a few papers, because now that is the time when we have the follow-up of these patients treated with chemotherapy 20 years back and 30 years back, which have actually raised this concern. And these toxicities could range from second cancers to cardiovascular disorders to pulmonary toxicity, fertility-related issues, ototoxicity, neuropathies, and Raynaud's syndrome. There's been actually a platinum study group. So, the initial group led by Larry Einhorn and, many centers which are treating high volumes testicular cancers actually looked at all these patients. And, it was found that, things like neuropathy has been seen in more than 50% of patients, hearing damage in, almost 40% of patients, things like tinnitus, Raynaud's phenomenon have been seen in significant number of patients. They actually, the outcome that they were looking at was the cumulative burden of morbidity, and this cumulative burden of morbidity was as high as 20%. The high or severe, very high burden was seen in almost 20% of patients. And also, it was found that the burden was directly correlated to the use of more cycles of chemotherapy. So the odds of developing this toxicity were more if more cycles of chemotherapy were used. There's another paper which has looked at these long-term toxicities of more than 6,000 patients which have been treated between 1976 and 2006, and with a follow-up of almost 17, 18 years. And what they found is that radiotherapy and chemotherapy were associated with almost 2 times or 2.5 times higher risk of second malignant neoplasm-related mortality compared to the general population. And this risk was again kind of related to the dose of platinum-based chemotherapy which has been received. So this paper actually concluded that platinum-containing chemotherapy is associated with dose-dependent increase in the risk of second neoplasm-related mortality, and that becomes the basis of the research which is going on right now. So this particular trial, which is called the SAC trial, actually tried to de-escalate both the treatment parts. So instead of using a certain dose and cycles of chemotherapy, what they did was that they used just carboplatin instead of BEP, and instead of radiating the entire field or the entire template, they radiated only, the radiation was focused only to the node, so as to kind of reduce the potential long-term toxicity. They could not meet the primary endpoint, but this seems like a strategy which will be explored. Also, there's been attempt to see if the number of cycles of chemotherapy can be tailored based on an interim PET CT. Okay, so this particular study did a PET CT somewhere in the interim and decided whether the further courses or the further cycles of chemotherapy can be tailored based on the response which has been seen in the PET CT, essentially with the idea of reducing the number of cycles. Exercise is being explored. We know that exercise has been, coming up in a big way in all cancers, in testicular cancer survivor patients also, because the spectrum of late toxicities or long-term toxicities is wide, right from cardiometabolic to skeletal muscle system related, nervous system related, psychosocial and others. And probably exercise would be help in many of these patients, and probably would be more relevant in testicular cancer patients considering that most of them are young patients. For the surgeon, something which is a lot of exciting thing happening in terms of revisiting the role of arpilin in seminoma. So generally, amongst those of us who do arpilin, we would be a little skeptical about doing arpilin for seminomas, because most of the times we would do it for the post chemotherapy scenario in which the planes could be really sticky, and we would be worried about major vessel injuries. In seminoma, generally it was radiotherapy or only chemotherapy or primary arpilin which had been used as one of the options. And generally for those with more than 3 centimeter nodal masses, one would start with chemotherapy. But the role of primary arpilin in stage 2 seminoma is being revisited. The rationale is that if the disease is limited to the retroperitoneum, so why not consider providing a cure and also avoiding a systemic therapy? And with that rationale, there have been actually 3 prospective studies which have been recently published in the last few years. One is the PRIME test, the other one is the COTRIMS, and the third one is the SEMS trial, which was published in the JCO. Now, beyond this, just to kind of save some time, actually, I would rather want to discuss the meta-analysis which has been published just in January of 2024. And it has obviously included these 3 studies, the PRIME test, COTRIMS, and SEMS, and additionally has including the other retrospective studies which have been done in the past. Now they've kind of looked at what has happened to the recurrence pattern. So how many of these patients failed in the retroperitoneum? How many of these patients had an recurrence rate overall other than the retroperitoneum? What are the complication rates of seminoma? Because arpilin in seminoma, because the arpilin in seminoma was always in a certain dispute that it has a higher rate of complication. But please understand that that was in context to post chemotherapy arpilin, where things would be tougher. But the realization with these studies was that when you do or attempt an RPLND in a chemo-naive patients, probably the complications are not, not that high, or certainly not, much higher compared to when it is done for non-somatous germ cell tumors. And also because this was being done for early stage seminomas, many of these RPLNDs were done as nerve sparing, and very high rates of antegrade ejaculation, above 90% could have been achieved in these studies. Interestingly, some of the...
Excuse me, Dr. Gagan, can you please wind up because we are very late. There are two more speakers. So you can just take home message regarding it's very nice. We relished the lecture.
So that's the take home. Yeah. So this is the take home, and it's a rather colorful take home with, wishing all of you a happy Holi as well. The first take home is that IGCC is a robust tool for risk assessment and has it as a recent validation, must be used. The second take home is that mRNA-based biomarkers are being extensively evaluated and could potentially govern the risk-based management of testicular germ cell tumors. The third take home is that long-term toxicity of chemo and radiotherapy is concerning. And the fourth take home is the role of surgery and stage 2 seminoma is evolving. And obviously, this is one of the opportunities for SOGO as well to do some collaborative studies here. Thank you.
Well, thank you very much, Dr. Gagan Prakash. We are really enjoyed your lectures and you've given new insights into this subject. And we are looking forward for more robust data. And in the future, we will come back with that. Thank you very much.
Thank you, sir.
So after such a nice presentation by Dr. Gagan Prakash, we come to our next presentation by Dr. James Moeller. He is Chair Emeritus Urology and Chief Interinstitutional Academics and Professor of Oncology at Roswell Park Comprehensive Cancer Center and Adjunct Professor of Urology and member of UNC Lennenberger Comprehensive Cancer Center at University of North Carolina. He is the chair of NCCN Prostate Cancer Treatment Panel from 2005 to 20 and a member of NCCN Prostate Cancer Early Detection Panel from 3 to 20. He earned his medical degree from Medical College of Georgia and completed residency training in surgery and urology at University of Kentucky Medical Center. He has received a lot of awards like Thomas Thomsey Hope Award, Society of Urology Research, Distinguished Service Award, and a lot more. He has authored and co-authored 334 publications and 20 book chapters. So he's a well-known academician. We'll invite you for your talk on the backdoor pathway for intracrine androgen metabolism, new targets for treatment directed against androgen receptor action, to Dr. James Moeller. Thank you.
Could you run the slides, please? Because I found that when our institute tries to use Zoom, there's all kinds of problems.
Okay,
rather
so
than me
we'll
sharing
do it for you,
screen.
sir.
With that nice introduction, we can just skip through the first couple. And I don't have any conflicts of interest other than the new novel agent I'll approach is protected by 4 patents.
I think we don't have your slides, sir. You're not able to play from your side?
I sent them like 10 days ago, so I'm not sure why you don't have them, but I'll try to find them here.
Extra.
Maybe you can say without slides, you can give us some message. There are no
Did you
slides.
find your slides, sir? You can resend to us, sir, by mail.
You want to do the next speaker and come back to me?
Yeah, that would be fine, sir, with your permission. Thank you so much, sir. We will move on to our next speaker. Till then,
Next speaker.
okay. So we are waiting for you. The next speaker is not here. In fact, your talk is the last one. So,
All right, well, hold on here. I'll find it.
please, sir.
Okay, here it is. Okay, now if we can just share screen. So okay, do you see my talk?
No, sir, we can't see your screen. We are only seeing your face right now.
Okay.
You speak from the slide as well. You can talk. You have read out from your slide.
You can mail us or you can just present.
You may read from your slide and we will listen to you. Just give us. Yeah. Oh, he has a slide with him.
I will email it to you. Okay, here it is. Okay, do you have it?
Yes, we are checking, sir.
Okay.
We'll just play in 2 minutes. Yes, we have received your mail.
It's the same. I replied to the email where you sent me the link a few minutes ago. Okay, I'm trying to share my screen. Do you see my screen now?
Not yet, sir.
This is why you need to run the slide, because I'm sharing my screen, but you don't see it. And that's the problem with the interaction between Roswell and Zoom. Roswell does not support Zoom.
We are trying from our side, sir. Play your slides.
Okay. Do you see my slot? Do you see my screen now?
Yes, it's a blue screen. Is it yours?
Okay.
Yeah, now we are able to see.
Success?
Yeah, success.
Okay. So you said all this, and I mentioned my disclosures. So we're going to talk about a different way of looking at advanced prostate cancer. And I'm going to try and teach you all 4 very quick things that we'll review at the end. But when I began my career at Johns Hopkins, this is a slide from Johns Hopkins from John Isaacs. And the view of the world in 1987 was that androgen-dependent cancers responded to castration and went away and had prolonged remissions. And when they didn't, it was because they were androgen independent from the beginning. And this was the accepted dogma, so that your response to hormone therapy was entirely dependent on the composition of your tumor. And so when I arrived at UNC in 1987, the group at UNC, Frank French and Betty Wilson, had just reported the sequence for the androgen receptor and had created an antibody that worked only in frozen tissue. And so my job as a translational scientist was to figure out if that androgen receptor was playing a role in why cells were either pink or blue, androgen responsive or not. And the startling finding was that castration recurrent prostate cancer that existed in the presence of surgical castration had more androgen receptor than did androgen stimulated benign prostate. And it was thought at the time that the cancer that came back after castration would lack androgen receptor. So this was very disruptive to the field. And so our group embarked on trying to figure out why the androgen receptor was expressed at such high levels in the presence of no testosterone. And so we spent a lot of time figuring out how the androgen receptor could be hypersensitized by molecular alterations, and published a whole bunch of stuff that turns out to be completely not the reason for the biology. And so the second unexpected finding we had was I, as a naive urologist, said, well, how do we know that there really is no testosterone in the prostate or its cancer? And we set about trying to measure this first by radioimmunoassay. Our group did the assays for the US Olympic Committee, but this was done in saliva or blood. And so we spent about 3 years perfecting a methodology that worked in tissue. And in the second column there, you see that the levels of testosterone in benign prostate and castration recurrent prostate cancer were basically the same. Now, the difference is in castration recurrent prostate cancer, the testosterone is not metabolized to DHT because there's something wrong with its 5-alpha reductase capability. And so we were told by various people that we were wrong. And simultaneously, I've been working with a group at NIEHS that measured androgens in river water, trying to explain why all the fish were becoming girls. And we adapted that assay for marine estrogen for testosterone and DHT, and we got the exact same findings as we got by radioimmunoassay. And now on the right-hand side of the slide are all the castration recurrent prostate cancers that we published in our first two papers. And you can see that only one of them had no measurable testosterone or DHT. We've now made these measurements in about 60 cases, and this remains the only one. And that tissue was probably degraded. So in essence, we do not have any such thing as an androgen-independent cancer. These cancers have all figured out how to make testicular androgens at the tissue level. Now, did we find something new? No, others had reported this, but it was dismissed like our initial work was as being basically unbelievable. And so what we had to do was learn how this was happening. And this is a picture from Streyer's textbook of biochemistry that I've adapted. And I can't remember names, so I do things by colors. And you can figure out that you only need 3 enzymes to convert a weak adrenal androgen into DHT. So we set about trying to understand this better. But as everything that looks simple generally proves to be, things are a lot more complicated, and this would be a modern drawing of the pathways to the production of DHT by tissue. And you can see that it's quite complicated. Critical to this is the enzyme CYP1, which is the target for abiraterone acetate. So from our work, targeting this enzyme was a big breakthrough by the group in England, and there have been several papers published on abiraterone and its progenitors that is now an accepted treatment for advanced prostate cancer, but it does a very poor job of extending survival. So it's our point that we need to do better. Now, why does it work so poorly? Our group and others have published a whole bunch of reasons why abiraterone fails rapidly. And so we set about to do a better job of blocking the backdoor production of DHT. So what we wanted to do was focus on the bottom right-hand corner. And it was thought at the time that a single enzyme was the last step in the conversion of androstenediol to DHT. And it turns out that that too is not true. It's actually a family of enzymes. But what's interesting is the ability to convert the weak adrenal androgen metabolite, androstenediol, to DHT is a unique property of prostate tissue. It cannot be done by any other tissue or any other cell line derived from cancers of other tissues. So this is a very worthwhile target. So does it make sense in vivo? Well, we took mice that were bearing tumors that were castration resistant and injected those tumors with androstenediol. And you can see that their ability to produce DHT at the tissue level was many-fold greater if they had androstenediol as substrate. So we've set about trying to block this enzyme. Now, I told you it's not just RDH5, one enzyme that does this, but it's actually a family of 5 enzymes. And 4 of them are found in prostate tissue, 1 is not. So then if there's 4 enzymes, there's no way you could develop a drug, except we demonstrated that, I'm going to skip through this. We demonstrated that this family of 4 enzymes in the red, when you look at the structure of the enzymes, their catalytic domain shares a common amino acid residue, so that it is possible to target this residue and, in theory, block all 4 enzymes and make a better abiraterone. And so we went about mutating each of these enzyme catalytic sites to prove our hypothesis. And to make a long story short, we did exactly that. You could demonstrate in cells growing in culture that mutating these enzymes decreased the ability of these cell lines to produce DHT. And this was enhanced if you also blocked 5-alpha reductase. So furthermore, one member of the family of 4 was the dominant 5-alpha reductase. 3-alpha oxidoreductase. So it looked like this represented a reasonable target. So we wanted to then develop a high throughput screen to inhibit the action of dial-17C. And we showed that dial-17C could co-localize with this 3-alpha oxidoreductase. The reason we made dial-17C, the C is coumarin, is because coumarin fluoresces, and we needed to be able to see it. And we had an unexpected finding here in that, I'll skip through this, that in the interest of time, the unexpected finding was that the cells died when we were treating them with dial-17C. And to make a long story short, it turns out that dial-17C that we were developing as a fluorescent assay to test for drugs that would inhibit this enzyme pathway was actually inhibiting the enzyme and being metabolized, converted by the enzymes to DHT that was labeled with coumarin. And that this DHT-17C, when it entered the nucleus, unexpectedly caused the death of all our cells, cell lines, including those that made high levels of ARB7. So what we're doing now is trying to find a derivative of our fluorescent marker developed to test for drugs that actually proves to be a drug itself, and we're trying to improve its pharmacologic properties. And we're using the exact same assay that we used, that we thought we were going to use to screen for inhibitors of the enzyme family to find better compounds. Now, why is this important? If you take all the new agents for advanced prostate cancer that have been approved by the FDA, and one patient could tolerate all of them, they would spend about $1 million for their drugs, and their added survival would be at most 2 years. So there's a real need here to do a better job. So what I've told you in brief is that the best term for recurrent prostate cancer, the medical oncologists say it's castration-resistant prostate cancer, but we urologists know that it's castration recurrent because we see the patients, we send the patients on to medical oncology once the cancer's already recurred. So it's not resistant, it's recurrent. How does prostate cancer escape ADT? Well, I showed you very complicated slides that indicated that the cancer itself can produce its own DHT, probably from weak adrenal androgens. And that is something we need to prevent. How does it do that? There's 3 pathways, a front door, a back door, and if you block both of them effectively, then you can make DHT not from weak adrenal androgens, but the cancer can make it directly from cholesterol and probably from the cholesterol that exists in the cell membranes in lipid rafts. And so I've shown you a novel approach to developing a drug for advanced prostate cancer that's based on new knowledge that has been acquired over the 40 years of my career. And my assistants in this are in yellow, Mike Fiandello, my postdoc, and then faculty member, David Watt, the chemist. Here's Mike at the SBUR. David Watt, now retired, who was the chemist at the beginning of all this work. And then I would have just discarded all this work if not for what Don Coffey taught me at Johns Hopkins, and that is when you have an unexpected finding, don't discard it, pursue it. And that's how all this came about. Thank you, and I'm sorry for the technical problems. That's one of the unintended consequences of COVID.
Thank you so much, sir, for your enlightening presentation. I mean, very basic, very new to us, all except this thing. Thank you so much, sir.
Welcome.
He's not leaving me. So thank you all. So it was very tiring actually. There are some hard learned lesson also for this meeting. We will discuss later on. Okay, sir. Thank you. Sir, thank you, sir. Thanks for actually joining the meeting. And we really, I think everyone appreciated your talk. It was very delighted, everyone delighted to just hear you, enlightened.
Okay, thank you, and have a good dinner.
Yeah, sure, sir.